ये एक मिनट दिखा दो, टैप कहाँ से, टैप घुमाते जाओ, घुमाते जाओ। तो जो ऊपर कैलकुलेट कर दो, दिखा दो, पहले दिखा दो ना जो कैप है। सो प्लीज pardon us if we are sounding very basic, but we are assuming कि आपने कभी पीडी देखा ही है। So let's start from there, right? So दूर से नजर आ जाएगा 4.25 वाला लाल होता है, वो तो लाल वैसे बताया उन्होंने कि भाई ध्यान से यूज करो। और जो आइकोडेक्स्ट्रिन है इसका भी हरा होता है, लेकिन ये कैच है, ध्यान से देखो, आइकोडेक्स्ट्रिन दूर से पहचान लेता है, हरा होता है, लेकिन जो उसका कनेक्शन वाला है वो नीला है। आपने देखा, जो आपने इस वाले हरे को देखो जरा ध्यान से, ये हरे वाले के साथ जो अटैचमेंट है वो वाइट है, वाइट के साथ है ना, जो हरा कहाँ लगा हुआ है, वाइट के ऊपर लगा हुआ है, वाइट के ऊपर लगा हुआ है। जो आइकोडेक्स्ट्रिन है वो जो हरा है वो नीले के ऊपर लगा हुआ है, इसलिए दूर से पहचान सकते हो, ठीक है। नाउ फाइनली क्विकली हम ये करके बाकी सारी चीज़ें हम सीखेंगे। So before you are exposed to the relatively higher level of what the speakers are going to talk about, you will take advantage कि आपको थोड़ी सी nitty-gritty पता है। So हमें पता लग गया 1.5 का मतलब है मीठा, कम मीठा, 2.5 का मतलब है ज़्यादा मीठा, 4.25 का मतलब है, ना प्लीज लिसन टू मी, 1.5 का मतलब है कम मीठा, 2.5 का मतलब है ज़्यादा मीठा, 4.25 का मतलब है बहुत मीठा। चाशनी, और चाशनी के क्यों मैं बार बार एग्जाम्पल देता हूँ, चाशनी जो जलेबी वाली होती है जैसे उसके ऊपर रखोगे सारा पानी सक कर लेती है अपने, इतना ज़्यादा उसमें पानी एब्जॉर्बिंग कैपेसिटी है, राइट। 7.5 इज आइकोडेक्स्ट्रिन, बट प्लीज़ 7.5 का मतलब ये नहीं है उसमें मीठा नहीं है। सो रिमेंबर it is a different molecule altogether. So इससे we'll come to that. 1.5 से कम की, अच्छा okay, I'll give you 2 rules of PD which you must remember by heart, and this will help you in PD prescription. 2 rules हैं PD के. Higher the concentration, more will come out. Obviously 1.5 यूज करोगे, 2 लीटर डाला, 2 लीटर है। 2.5% यूज करोगे, 2 लीटर डाला, 250 है। 4.25 डालोगे, 2 लीटर डाला, 25 है। So higher the concentration, more will come out. Secondly, shorter the time, more will come out. 8 बजे डाला, 10 बजे खाली किया, ज़्यादा निकला, सेम बैग, चाहे वो 1.5 डाला, 2.5 डाला, उसी 8 बजे डाल के 10 बजे खाली किया, ज़्यादा निकला, 12 बजे खाली किया, थोड़ा सा कम निकला, 2 बजे किया और कम निकला, 4 बजे वापस चला गया। इट मीन 2 लीटर डाला, 2 घंटे के बाद 250 आया, 4 घंटे के बाद 2200 आया, 6 घंटे के बाद 2 लीटर आया, 8 घंटे के बाद 1950 आया, रात भूल गए कहीं गलती से 2 लीटर से 1612। क्लियर होगी बात। तो ये 2 रूल से सारी प्रिस्क्रिप्शन दुनिया जीत लोगे, ये 2 रूल से। तीसरा रूल है कि हर एक बंदे की मेम्ब्रेन अपनी है, वो तो अपनी है, उसको आप चेंज नहीं कर सकते। तो जो जिससे पैदा हुआ है वो हुआ है, उसको थोड़ा बहुत हम कर सकते हैं, वो ट्रीट करेंगे, बात करेंगे उसके बाद। नाउ कोवर विल टेल यू अबाउट दी कनेक्शन। कनेक्शन इसका दिखा रहे हैं, ये टॉक्सिक जो है पहले यार कनेक्शन सिखा रहे हैं कैसे। तो सबसे पहले सर्जन आ गए या नेफ्रोलॉजिस्ट को जाने, आपके पास एक कैथेटर टैंक ऑफ होगा, ठीक है, वो अंदर से स्ट्रेट हो सकता है, ठीक है, वो सामने को हो सकता है, कॉइल हो सकता है। हर एक अपने अपने फायदे हैं, सर्जन की रेफरेंस है। कॉइल का मतलब आप सीधा चढ़ा के उसको बोला है, कुत्ते की पूंछ होती है ना, सीधी नहीं होती है, आपने थोड़ा देर के लिए उसको पकड़ के रख लिया, अंदर जाके जैसे ही छोड़ा तो घूम गई। तो घूम इसलिए गई क्योंकि आप मोमेंटम को अवॉइड करना चाहते हैं। तो कई लोग वो प्रेफर करते हैं, स्ट्रेट सेट में मोमेंटम फंस जाता है, स्वेल नेक की अपनी प्रॉब्लम है। तो ये सारी चीज़ें जो आप थ्योरी में फिर पढ़ोगे, बट इतना है सर्जन ने या नेफ्रोलॉजिस्ट ने जिसने भी डाला उसने आपको एक कैथेटर डाल के दे दिया बाहर, उसके आगे से ओवर इसको बोलते हैं ट्रांसफ्यूजन। अब ये सीख लो क्योंकि ये आपको आनी ही चाहिए और आपको खुद हाथ से करनी चाहिए। प्लीज डू।
थैंक यू वेरी मच। गुड मॉर्निंग एवरीवन, माय नेम इज प्रताप सिंह। तो मैं जस्ट क्विकली आपको बताऊंगा कि कैसे हम कनेक्शन है वो कैसे किस तरीके से। तो जैसे कि आप सब लोगों को पता है, सर ने बताया कि CAPD कैथेटर एक बार इंसर्ट हो गया। कैथेटर जो इंसर्ट है वो आज की डेट में बहुत सारे नेफ्रोलॉजिस्ट एज वेल एज यूरोलॉजिस्ट जो है वो करते हैं एंड टाइप जो है वो भी सर ने बताया कि हमारे पास स्ट्रेट, क्वाड, श्वेन नेक, ये 3 7 4 तरीके के कैसेट हैं जो नॉर्मली हम अभी यूज़ कर रहे हैं।
रिकॉर्ड भी हो रहा है। अच्छा, ओके।
तो आफ्टर कैसेटराइजेशन, तो आप सभी लोगों को पता है कि कैसेटर डलने के बाद तो नॉर्मली एक पिकिंग टाइम होता है। नॉर्मली अगर मैं बात करता हूँ तो 2 वीक का हो सकता है। तो लेकिन 2 वीक के इन बिटवीन 2 वीक्स वी हैव टू डू फ्लैशिंग। तो फ्लैशिंग बेसिकली हम करते हैं ताकि जो पेशेंट का इनफ्लो आउटफ्लो में चलेगा तो इसमें वॉश होकर बाहर आ जाएगा। पर्पज़ हमारा ये है कि कैथेटर का इनफ्लो आउटफ्लो हमारे पास रेगुलर पता होना चाहिए कि वो ठीक से आ रहा है। तो आफ्टर 3 to 4 फ्लैशिंग और जो भी रिकमेंडेशन गाइडलाइंस है, उसके बाद आफ्टर 2 वीक वी विल स्टार्ट विद पेरिटोनियल डायलिसिस, पूरा कोलेटर के साथ में स्टार्ट करेंगे। तो सबसे पहले जब भी हम, अब मैं आपको बताने के लिए जा रहा हूँ जो हम पेशेंट को एक्सपीरियंस है। तो नॉर्मली वी डू 5 days ट्रेनिंग एट हॉस्पिटल पेशेंट उसको 5 दिन के अंदर हम पूरी तरीके से एक्सपर्ट कर देते हैं कि घर पर जाकर वो डायलिसिस करता रहेगा। और जैसे सर ने बताया वी हैव ऑलमोस्ट इंडिया के अंदर करीबन 4500 के आसपास पेशेंट हैं एंड आउट ऑफ 4500 पेशेंट मोस्ट प्रॉब्ली अराउंड 30% पेशेंट हैं जो 10 साल से ज़्यादा से डायलिसिस हैं एंड वो रेगुलरली, अगर पेशेंट अच्छे से करेगा कभी वो इन्फेक्शन। सो अगर इसके लिए सबसे पहले क्या करना होता है, हम पेशेंट को एजुकेट करते हैं कि जब भी इसमें कहीं पर भी बहुत सारे मिथ हैं कि जो पेशेंट, जिस पेशेंट के घर पर एक रूम है या तो उनको वो पीटी नहीं कर सकते या उनको साफ सफाई इन्फेक्शन होने का चांस है। इन्फेक्शन कभी भी हो सकता है, लेकिन अगर हम सही तरीके से स्टेप फॉलो करेंगे तो हम कहीं ना कहीं इन्फेक्शन को रिड्यूस कर सकते हैं। फर्स्ट स्टेप हमारा है रूम प्रिपरेशन। तो जब भी अगर पेशेंट के घर उसी रूम में रहते हैं, रूम प्रिपरेशन के लिए हमें देखना है कि जब भी पेशेंट डायलिसिस करेगा, डायलिसिस के लिए जो प्रिस्क्रिप्शन होती है वो बेसिकली थ्राइस अ डे होती है, 3 बार हमें करना है। नॉर्मल जनरल प्रिस्क्रिप्शन की मैं बात कर रहा हूँ, तो हर 6 to 8 आवर्स जनरल प्रिस्क्रिप्शन है और ये डिपेंड करता है अगेन पेशेंट की कैटेगरी। बड़ा भी रूम है, रूम के अंदर नॉर्मली साफ़ सुथरा होना चाहिए, खिड़की दरवाजे जो है वो बंद हो जाने चाहिए और उसको ऐसी चीज़ें होनी चाहिए जिसको हम ईजिली साफ़ कर सकें। डस्ट नहीं रुकनी चाहिए और एयर वेंटिलेशन बेसिकली जो एयर फ्लो है वो मेंटेन रहना चाहिए। अगर वो एयर मूवमेंट होगा तो थोड़ा कंटामिनेट होने के चांसेस हो सकते हैं। तो वो फर्स्ट स्टेप है रूम प्रिपरेशन। सेकेंड स्टेप है हमारा टेबल प्रिपरेशन। तो उसके लिए हमें कोई स्ट्राइड नहीं करना, सिर्फ एक इतनी बड़ी टेबल हमें चाहिए, एक कोने में, यहाँ पर एक कोने में रख के उसको स्पीड एंड कॉटन से हमें टेबल को क्लीन करना है। एंड उसके बाद जो भी हमें CAPD करने के, अभी हम सिर्फ CAPD की बात कर रहे हैं। CAPD करने के लिए हमें सिर्फ 3 चीज़ों की जरूरत है। एक है हमारे पास बैग, दूसरा है मिनी कैप, तीसरा है क्लैप। इसके अलावा जो एसेसरीज है लाइक हमें जो अपना आपका स्प्रिट हो गई, कॉटन हो गया, ये सारा सामान हमें रखना है। और ड्रेसिंग अगर हम बाद में करें तो ड्रेसिंग का सामान अलग से रखें। तो अभी हम एक्सचेंज प्रोसीजर के लिए बात करें तो सबसे पहले हमने स्प्रिट एंड कॉटन से साफ करा, उसके बाद बैग को हमने चेक कर लिया। मास्क लगाना है, मास्क इसके लिए पूरा मैंडेटरी है कि पेशेंट और पेशेंट केयर गिवर, अगर पेशेंट खुद कर रहे हैं तो खुद भी मास्क लगाना है, अगर केयर गिवर भी कर रहे हैं तो पेशेंट और केयर गिवर दोनों को मास्क लगाना है। मास्क लगाने के बाद उसको सिंपल हैंड वॉश करने हैं, हाथ धोने के बाद हाथ को अच्छे से सुखाना है एंड देन उसके बाद में बैग, मिनी कैप, बीटाडीन, स्प्रिट एंड जो भी हमारे पास सर्जिकल सीट है वो हम एक साइड में रखते हैं। उसके बाद जो हमने टेबल क्लीन करी है, टेबल क्लीन करके बैग को अच्छे से चेक करें। अगर आप इसके अंदर बैग को चेक करेंगे तो जैसे कि डॉक्टर साहब ने बताया है कि इसके अंदर सबसे बड़ा है कॉन्सेंट्रेशन। कौन सी कॉन्सेंट्रेशन यूज़ करें, क्या प्रिस्क्रिप्शन, क्योंकि पेशेंट जो है हमारे पास नॉर्मली वो इस तरह के पेशेंट होते हैं, कभी कभी तो ये हमारे पास पेशेंट की डमी है। तो ये डमी है, हमने पेशेंट को मास्क लगा लिया, 6 स्टेप हैंड वॉश करें। हैंड वॉश करने के बाद आपको मैं वहाँ हो, तो जब भी हमें देखना है तो बैग को अच्छे से, बैग को IV स्टैंड पर हैंग करा, उसके बाद इसको ट्यूब को अनरोल करा। अनरोल करने के बाद आपका जो कनेक्शन करने का तरीका है वो ये होना चाहिए। इस तरीके से हमें इसको पकड़ना और ऑलवेज ये जो है ना पुल नहीं होना चाहिए। इसको हमें इस तरीके से थोड़ा सा बैंड हो ये खींचते हैं और आप इसको निकालो और ये सीधा इसके साथ। जब भी हम करेक्शन करें ध्यान रखना चाहिए कि जो हमें ट्रांसफर साइड को मूव नहीं करना, हमें जो है सिर्फ जो बैक का कनेक्टिंग पॉइंट है वाई जंक्शन इसको हमें रोटेट करना। सो दैट इज मेन। और इसमें जितना टाइम कम लगे उतना ही पेशेंट को इन्फेक्शन कब हो सकता है? पेशेंट को इन्फेक्शन तभी होगा जब हम इसको कनेक्शन और डिस्कनेक्शन करें। ये हमारा सिर्फ कुछ सेकंड, मैक्सिमम 3 to 5 सेकंड का है। अगर एक बार हम अच्छे से पेशेंट को एजुकेट कर देते हैं कनेक्शन कैसे करना है, मास्क पहना हुआ है, 6 स्टेप हैंड वॉश करें, हाथ को अच्छे से धुआ हुआ है, उसके बाद हमने ट्रांसफर सेट को निकाल के क्रीम जो हमारे पास सर्जिकल सीट है जो हम पेशेंट को बताते हैं कि स्टाइल कैसे करना है, उसको बिछाने के बाद इसको ट्रांसफर सेट को हाइजीन तरीके से इसको डाउन, और हमेशा जो ट्रांसफर सेट का मुँह जो हमारे इसको ये डाउनवर्ड्स रखना है। इसको हमारे पास ये इस तरीके से बैक का कनेक्शन होगा, ये हमने डाउन करा, रिमूव किया, लिंक है और ये इस तरीके से। मेरा हाथ आप देखिए, हाथ जो है बिल्कुल फिक्स है, ट्रांसफर साइड मूव नहीं होगा। अगर हम ट्रांसफर साइड को घुमाएंगे एक्सिट पॉइंट पे हम होने के चांसेस, ठीक है, अंडरस्टूड। तो इसके अलावा अगर आपको एक चीज़ का और भी ध्यान रखना है कि कहीं ना कहीं अगर हमारे पास पेशेंट है, पेशेंट के केयर गिवर जो है वो बार बार चेंज हुआ है, क्योंकि अगर लॉन्ग टर्म पीडी की बात करेंगे तो क्या होता है, अगर जो पेशेंट अभी मैं देखूँ हमारे पास पर्टिकुलर बहुत सारे पेशेंट हैं जो खुद डायलिसिस करते हैं एंड उनके आउटकम सबसे बड़े, तो इसलिए कुछ पेशेंट ऐसे हैं जो कर सकते हैं लेकिन वो करना नहीं चाहते। तो हमें इंश्योर करना है कि जो पेशेंट भी डायलिसिस अगर वो खुद कर सकते हैं तो बेस्ट है, बिकॉज अदरवाइज केयर गिवर क्या है ना फ्रिक्वेंटली चेंज होते हैं। आज उनका लड़का कर रहा है, उसकी जॉब लग गई, वो बाहर चले गए, फिर लड़की नहीं करना शुरू कर, लड़की की शादी होगी, वो बाहर चली गई। तो अब जो नए बंदे सीखेंगे शायद वो इतने अच्छे से नहीं सीख पाए, तो कहीं गलती होने के चांसेस हैं। तो ये है हमारा कनेक्शन करना। इसके बाद एग्जिट साइड ड्रेसिंग करनी है। एग्जिट पॉइंट जो होता है जहाँ से कैथेटर निकला होता है, तो ये इंश्योर करना है कि आफ्टर बाथ, नहाने के बाद, नहाते टाइम आप इसकी जो ड्रेसिंग है वो पूरी हटा सकते हैं। इसको हम कैसे बोलते हैं, इसको इस तरीके से शीशे बना के एक छोटा माइक्रो टेप लगा कर रखते हैं एंड वो आराम से सोप एंड वाटर से आफ्टर 4 to 6 वीक, 6 वीक के बाद में जो एग्जिट पॉइंट है वो हेल्दी हो जाती है एंड इफ एग्जिट साइड इज हेल्दी देन उसको कोई भी नहाने के लिए कुछ नहा सकता है, सोप एंड वाटर से क्लियर कर सकता है। लेकिन इमीडिएटली जैसे ही वो नहाने के बाद बाहर आएंगे तो सबसे पहले एग्जिट साइड ड्रेसिंग, एक्सरसाइज ड्रेसिंग करने के लिए बीटाडीन, सिंपल नॉर्मल बीटाडीन यूज़ करनी है। बीटाडीन के 6 गॉज हम बीटाडीन यूज़ करते हैं। फर्स्ट 3 गॉज से बीटाडीन से साफ करेंगे अंदर से बाहर की तरफ एंड उसके बाद में 2 गॉज से इसको ड्राई कर देंगे अच्छे से। इसको हम बीटाडीन यहाँ लगे नहीं होना चाहिए एंड उसके बाद में इन कुछ डॉक्टर्स हैं जो रिकमेंड करते हैं कुछ लोकेशन ऑर्नमेंट वगैरह इन केस अगर कोई पेशेंट को इन्फेक्शन है या कभी कभी नॉर्मल प्रिकॉशन यूज़ कर देते हैं। अदरवाइज अगर कुछ भी नहीं है तो आपको सिंपल इसको ड्राई करने के बाद एक गॉज रखें, गॉज रखने के बाद इसको आप माइक्रोटेप से कम्प्लीटली कवर करें। सो 24 आवर्स में एक बार आफ्टर बाथ ड्रेसिंग करना कंपल्सरी है। अगर एग्जिट साइड हेल्दी है और इसके बाद अगर आप यहाँ से देखोगे जो टनल बनती है, तो जब भी हम एग्जिट साइड ड्रेसिंग करते हैं तो वी हैव टू चेक कि यहाँ पल्पिटेशन आपको दबा कर चेक करना है उसको कि कोई पेशेंट को टनल इन्फेक्शन एग्जिट पॉइंट से कभी कभी क्या होता है, अगर पुशिंग हो रही है, हल्का बहुत रेडिश हो रखी है, या फिर इसकी स्वेलिंग हो रखी है, तो इन दैट केस आपको ध्यान रखना है कि उसको सही तरीके का चेक कर लें। अगर कुछ भी पेन होगा तो उसको एक बार स्कैन करेंगे। सो दिस इज़ ऑल अबाउट CAPD। CAPD के लिए किसी मशीन की ज़रूरत नहीं है, सिर्फ कनेक्शन करना है, डिस्कनेक्शन सही तरीके से करना है एंड एज पर डॉक्टर प्रिस्क्रिप्शन आपको पेरिटोनियम में है वो फ्लूइड जो पेरिटोनियम के अंदर एंड आफ्टर फ्यू आवर्स रेनल। तो ये हमारे पास में बैग है। इस बैग को आप जब ये बैग है इस बैग के ऊपर हमेशा कट का निशान रखो। तो जब भी अब जो पूरा प्रोसेस है इसलिए हमें थोड़ा जल्दी करना है। अदरवाइज हम जो हमारी जो टेबल होगी जिसको हम स्प्रे एंड कॉटन से साफ कर रहे हैं, मास्क लगाने के बाद प्रॉपर 6 स्टेप हैंड वॉशिंग करने के बाद हम इस अंदर वाले आप जैसे इसको एक बार अगर देखो ना ये आप देखिए, अगर मैं इस पर लगाता हूँ इसमें तो कभी भी ब्लेड या सीजर यूज़ नहीं करते। तो इसको आप ये अगर आप नीचे रखे तो ये आराम से खुल जाएगा। और इसको खोलने के बाद आप इसको जो हमने टेबल स्पीड एंड कॉटन साफ करते हैं उसको आप इंसाइड रखें। ये भी बिल्कुल एक लेयर में पड़ेगा, जैसे ये है ये पूरा। और उसके बाद 6 स्टेप हैंड वॉश करने के लिए जाना। आफ्टर 6 स्टेप हैंड वॉश आपको तो सिर्फ अंदर वाले बैग को ही टच करना है, बाहर वाले बैग को टच नहीं करना। जो हमारी इसको आप निकालने के बाद आप देखेंगे अब दोनों कॉर्नर पकड़ के इसको आप स्टैंड पर हैंग कर हैंग करने के बाद आपको ये ध्यान रखना है कि ये जो पार्ट है इस पार्ट को कहीं पर भी पेशेंट को जब हम एजुकेट करते हैं कि वो बोलते टाइम इसको अपने कपड़े से या किसी और चीज़ से टच न करें। तो दिस इज स्ट्राइक, इसको हमने क्लीन करा। अभी देख रहे हैं इसमें 2 लाइनें हैं और मैं इसको डिटेल में आपसे बताऊँ। दैट इज़ फिल बैग, ये मेडिकेशन बोर्ड है, दैट इज मेडिकेशन बोर्ड। ये फिल लाइन होती है, ये ड्रेन लाइन है, ये ड्रेन लाइन क्लैंप है, दैट इज कॉल्ड ग्रीन फ्रिंजिंग। और ये होती है पुल। तो सबसे पहले मैंने क्या किया, जब भी कनेक्शन करने के लिए जा रहे हैं मैंने फिल लाइन पे क्लैंप लगा दिया। और क्लैंप लगाते टाइम ये ध्यान रखना चाहिए कि ये वाला पार्ट है ऊपर होना चाहिए। इस पर काफ़ी क्वेश्चन तो ये इसलिए होता है ताकि ट्यूब जो है अगर इसको मान लो मैं नीचे की तरफ रखता हूँ और ब्लाइंड नहीं है इस तरीके से आप देखना ये पूरी तरीके से नहीं ऑलवेज ध्यान रखें कि जब भी हम इसको कनेक्शन कर रहे हैं तो इसको ग्रिप मान लीजिए। आने के बाद हमने ग्रीन सील जो है, ग्रीन सील का बेसिक पर्पज है कि जो फ्लूइड है वो बैग से ड्रेन बैग में नहीं जाएगा। तो इसको मैंने सील ब्रेक करी और सील ब्रेक करने के बाद इसको नाउ ये हमारा कनेक्शन करने के लिए सबसे मैंने बताया था यही तरीका है काम में। आपने इसको विंग पे थोड़ा ढीला कर, ये सबसे सेंसिटिव पार्ट है। और ये मेरे तीनों फिंगर उसको बांधना है डाउनवर्ड, इसको ध्यान नहीं रखना। ये कनेक्शन हर एक एक्सचेंज पर हमारे जो मिनी कैप है जो मैंने अभी नीचे दिखाई प्रेस होनी चाहिए। ये मैंने कनेक्शन किया। अब इसके बाद जैसे मैं कुछ किया इसके बीटाडिन सोप। तो कनेक्शन करने के बाद सबसे पहला काम है ड्रेन। तो मैंने जैसे ही मैं ट्विस्ट क्लैंप ओपन करूँगा क्योंकि मैंने फिल लाइन क्लोज किया, क्लैंप क्लोज किया हुआ, ड्रेन लाइन का क्लैंप ओपन है, कनेक्शन किया। कनेक्शन करने के बाद जैसे ही मैंने इसको ड्रेन करा तो पहले
concept is flush before fill. So सबसे important है the difference between the traditional straight set, post set to Y set to this is flush before. This allows you सारा गन इधर निकल जाएगा, right? और जब अंदर से खोलोगे पहले वो बाहर निकलेगा उसमें गन सारा निकलेगा।
सो ड्रेन होने के लिए नॉर्मली 2 लीटर ड्रेन होने के लिए अप्रॉक्सीमेटली जो ड्रेन टाइम है अराउंड 170 to 180 ml पर मिनट के हिसाब से ड्रेन होने के लिए हमारे पास अप्रॉक्सीमेटली 12 से 14 मिनट लगते हैं। बट जो हमारी एक्सपेक्टेशन है या फ्लूइड जो अल्ट्रा फिल्ट्रेशन को मैं ऐड करता हूँ अराउंड 300 to 700 ml एक्स्ट्रा अप्रॉक्सीमेटली ड्रेन फिल का जो कॉन्सेप्ट है। अब हमने ड्रेन लाइन का क्लैंप हमारा पुश क्लैंप बन गया, ड्रेन लाइन का क्लैंप खुला है। अब मैं इस क्लैंप को अगर खोलूँगा देखिए तो ये इसके लिए मुझे सिर्फ 5 सेकंड वेट करना है, 1 2 3 4 5 और इसके बाद मैंने ड्रेन लाइन का क्लैंप। इसके अंदर जो भी एयर से या जो ड्रेन के टाइम पर कुछ भी कंटामिनेट अगर इनकेस हुआ तो सारा ड्रेन बैक ड्रेन होने के बाद अब मैं जैसे ही इसको इस क्लैंप को ओपन करूँगा क्योंकि ये अंदर डमी में वो नहीं है, मैं इसको क्लैंप कर रहा हूँ अंदर। तो जैसे ही मैं अब इसको मैं पुश क्लैंप ओपन करूँगा देन ग्रेविटी फोर्स से फिल होने का सिंपल कंसेप्ट 200 ml पर मिनट, मैक्सिमम 10 मिनट लगते हैं 2 लीटर। टोटल 30 मिनट में पूरा एक एक्शन हमारा जो है कंप्लीट हो जाता है।
थोड़ी सी एयर फिर भी चली जाएगी। आप देखोगे कभी भी पीडी करते हैं एयर में डायफ्राम थोड़ा सा रहता है, अगर जितना मर्जी आप कोशिश कर लो कुछ ना कुछ एयर देख नहीं रही है जरूरी करके ओके, सो यू कैन हैव सम। और 25 मिनट से ज़्यादा ड्रेन करना नहीं, और जो आपने 45 मिनट इज इम्पॉर्टेंट। जब आप इफेक्ट बताया जाएगा इफेक्ट करते हैं देन यू वेट फॉर 25 मिनट्स और ड्रेन।
तो कंप्लीट ट्रेन होने के बाद हमें क्या करना है, दोबारा से अगर उनके मेरे हाथ में टच हुआ है तो दोबारा से हाथ को अच्छे से वॉश करने हैं, वेटिकेट करते हैं या फिर अगर स्टीलिंग वगैरह है वो यूज़ करते हैं। उसके बाद जो फ्रेश मिनीकेयर, ये फ्रेश मिनीकेयर का मेरे पास हर मिनीकेयर का मेरे से मिलता है कि जो मिनीकेयर को यूज़ करते हैं मेरा रेस्पॉन्ड होता है वो देखना बड़ी होती है। और उसके बाद में इसको यहाँ पर मैंने क्लैम्प किया, ऊपर वाली लाइन क्लैम्प करी और इस मिनीकेयर को जो है अब देखिए पहले इसकी एक्सपायरी डेट वगैरह सब चेक करने के बाद इसको मैं इस तरीके से रख देता हूँ, ऐसे ही रख देती हूँ। अब मुझे कभी कभी हाथ में लगाना है इसको मैंने सर इसको ट्रांसफर आई होप कि आपको कनेक्शन कैसे करना है समझ आ रहा है। ट्रांसप्लांट 6 months तक टाइटेनियम डॉक्टर कैसेटर है सो आप देख सकते हो ये हमारा टाइटेनियम है। तो मैं आपको
I think you can assemble around him सभी how to set up the तो इधर देख लो स्टार्ट रॉकेट साइंस कुछ नहीं ऐसे और लगाया होता है वो कुछ नहीं होता एक बार देख लो।
So this is called Infectious. So वैसे हमारे पास मशीन है तो ये जो मशीन है सबसे पहले अगर जब भी हम प्रिस्क्रिप्शन सेट करते हैं तो प्रिस्क्रिप्शन सेट करने की जो भी डॉक्टर्स प्रिस्क्रिप्शन देते हैं प्रिस्क्रिप्शन को हमें एक बार सेट कर देंगे एंड इसके लिए वन टाइम जो भी पेशेंट क्रॉनिक पेशेंट है घर पर ये मशीन ले जाते हैं वो यूज़ करते हैं। तो सबसे पहले जब भी मैं इस मशीन को स्टार्ट करूँगा फर्स्ट टाइम पेशेंट के लिए जाऊँगा तो सबसे पहले आप देखोगे जैसी मशीन ऑन करोगे यहाँ प्रेस होना स्टार्ट है तो मैं प्रिस्क्रिप्शन सेट करूँगा। आपको ऐसा एक बार प्रिस्क्रिप्शन सेट करना प्रेस डाउन है देन मशीन डिस्प्ले चेंज प्रोग्राम। तो इसके अंदर दो तरीके के प्रोग्राम चेंज करने, एक है हमारा जो थेरेपी रिलेटेड है, दूसरा है जो पेशेंट कन्वीनियंस के हिसाब से। तो सबसे पहले मैं थेरेपी की बात करूँगा इसके लिए जैसे अगर मैं ओवरऑल बात करूँ दैट इज गो बटन, स्टॉप बटन, अप एरो, डाउन एरो एंड एंटर। ओके तो चेंज प्रोग्राम देन यू हैव टू प्रेस एंटर थेरेपी। सो वी हैव 4 थेरेपी इन दिस मशीन। फर्स्ट थेरेपी सीसीपीडी ऑफ द कंटीन्यूअस साइकिल पेरिटोनियल डायलिसिस और इंटरमीडिएट पेरिटोनियल डायलिसिस। तो जो एक्यूट पीडी का काम है वो भी इस थेरेपी। इसके अलावा अगर मैं बात करूँ वी हैव टाइडल थेरेपी एंड वी हैव हाई डोसेज हाइब्रिड थेरेपी। तो टाइडल आप सब लोगों को पता है कि एक रिजर्व वॉल्यूम ड्यूरेशन में रहता है। अगर पेशेंट को इनफ्लो आउटफ्लो ऑब्स्ट्रक्शन से आपने देखा होगा कुछ पेशेंट है जिनका पोजिशनल ड्रेन होता है। अगर पोजिशनल ड्रेन हो रहा है तो हमें पता है कि इस 2 लीटर का 1500 ml बहुत ईजिली ड्रेन आउट हो रहा है, लेकिन जो 25% वो ड्रेन होने में बैठना पड़ता है। तो अगर एक बार लगाओगे उससे क्या होगा कि हमें टोटल 75% टाइडल 75% टाइडल में इस टोटल 2 लीटर डालता है तो 1500 ml बाहर आएगा और 1500 ml के अंदर प्लस इसके अंदर एक कैच है। अगर थोड़ा सा ये देख सकते हैं कि ओवरऑल पेशेंट का अल्ट्रा फिल्ट्रेशन कितना जाएगा। तो अगर मैंने सपोज करा कि इसका हमें टारगेट अल्ट्रा फिल्ट्रेशन 1 लीटर तो टोटल नंबर ऑफ साइकिल 5 1 लीटर डिवाइडेड बाय 5 तो टोटल 200 ml पर साइकिल। तो इसके अंदर मैंने टाइडल 5% प्लस अल्ट्रा फिल्ट्रेशन टारगेट सेट किया 1 लीटर तो वो ऑटोमेटिक साइकिल 200। तो हमारा जो ड्रेन होगा वो होगा 1500 ml प्लस 200 1700 एंड फिल होगा 1500। सो दिस इज ऑल अबाउट द कैलकुलेशन ऑफ टाइडल। ठीक है टाइडल समझ में आ गया। तो इसके ये नॉर्मली हम मतलब एक्यूट पीडी करते हैं, स्पेशली इन पीडियाट्रिक, स्पेशली इन जो पेशेंट जिनको थोड़ा जिनका एचपी नहीं होता है। 80 लीटर एक बार, आपको बार बार देखने की जरूरत है। साइकिल के बाद हम अल्ट्रा फिल्ट्रेशन टारगेट चेक कर सकते हैं। इन केस अगर आपको लगता है कि अल्ट्रा फिल्ट्रेशन चेंज करना है तो आपके पास जो बोर्ड अल्ट्रा फिल्ट्रेशन टारगेट था हमारा कितना अचीव हुआ है। इन केस तो दिस इज वेरी फ्रेंडली पेशेंट एंड एक्सिडेंट। तो सबसे पहले मैं सेलेक्ट करी, उसके बाद टोटल वॉल्यूम एट ए टाइम। नॉर्मली जो क्रॉनिक पेशेंट है उनका मैक्सिमम 15 लीटर तक ही होता है मैक्सिमम, वैसे नॉर्मल प्रिस्क्रिप्शन इज 10 लीटर। तो अगर मैं 15 लीटर की भी प्रिस्क्रिप्शन कर रहा हूँ तो आप यहाँ पर 15 कर सकते हो, बट फॉर एक्यूट पर्पज हम इस मशीन को अप टू 80 लीटर तक का प्रोग्राम एक साथ कर सकते हैं। देन वी हैव थेरेपी टाइम, तो अप टू 48 आवर्स तक लगा सकते हैं, बट जो क्रॉनिक पेशेंट है जो घर पर करते हैं वो मैक्सिमम बिटवीन 8 to 12 आवर्स के बीच में मशीन लगाते हैं। इसके बाद फिल वॉल्यूम, पेशेंट फिल वॉल्यूम, ये मशीन है 2 मोड में काम करती है, स्टैंडर्ड मोड एंड लो फिल मोड। तो स्टैंडर्ड मोड अगर मैं यूज़ कर रहा हूँ फॉर एडल्ट पेशेंट तो इसका फिल वॉल्यूम स्टार्ट होता है 100 ml और 100 ml से अप टू 3 लीटर। लेकिन अगर जैसे ही मैं लो फिल मोड में इसको कन्वर्ट करता हूँ तो लो फिल मोड में कन्वर्ट करने के लिए ये प्रोग्राम स्टार्ट हो जाता है 60 ml से एंड अप टू 1 लीटर। इसके बाद लास्ट फिल वॉल्यूम अगेन उन पेशेंटों के लिए हम यूज़ करते हैं जैसे कि आप सबने पढ़ा होगा, अगर पेशेंट की जो पेरिटोनियम कैरेक्टरिस्टिक है वो अगर पेशेंट लो ट्रांसपोर्टर है, यहाँ पर लो एवरेज, हाई एवरेज एंड हाई ट्रांसपोर्टर, ये इस तरह की पेरिटोनियम होती है। तो स्पेशली अगर लो एवरेज ट्रांसपोर्ट में हम जब मशीन लगाते हैं तो मे बी अल्ट्रा फिल्ट्रेशन तो हम अचीव हो जाता है, बट कहीं ना कहीं क्लियरेंस जो है वो मे बी अचीव नहीं होता। तो इन दैट केस वी नीड सम मोर टाइम टू एक्सपोज पेरिटोनियम विद फ्लूइड। तो उसके लिए हमें क्या करना है, हम डे फिल या लास्ट फिल रख सकते हैं। तो लास्ट फिल के लिए हमारे पास 2 ऑप्शन है, आइदर टैक्सोइड बेस्ड सॉल्यूशन रख सकते हैं या फिर आइकोडेक्स बेस्ड सॉल्यूशन। इसके बाद पेशेंट वेट एंड पेशेंट का वेट हम एक बार डालेंगे। तो बेसिकली वेट डालने का पर्पज़ ये है कि एक सेफ्टी फीचर है अकॉर्डिंग टू मशीन। अगर एक पेशेंट का फिल वॉल्यूम आपने रख दिया, मान लो बच्चा है उसका वजन है 20 kg और आपने फिल वॉल्यूम रख दिया 2 लीटर, क्या होगा, ये पेशेंट को आई। तो इन दैट केस जैसे ही अगर ये कॉम्बिनेशन ठीक नहीं एज पर बॉडी वेट जो हमारी गाइडलाइंस उसके हिसाब से अगर ये ऊपर नीचे होगा मशीन को लगा ठीक है जी। सो आपने जैसी साइकिल तो मशीन ऑटोमेटिकली कैलकुलेट करेगी नंबर ऑफ साइकिल एंड ईच साइकिल ये चल रहा है। तो ये मशीन ऑटोमेटिकली कैलकुलेट, ये जो 1 आवर दैट इज नेट वेट। इसके अंदर फिल और ड्रेन टाइम अलग चल रहा है। प्रॉपर तरीके से सिंपल सा हमने 10 मिनट रखी और अगर 5 साइकिल हो रही और 1 आवर 26 मिनट तो 26 मिनट मशीन ने ऑटोमेटिकली कैलकुलेट एंड ड्रेन। तो ये दिस इज ऑल अबाउट प्रोग्रामिंग। इसके बाद जैसे ही आपने प्रोग्राम सेट किया देन जस्ट प्रेस टू ग्रीन बटन प्रेस करके ही आपको मशीन स्टार्ट मशीन डिस्प्ले करेगी। तो मैं एक बार आपको कितना टाइम
एक तरीके से बताइए, एक स्टैंडर्ड एडल्ट 2 साइकिल कर रहे हैं 1.5 2.5,
ओके
तो क्या क्या सेटिंग करेंगे?
ओके सो
इनसे से हम किसी को CPD कर रहे हैं, वी फिक्स 1.5 हम कर रहे हैं 3 आवर्स की, 2.5 5 आवर्स के लिए, देन 2.5 से 5 आवर्स की, इसमें कैसे करेंगे? पता APD में सपोज वी वांट टू डू ओवरनाइट 12 hours का we want to do, and we have APD bags contain how much fluid? 5 लीटर। तो हमें 2 बैग यूज करना है, एक 1.5 और 2.5। तो इसमें कैसे सेट करेंगे बता, इन्होंने पूरा कहा ना सेटिंग। तो इनको ना वो सब एक्यूट पीडी पूरा 40 डेज का स्टैंडर्ड बताइए, 2 बैग्स का कैसे करेंगे, एक का किसी का करके उनको स्टैंडर्ड वाला।
सो लेट्स
तो इसमें जैसे सर डिफरेंस इज दैट हम CPD में हम सब कुछ खुद सेट करते हैं, इसमें तो मशीन ऑटो सेट्स, वी कांट सिलेक्ट कि इतने ड्यूरेशन का कर लो, इतना फील्ड वॉल्यूम, ऑल दिस थिंग्स ये ऑटो सेट। with the total duration of time, including volume and cycle and कितना है in volume.
सो अभी एक रफ कैलकुलेशन कर लेते हैं. तो सपोज सर ने एक पेशेंट दिया एंड सिंपल पेशेंट का जो हाइट है वो 5 फुट 5 इंच है एंड वेट जो है उसका वो 60 kg है. एंड सर ने बोला कि आप इनका रात को 10 लीटर बैग के साथ में 2 लीटर फिल वॉल्यूम रखना है एंड इनकी साइड में. तो सबसे पहले आप हाउ विल यू प्रोग्राम. तो जैसे ही मशीन आपने ऑन किया ऑन करते ही सबसे पहले मशीन में स्प्रे होगा. प्रेस गो टू स्टार्ट. तो वोट यू हैव टू डू जस्ट प्रेस डाउन. मशीन डिस्प्ले करेगी चेंज प्रोग्राम. अब हमें 1.5 एंड 2.5. तो इस मशीन के अंदर दो ऑप्शन हैं. और तो ये आप देखें हीटर बैग आप अगर इस पर हाथ रखिए तो ये फ्लूड वॉल. इसका एक एडिशनल एडवांटेज ये है कि जैसे जहाँ पर बहुत सर्दी होती है तो वहाँ पर भी फ्लूड जो है वो 36 और 37 डिग्री सेंटीग्रेड पे ही पेशेंट की बॉडी में जाएगा, उससे पहले नहीं जाएगा. तो ये इसका एक फंक्शन है. तो सबसे पहले आपने चेंज प्रोग्राम किया, हमने एंटर दबाया. तो थेरेपी हमने सिर्फ की क्योंकि हमें नॉर्मल जैसे सर ने बताया कि जो डेली जो क्रॉनिक पेशेंट है और घर पर डेली मशीन लगा रहे हैं उसके लिए हमें प्रोग्राम सेट करें. फर्स्ट हमारा प्रोग्राम हुआ हमने थेरेपी सेलेक्ट कर ली. थेरेपी CCPD और IPD. CCPD मीन्स कंटिन्यूस साइक्लर पेरिटोनियल डायलिसिस और इंक्रीमेंटल पेरिटोनियल डायलिसिस. ठीक है, ये हमारी सेलेक्ट हो गई. देन अब टोटल वॉल्यूम. तो सर ने हमें बताया था कि टोटल वॉल्यूम कितने लीटर रखना है. अगर सर बोलते हैं 15 लीटर करना है तो कैसे करोगे. जस्ट टू प्रेस टू एंटर एंड प्रेस अप एरो फॉर इंक्रीज एंड डाउन एरो फॉर डिक्रीज. तो ये मैंने 10 लीटर सेट कर दिया. नाउ अगेन थेरेपी टाइम. तो थेरेपी टाइम हमने 10 घंटे रखी है. अप एंड डाउन से आप इसको भी अप या डाउन कर सकते हो. अगर मुझे सर बोलते हैं कि नहीं यार ये पेशेंट को लो ट्रांसपोर्टर है इसको थोड़ा लंबा रखना है तो हम 12 घंटे रख सकते हैं. इसीलिए एक और मेरी जो रिक्वेस्ट है, हम सर से भी बात करते हैं सबसे बात करते हैं कि अगर APD में हम पेशेंट शिफ्ट करें तो हम पैट स्टेटस बता देना चाहिए. अगर पैट स्टेटस नहीं पता तो यहीं पर हमारा जो पूरा रोल है कितने घंटे से रहते हैं. पेशेंट सीवियर हाई ट्रांसपोर्ट मे भी रात की मशीन 8 घंटे से भी काम चल जाएगा, दिन में एक हम हाइपोटेक्शन डालेंगे. लेकिन अगर पेशेंट लो ट्रांसपोर्ट तो उसको रात की साइकिल बीच में देखेंगे फिर हमें 5 साइकिल की ज़रूरत नहीं है. मे बी अगर पेशेंट अलाउ करता है, पेशेंट का बॉडी सर्विस एरिया अलाउ करता है, वी विल डू 4 साइकिल इन 10 लीटर. ठीक है. अब पेशेंट का बॉडी सर्विस एरिया बहुत हाई है तो इवन वी कैन डू 3 साइकिल ऑल्सो.
So suppose someone is a high transporter. So the volume we put only 1.5. He does more number of cycles. हो जाएगा ट्रांसपोर्ट. सपोज इज लो ट्रांसपोर्ट तो वी रिक्वायर मोर अमाउंट ऑफ एक्सचेंज टू टेक प्लेस. तो हम वॉल्यूम बढ़ा देंगे 2.5 कर लेंगे. तो दैट एंड तो उसका जो थेरेपी टाइम है तो एक्सचेंज टाइम भी गो वी कैन कीप लॉन्गर. सो दैट इज हाउ वी
ठीक है. तो ये इसी के हिसाब से
ये समझना बहुत जरूरी है. अनलेस यू डू दैट व्हाट हैपेंस देयर इज अ मिसमैच. सो यू आर डूइंग APD 2 बार कर रहे हैं कुछ आई नहीं. So you have to see what is this transporter and accordingly either the volume increase or the number of cycles you go you change.
So once एक बार हमने थेरेपी सेट कर दी then we have to fill volume. तो fill volume अगेन ये स्टैंडर्ड नहीं है. आप ऐसा नहीं है कि हर पेशेंट को एक सिंपल आंख बंद करके एक ही थेरेपी चल रही है 10 लीटर 2 लीटर 5 सेट नहीं. ये हमें देखना है क्योंकि यहाँ पर हमारे पास फ्लेक्सिबिलिटी. अनफॉर्चुनेटली जो 2 लीटर वाला बैग है वहाँ पर हमारे पास फ्लेक्सिबिलिटी नहीं है. वी हैव 2 लीटर बैग. आइदर हम वेस्ट करेंगे उसको और ज़्यादा हम लगा नहीं सकते. 2 लीटर बैग तो नहीं लगाएंगे उसको. तो यहाँ पर हमारे पास फ्लेक्सिबिलिटी है. एज पर रिकमेंडेशन गाइडलाइंस बॉडी सर्फेस एरिया हमने कैलकुलेट कर लिया तो हमें सबको 5 साइकिल देने की जरूरत नहीं. इफ पेशेंट का बॉडी सर्फेस एरिया ज़्यादा है, पेशेंट जो है वो एवरेज ट्रांसपोर्टर है, वी कैन डू 2 साइकिल 3 साइकिल ऑल्सो इफ नीडेड. अगर पेशेंट को हम सिंपल इसके अंदर एक और साइकिल क्या होती है. अगर मैंने एक पेशेंट है डे फील्ड लास्ट फ्लो तक मैंने ऑप्शन लगाया है. अभी देखिए लास्ट फ्लो. तो लास्ट फ्लो में मशीन अगर मैं लास्ट फ्लो यहाँ पर 2 लीटर डाल देता हूँ या 2.2 लीटर डाल देता हूँ. डालने के बाद जब मशीन एंड होगी तो फर्स्ट वो 2 लीटर फिल कर देगी पेट्रोलियम में एंड आफ्टर दैट मशीन पे यहाँ पर एंड ऑफ रख देगा. विल डिस्कनेक्ट द मशीन. आफ्टर डिस्कनेक्शन पेशेंट कहीं भी जा सकते हैं. नॉर्मली वो 6 घंटे 8 घंटे के लिए कहीं भी जा सकते हैं. पेशेंट इज सीवियर लो ट्रांसपोर्टर देन इवन दे कैन फिल एक्स्ट्रा बेस्ड सॉल्यूशन अप टू 8 आवर. तो उसके बाद 8 आवर के बाद ड्रेन करें. वो मैनुअल ड्रेन कर सकते हैं बाई मशीन पर ड्रेन कर सकते हैं. लेकिन अगर आइको डेक्स्ट्रिन हम फिल कर रहे हैं तो वो हम फिल मैनुअली करेंगे, बट ड्रेन जो होगा आफ्टर 8 to 14 आवर्स के बाद में मिनिमम, अगर आइको डेक्स्ट्रिन डेबिल क्लियर मिनिमम 10 आवर्स से कम अगर अप्रोच का फायदा है, मिनिमम वी हैव टू कीप अराउंड 10 to 12 आवर्स मिनिमम। लेकिन आइको डेक्स्ट्रिन को आप अप टू 16 आवर्स तक भी पेरिटोनियम में रख सकते हैं। अगर डेबिल कर रहे हैं आइको डेक्स्ट्रिन को 16 आवर्स तक ये रखने के बाद सिंपल अपने नंबर मशीन कैलकुलेट करेंगे। मैं इसके लिए मैं जस्ट वी नीड दिस 4 फ्रॉम सेट। ये हर बार हर डे एक फ्रेश, ये एक कैसेट चाहिए, 2 हमारे पास बैग चाहिए 5 नॉर्मल 10 एंड वी नीड 1 मिनट। ठीक है, तो मेरे पास में मैं आप सब लोगों को एक वीडियो भी शेयर कर देता हूँ, पूरा प्रोसेस है करेक्शन करें। तो इसमें सबसे पहले इसमें बटन को या प्रेस बटन स्टार्ट है, प्रेस बटन स्टार्ट होता है, ये इसका लोड कर सकते हैं, ये इसका हैंडल। सो वी विल आई विल गिव यू एंटायर कनेक्टर लॉजिक कैसे होता है। तो मैं आपको एक वीडियो इसका देखिए, सिंपल 1 बटन सिस्टम है। जो हमारे पेशेंट हैं वो भी मैक्सिमम तो इसके लिए 1.5 2.5 दोनों मिक्स हो गया। अगर आपको दोनों अगर अलग से डालें तो वी हैव सेपरेट ऑप्शन, डिफरेंट टाइप डिफरेंट कॉम्प्लेक्सिटी, बट नॉर्मली जो प्रोडक्ट है दोनों हमारे 1.5 2.5 फर्स्ट 2 लीटर इस बैग से पेरिटोनियम में जाएगा एंड इन बिटवीन जितना वो डायलिजेट हो रहा है, जो नीचे वाला बैग है 2 लीटर इसके अंदर। तो हमेशा जो भी पेशेंट पेरिटोनियम के अंदर फ्लूइड जाएगा इसी बैग से मिक्स होगा। नहीं 2 लीटर पहले सेकंड टाइम इसको मिक्स होगा। महेश so thank you very much and अगर कुछ भी this is
CME on PD College, and thank you all so much for coming and taking out your precious time. And I would like to request Dr. Professor Dinesh Khulla, Chairman and HOD Department of Nephrology at Saket Complex, to inaugurate the session, please. Welcome, sir.
Good afternoon, everyone, and warm welcome on behalf of our hospital to some of the very dear friends, my seniors, colleagues who I can see here, and certainly many more are going to join during the course of the day. It's a privilege to have, and a big honor to have people like Jen Verma, Professor Rupi Kalra, Mr. A.K. Bhalla, Mr. Bhaumik, Neil Agarwal, and Piyush Mathur, Vineet, and as I said, a whole lot of faculty members who have tremendous experience in the field of peritoneal dialysis. So we'll limit our discussion as nephrologists to peritoneal dialysis, which we all believe is not getting its due share, a wonderful modality, and that's why we have named today's program as reinvigorating peritoneal dialysis, because we believe it needs that kind of extra thrust. So there has been some degree of pessimism surrounding around a wonderful modality, and people from whom I have learned a lot of nephrology tips in nephrology who are here will testify to my statement that we have experienced great results. We have been able to save innumerable precious lives with the help of this modality, which has evolved over the years. But somehow we have also found, and that's very, very relevant from the youngsters, because you are the future. And if you do not get the desired confidence in the modality of peritoneal dialysis, we are not going to head anywhere. So it's basically to overcome this inertia which we have found has percolated into the youngsters like you for unfounded, for unknown reasons, for unfounded fears and unnecessary apprehensions about this modality, that we thought it is very, very important to talk about the nitty-gritties of peritoneal dialysis today. We had planned this well in advance, and we welcome Dr. Kailash, welcome Dr. We had planned it well in advance. So as you all know, these are very testing times for us as doctors. So after that heinous crime which has shaken the entire world, not just the medical fraternity, we were in two minds whether to go ahead with today's agenda or call it off, because we know the sentiments are there. We are echoing each other's sentiments. We are as I said, passing through very difficult times, coming to terms with what has happened to a very precious colleague of ours. This brutal crime needs to be condemned in the harshest of the words, and the strictest of punishment to be given to the perpetrators of this crime. So that goes without saying. So while we are praying for the peace of the departed soul and conveying our sentiments to the family of the deceased, we thought that this endeavor of perpetuating knowledge should continue. And with that in mind, we decided to go ahead with today's program, which is also being transmitted live online. And at this stage, I would want to express my deep gratitude to all those people who have helped me in organizing today's program. Dr. N.P. Singh, our academic in charge, who is at the moment sitting in the US, has been a pillar of support as far as organizing these kind of academic endeavors are concerned. I'm sure is going to join us. Maybe he has already joined. If someone can check it for me, if he's there online, and can we just hear him give his words of encouragement to us. That's one. And of course, the entire department, starting from Rahul Grover, Kulwant, Deepak, and Abhishek, and of course Sahil, who actually just left the hospital for some other one, but then he was also instrumental in organizing today's program as well. So the whole idea today is going to be spent on the actual nitty-gritties of peritoneal dialysis. And of course, if we, and this is something definitely which we would love to make it a regular affair, in times to come, in the future editions, we'll take the level, the standard to the next level, so that you take it from where we leave today. But for today, we will talk about absolute basics, and please feel free to interrupt us and ask your questions, because ultimately we would love to have the participation of the residents, the young budding nephrologists, because it is basically aimed for you. So please do not disappoint us, because this is basically keeping you in mind that we are organizing this program today. And of course, the unrestricted grant, the educational grant from Baxter, which has been instrumental in organizing today's function. Before I proceed, I think I'll just let you know the format of today's program. So we will first start by a keynote address, and I couldn't think of a person better than Professor A.K. Bhalla, who has been my senior colleague, my mentor. I've learned a whole lot of things from him. I was fortunate to be working with him, under him as a junior nephrologist for good over 17, 18 years while I was at the Renal hospital. And he has many facets when it comes to being a great nephrologist. But if I were to choose one, the two striking things come to mind. First of all, are his skills at making vascular access, and secondly, the time and energy and passion he has shown to promote peritoneal dialysis in our country. So I don't think of a person better than Professor Bhalla to give a keynote address talking about his journey of peritoneal dialysis, and he is going to be flanked by three chairpersons. Srishti is going to announce the names, but when I said I will announce the format, the speaker is going to give his or her lecture, the talk, which will be followed, that will be typically for about 12 to 14 minutes. And for the remaining 3 to 4 minutes, the chairpersons are going to talk about their experience of peritoneal dialysis. All the senior people, we would love to hear from their experience, their pearls of wisdom, while avoiding asking the speakers any questions at that point in time. And for the question and answer to the speakers as well, we will have two panel discussions. For the first three talks, a panel discussion which will follow the first three talks, and then we'll disperse for a short tea break, followed by another 4 or 5 talks by the experienced faculty, and again the same will follow. The chairperson will give their viewpoints, and then finally there will be a discussion. For the first discussion, I'll be joining General P.B. Verma, another great personality having tremendous experience. As you can see, I'm reminded of my PGI days where I was junior to General Verma and Professor O.P. Kalra, and I learned a lot of things. And PD was actually, we were all students of late the famous, the legendary Professor K.S. Chud. And PD was etched into our minds. It was incorporated like anything when it comes to the day-to-day working of the department and was concerned. And then of course, over a period of time, we have seen a lot of innovation, a lot of improvements, and that is why we became so much interested, to an extent that we started emulating what the Western world, what the other countries had shown in terms of the longevity of the procedure. So when I started doing peritoneal dialysis, I could never have imagined that one fine day I would be able to claim that one of my patients has lived on peritoneal dialysis for 21 years without a single episode of peritonitis. There have been at least 5 patients. Unfortunately, that patient migrated to Canada last year, and out there, for some reasons, they gave a break to peritoneal dialysis, and he had encapsulating peritoneal sclerosis. We will say why we may believe that EPS at times happens when you give it a break. So that's a learning point. But then the gentleman is doing very well still. After 21 years in PD, he's now on hemodialysis. His brother lasted for 17 years on peritoneal dialysis. There have been at least 10 cases which come to my mind, people who have survived for longer than 12 years. So we in India can also boast about the fact that peritoneal dialysis patients can survive for much longer than 10 years, 15 years without any episode of peritonitis, because the main reason why we have been discouraged to promote peritoneal dialysis was these inherent fears, unfounded fears that this can promote, this is invariably going to have infection, but that is not the case. We will be discussing about what ails the peritoneal dialysis during the panel discussion, and we will come back to that question one more time as to why we believe it's being nowadays labeled as a dying art. So before we actually really face that kind of harsh reality. It's time to wake up and have that desired confidence in the peritoneal dialysis modality as a treatment, so that we can continue to practice something which I've often reiterated today is a remarkable modality of treatment. With that, may I request Professor A.K. Bhalla for his keynote address, and can Srishti, can you announce that, the chairperson for the...
For the first session of the afternoon, I would like to call upon the chairpersons, Dr. U.P. Galra, ex-Vice Chairman, University of Health Sciences, Rohtak, and ex-Principal and Head of Department of Medicine at UCMS Delhi, who is currently associated with Santosh Medical College, Ghaziabad. Our second chairperson, Dr. Neeru Agarwal, Principal and Director, Nephrology and Kidney Transplantation at Max Vaishali. And Dr. Piyush Mathur, Senior Consultant, Department of Nephrology at Santhopa Durlabji Memorial Hospital, Jaipur.
Good afternoon, everyone. The speaker for the session is Dr. A.K. Bhalla. He is Honorary Secretary, Board of Management, Sir Gangaram Hospital, Chairman, Institute of Renal Sciences, Sir, and he is Padam Shri awardee, Dr. B.C. Roy Award. Both of them are very extremely prestigious awards, and he also has won Dronacharya Award also. So peritoneal dialysis that we see nowadays is very, very different from how it evolved. The rubber tubes were used as catheters, then there has been many changes in the catheter, in the fluid, in the insertion techniques. Many more evolutions have taken place over the time, be it the world level or as well as in India. So I invite Dr. A.K. Bhalla, sir, please come and enlighten us about the journey of peritoneal dialysis in India.
Thank you, Chairperson, sir. At the outset, I would like to thank Professor Dinesh Puller for your kind introduction and inviting me for this PD college and giving me this prestigious keynote address. Now, my journey of peritoneal dialysis society started from 1988 in Dandaram Hospital, but during our PGI trainings from 81 to 87 also, we were regularly doing intermittent peritoneal dialysis. So IPD was So we all actually started during our training, we were regularly practicing intermittent peritoneal dialysis. That is acute peritoneal dialysis with a rigid catheter. So that was a part of our training. So even when I came to private setup, I continued with the practice of IPD, and Dr. Rana, of course, he was also trained from PGI Chandigarh. So he also was in favor of IPD, and we used to do on an average 7 to 8 peritoneal dialysis daily. So that was how we started our peritoneal dialysis. It was 1988 when Dr. Rana, he asked me to focus on CAPD, because that was the modality which was not being practiced in our country. And then I started working on peritoneal dialysis. So one thing I would like to say before the start of the peritoneal dialysis journey, that I started with my efforts with the saying that PD is being practiced by second degree nephrologists on second degree patients, and it is a second degree treatment for the as dialysis. So that was the saying, and that's how the peritoneal dialysis was described in comparison to hemodialysis. So as Dr. Kudar already highlighted, so anyone who wants to go, who is interested in peritoneal dialysis, he has to have passion in peritoneal dialysis. If you don't have passion, commitment, then you cannot succeed in establishing this form of treatment. And I must acknowledge here that this Padma Shri Award as well as Viceroy Award, both were actually my recognition of my contribution in peritoneal dialysis. I will acknowledge these 5 great personalities. Dr. Chud, who trained me in nephrology, and Dr. Johari actually. He brought this Tancroft catheter from London when he joined our hospital. So he pushed me to put some patients on PD because it was only he who knew how to put Tancroft catheter. Nobody else could put a Tancroft catheter. And it was not available, but he brought few CAPD catheters, and that's how we started doing peritoneal dialysis by putting Tancroft catheter and then putting these patients on glass bottles. So we were using glass bottles with ordinary IV set, and the longest survival was 9 months. So we presented that data at Jabalpur API conference. Then Dr. Anna, of course, he is my mentor, and it was Dr. Vatsala, which nobody will know that now she is more into transplant, kidney transplant at Singapore General Hospital. We went to CAPD training in Singapore General Hospital. It was that during that training that I learned how to use OSET, and then I came back to Delhi and I started using CAPD at Gangaram Hospital. Dr. P.D. Durati, I have put his photo here because he referred me the first patient who was put on OSET system. And after that, Dr. O.P. Tarda is sitting here. So Dr. O.P. Tarda was a tremendous support for me when he was in UCMS heading the nephrology department. He referred many patients for PD, and that's how I had got this procedure at Gangaram Hospital. So just to share with you, you all know this, that there is a huge population who needs dialysis. And there are about only maximum 2 lakh patients, which is we have collected figures from industry who are on hemodialysis. And there are about 6,000 patients only. At one time we had 8,000 patients on PD, but this figure also I am saying maybe that it is overstated. But now there are hardly about 4,000 to 5,000 patients who are on PD. And around 13,000 transplants were done last year. So rest are on conservative treatment, and we all know what is going to happen to these patients. But dialysis is growing at a very fast pace, that is 31% growth rate. And hemodialysis is such a established procedure in our country and such a fast growth and relatively easy procedure and nothing much burden on the nephrologists. That's how the hemodialysis is growing on a very fast pace. And as far as PD is concerned, you have to you have to have all efforts if you want to have any growth in peritoneal dialysis. Why I have put this slide? This slide should not be there in any nephrology gathering, but still, our DNB students, apart from very few centers, they hardly know that there is a third modality of treatment also for end-stage renal disease. That is hemodialysis, peritoneal dialysis, and kidney transplant. So we have to again and again stress this fact that peritoneal dialysis also is a treatment modality for end-stage kidney disease. And it is a very established and accepted procedure. Again, dialysis modality, if you know hemodialysis, it is now, home dialysis again is now growing in our country. So hemodialysis we all know, but peritoneal dialysis, both manual as well as CCPD and the CAPD, both have to be trained to our younger colleagues. Again, what are the benefits of preserving residual renal function? we all know that residual renal function is better preserved in peritoneal dialysis, and so we have to do all our efforts to preserve residual renal functions. At least for first 2 years on dialysis, there are a lot of studies. I will not go into the much of science in my talk because it is a different kind of keynote address. But for first 2 years, the residual renal, the mortality and survival benefits are better in peritoneal dialysis as compared to hemodialysis. So residual renal function is very important. Almost 1 ml per minute of creatinine clearance is equal to 10 liter of creatinine clearance per week of peritoneal dialysis. So we have better endocrinal function, better anemia management, better quality of life, improves beta-2 microglobulins and middle molecule clearance, and better volume control. So definitely there are some advantages of preserving residual renal functions. In India, in 50s, when Department of Nephrology was established at PGI Chandigarh, then it was the dialysis was started with intermittent rigid peritoneal dialysis, acute peritoneal dialysis, and it was used for both AKI and CKD. All those who are trained from PGI Chandigarh, we know how we used to keep the patients alive for 6 months or 1 year on just intermittent peritoneal dialysis. Once in a week or once in 10 days, patient will come, he will be given one peritoneal dialysis, and then he comes again after 10 to 15 days. So it was in chronic CAPD, the efforts were, various attempts were started at SGRH, Chennai, SGPG, Lucknow, but no proper fluids was available. Lot of companies came like Transplant company, then Claris company. Then of course we spent months and years with Baxter company, and we gave lot of material written applications to them for custom clearance, for import, and it was the effort of about 4 or 5 years. And this was a combined effort of Dr. Georgie, Dr. Amit Gupta, and Dandaram Hospital. So we were the 3 main centers involved in this getting the custom import clearance, and that's how, and of course this all homework was done by Baxter company. So Baxter was keen to bring this in our country, and tank of catheter was also not available here. So this was also regularly available after 1992 only. So actual CAPD started in 1993. Then OSETs, I am sure none of you must be knowing what is OSET. So maybe Dr. Kudar or Dr. Narayan Prasad also may not be using, he might not have used OSET.
I have seen it.
So Dr. Kudar has used. So OSET was the first set available with us, and after it was a very cumbersome process, but after that we could still put many patients on OSET. But it was YSET actually when it became popular, and infection rates also came down. But ultimately, then today you have the twin bed available with you, such a easy treatment, and such a already it is the effort of all your seniors that today these materials is available in our country, and it has become much easier with the twin bed as well as this home choice system and other APD machines from our other companies also. So there are now 3 companies available in our country who are supplying CAPD material. So Peritoneal Dialysis Society, ultimately, then all these centers who were interested in peritoneal dialysis, they collected at Bangalore. So it was Sundar, Dr. Sundar, who called this meeting. So at that meeting, the Peritoneal Dialysis Society of India was formed, and after that we are having a regular annual meeting, and regular Journal of Peritoneal Dialysis also been published since then. So this is just to show that how this Singapore training has helped me in establishing peritoneal dialysis. This is a photograph of our Peritoneal Dialysis Society of India, where you can see Dr. Rana, Dr. Georgie, myself, Dr. Amit Gupta, Dr. K.S. Naik. So these are the actually people who have really worked hard for peritoneal dialysis. So these were the collaborators who worked at that time, and we also worked with some international nephrologists like DG Oriopoulos from Toronto, then Ramesh Khanna, he was one of our own. He used to come regularly to India and used to help us. Karnov and Ram Gokal, then Bargeman and Sarah Pritchard. They were really interested. I have personally interacted with all of them, and they were interested in peritoneal dialysis program in India. So as I said that you have to have, even our curriculum, I don't know whether it is mandatory that some number of PD have to be monitored, or you have to put catheters, or you have to work up minimum 25 CAPD patients, nothing like that. So DNP or DM training has to be PD oriented also, apart from hemodialysis. And the positive patient selection is also very important. Not that all neglected patients on hemodialysis, they are referred for PD. And we have to see that now the PD technique has become much easy. So now there should be growth. At one time we had a very good growth in peritoneal dialysis, but since last about 5 to 6 years, again it has shown a downward trend. So that period when we used to do almost 20 to 25 insertions per month at Renal hospital. Now we were reduced to about 5 or 6. Only since last 6 months, the PD has really, as we said, it has re-emerged or been reinvented, and now we have put almost 51 patients in one, and in April we put 25 patients on peritoneal dialysis, which we were ourselves also we were surprised that how suddenly the PD number has grown at our center. Then it has to be a team approach. Nephrologists, nurses, dietitians, clinical coordinators, and industry also is very important in this. The decrease in peritoneal, almost 1 in 60 months. When we started it was almost 1 in 20 months, and now it is 1 in 60 months, which is quite acceptable and almost comparable to international standards. These were the various events organized by Ganga Hospital and office bearer positions we held. Annual conference of PDSI was held in 2001, then at 2007, then 2022 and 2023. So PD University, again that is a further advanced form of education, was held in 2001, which was a grand success. Lot of DNB and DM students, they developed interest in peritoneal dialysis after this. PD college we had organized in 2012. So all these, like this today PD college, I'm sure some of your DM students will get interested after, in this procedure. So one major meeting in such a large meeting was organized by us. That was Asian chapter of ISPD. So it was really a very successful meeting, and almost 1,000 delegates were there, and a lot of international participation was there. So we are organizing annual CAPD patients meet every year. So more than 100 patients, we call them on our meeting. All surviving patients, they come, they share their experience. This is a regular exercise since 2001. Dr. Kuller knows that he has participated in all these CAPD patients meeting. Then I became Secretary General of Peritoneal Dialysis from 2001 to 2004 for 2 terms, and now presently I am Peritoneal Dialysis President, PDSI, I am President of Peritoneal Dialysis Society of India from 2023 to 2024. This is just to share some of the photographs, and this is actually from our 4 pillars of Randaram Hospital. Dr. Rana, I will say this term even for myself also at that time, Dr. Ashwini Gupta, and of course Dr. Dinesh Kuller. You can see how happy Dr. Kuller is. Dr. Kuller actually he joined in 1997, and then he was for 3 years DMC, he was the faculty member there in DMC Ludhiana. He was practicing peritoneal dialysis even at Ludhiana also. And 1997, he had a passion for peritoneal dialysis. He became very interested in developing peritoneal dialysis. From 1997 to 2013, he stayed at Randaram Hospital, and he contributed a lot in every field. Of course, later on his main focus of interest became induction in kidney transplantation, but he was very much interested in peritoneal dialysis, and he used to put a lot of patients on peritoneal dialysis. This is the annual meeting of CAPD patients we used to conduct every year. This is our 2023 workshop. Again, I think Fuller is very popular amongst girls. So this is thus all 3. We have this cycler from Baxter, even enditist Fresenius. Although Fresenius is not promoting peritoneal dialysis in our country, they are mainly focused on hemodialysis. And we have Fresenius APD also. And we have J. Mitra also has come up with cycler, and that is made in India cycler. And they have again this is made in India fluid also. Apart from twin bed, now they have come with triple chamber bed also, which is a neutral pH bed. So I am sure in this, if we start promoting our Indian companies also, it will be helpful in reducing the cost. This is one major study which was multi-center study for peritoneal infection peritonitis in India. So almost 20 centers participated in this study. So this was a very useful study. So actually PD and hemodialysis, we should consider them as a complementary to each other. And PD first policy, we know it is being already practiced in Thailand, Hong Kong, Mexico, and they have more than their 80% on PD initially. So maybe after 2 years, so when maybe residual renal function goes down, you can shift them to hemodialysis. So that kind of policy in our country, actually, it is a state subject. So I don't think government can do that. There cannot be a mandatory policy like that in our country. But still, as a nephrology community, we can always promote that practice. Why I have to again list all these? You all know. But still, we must see that there are certain advantages of peritoneal dialysis over hemodialysis, which should be highlighted. If our DNB, DM students, they are not taught this thing, and they are not shown that how in practice this is actually beneficial, how they will start, they will have the confidence in the procedure. So as a teacher, as professor, as HODs, it is our duty also that we should again and again teach peritoneal dialysis. When we go in the exam, we ask about PD. Almost 90% of the candidates, they have not seen actually a CAPD patient. So when we show them Tankov catheter, sometimes they don't know any functioning, how Tankov catheter functions, what is the dual rod, what is titanium diaphragm, they don't know anything. So what is YSAT, what is planetal, unless you see these things, you will not know. We have all kinds of fluids available, although Nutrimil amino acid fluid is not very popular, but other fluids are all available, icodextrin is available, and it is routinely being used. Now a remote control monitoring system also is there. We have a Claria system from Baxter also, where you can monitor the fluid being delivered to the patient by remote control. So this Claria system, again you have to learn. First you have to learn the basics, only then you can go for advanced softwares. So now at one time, actually 15% of the patients were on PD, but now it is not so. This is actually slide which is old slide, but today only there are about 6% patients who are on peritoneal dialysis. But dropout rate has not changed. It is still 30% because the kind of patient you put on PD is already at an advantage and disadvantage, because they are either CVA patients or cardiomyopathy patients. We have had all kind of experience at our center. CAPD in congestive heart failure, ejection fraction as low as 10%, CAPD in chronic liver disease with decompensation and having very good survival. Then again CAPD in failed transplants, again very successful. Even to the extent that some patients, if you want to shift them from PD to hemodialysis, they refuse, because they are so much happy, so satisfied with PD that they do not want to shift to hemodialysis. I am sure all those who are practicing PD, they must have seen, experienced this, that patients themselves, they don't want to shift from PD to hemodialysis. We started our program in 1989, 51 patients on glass bottles, 1993 OSAT, 1995 YSAT and twin bag, then regular PD program since then. Total insertions 2800, total surviving patients 136, 19 patients on APD, and 36 patients on icodextrin. And more than 10 years patients, we have 11 patients who are surviving, and 11 patients out of these 6 are surviving. We had longest was 16 years, and I must compliment Dr. Fuller that 21 years is really a record. I'm sure you should have published that patient, the 21 years survival. PD room is as important as hemodialysis machine for hemodialysis. This fact I think we have to highlight. Unless until you have a dedicated PD room, you will not be able to develop a PD program. If you want to really see how infrastructure should be there, you should go to SGPJ in Lucknow and see how they have excellent infrastructure for nephrology department. To the extent that C-arms are there, proper OTs are there. So that is how interventional nephrology can be practiced, PD can be practiced. PD Catheter should be placed right in your own department. You should not be dependent on your OT. You should not be dependent on your surgeons, other surgeons who are not nephrologists. So that PD room is very important, and you should have a computer. You should have a person who will feed the data. Only then you can have publications. So in our PD room, this is our PD room where we have a bed also and we have chair also. So some patients who are stable, ambulatory, they can sit on chair also, and those patients who are not ambulatory, they can lie down on the bed. This is our data of patients who are surviving on more than 10 years, but only one point I will like to highlight here is that none of them was diabetic. So basic disease also depends. If these patients, if they are low weight babies, patients, relatively less than 50 years, or they are not diabetic, women will do better, low weight patients will do better, non-diabetes will do better. Now, latest armamentarium in our hands is now Pradhan Mantri National Dialysis Program, which came in 2016, but peritoneal dialysis was added in 2019. So as a nephrologist, we have to see, now suppose our Prime Minister Narendra Modi ji, he has given us something. Now it is for us to how to utilize that. And Dr. Narayan Sir is there in that committee which decides about that how to go for dialysis in our country. So I am sure that you must promote peritoneal dialysis also. It has been already included. There are 748 districts in our country. So all districts they have 5 machines, minimum hemodialysis machine, peritoneal dialysis. So far, I think it is Baxter only which supplies, it has the contract with them. So maybe that it is a huge, difficult task. Where are the nephrologists? Where are the coordinators? Who will train them? But anyway, government has given you something. Now it is for us, for nephrology community, for PDSI to decide how to utilize this huge fund and huge infrastructure. There are certain non-medical challenges in rolling out this national PD program. That we don't have a uniform country. There are mountains, deserts, plains, and some very humid atmosphere, extreme of temperature. Then our economic variations, socio-economic status, so all things will matter. Family sport, of course, where we score in throughout the world. Maximum excellent family sport. So far, most of my patients, it's a husband who is there, wife will do, daughter-in-law will do. Very few patients are dependent on servants or nurse or coordinators. So that is, I think, biggest benefit in our Indian population, that this factor is already taken care of by our family members. We certainly had recent publications about survival data and microbiological spectrum in our center. Both have been accepted in Indian Journal of Peritoneal Dialysis. So to conclude, it is a viable option. Let's start from that, because now reinventing or innovating to the extent that we are thinking whether it is viable or not. It is suitable for certain population, definitely, whether neonates, ICU, CCU settings, and API as API therapy also. It may be the only available method of treatment for certain rural areas where hemodialysis facility is not available. PD first policy will definitely save this residual renal function. PD is a preferred modality in refractory heart failure, chronic liver disease, extremes of age, CVA patients, vascular access problems, and diabetes and patients with severe peripheral vascular disease. PD as renal replacement therapy for initial 2 years definitely has better survival. PD is a preferred modality in developing countries like India, where adequate hemodialysis units may not be possible in every corner, every place in the country. And PD remains underutilized, and Pradhan Mantri National Dialysis Program may prove to be a game changer. Thank you. Once again, I thank Dr. Surat for giving me the opportunity to deliver keynote address here.
First of all, I would like to thank Dr. Kuller for inviting me for this very important session. And after a masterly presentation by Dr. Bhalla, nothing really much for me to say. The journey of last 35, 36 years, which has been synonymous with the growth of many of us during the field of nephrology. We have seen the PD coming up, and then now we are talking of revival of PD. We talk of revival of the patient, but here we are talking of revival of a life-saving technique. I'm feeling it's a little unfortunate that we are, even after nearly 35 years of its usage in India, we are talking about this. But the fact is there. And it is not that the technique is bad. There is nothing wrong with the technique. Even when the infection rate was once in 12 months, even at that time it was being used, but now it has come down to nearly 1 in 60 months. It's such a wonderful technique, and patient is so comfortable. Patient has a flexible lifestyle, and the attendants don't have to worry. He has to visit the nephrologist once in 2 months, 3 months or so. You are having more liberty with your diet and all that. And patients who are having underlying heart disease, they can tolerate it much better. Still, it is not being practiced to that extent or with that vigor. And I feel to some extent, many of us are also responsible for it. Because I sometimes talk to the patients when we are discussing with them about various options for renal replacement therapy. And sometimes it is very surprising to know that although that person has been to quite a few number of hospitals, but a detailed discussion about peritoneal dialysis as one of the, life-saving modality is not even discussed in detail. In Southeast Asian countries, in Mexico also, it is being used as a very common form of treatment for patients with end-stage renal failure. Why not with others? Of course, there has to be things like policy at the national level, reimbursement policies and all that. But then it is not the only thing. The role of nephrologist as the main person who has to counsel the patient. I think when first meeting we are discussing with the patient about various options for renal replacement therapy, that is the time when we should spend maximum amount of time. And that is what we are not able to do. Because I know our outpatients are very busy and we have large number of patients, but then every patient who develops end-stage renal failure, for that patient to accept the idea that now his lifestyle is going to change completely, either transplantation or he is virtually feeling tied to a machine, but then we don't discuss that option that, okay, you may not go for transplant, you may not be tied to a machine, you can be still your own master. We don't discuss that so much. I was just recollecting my days when I was training for my DM in nephrology. At that time, although 91 or so when I went for my training in nephrology, 2 years we were doing large number of peritoneal dialysis. In fact, there used to be even a competition. Most of us were able to do intermittent peritoneal dialysis in 7 to 8 minutes. Although at that time we were using the glass bottles and the rubber set, which was reused after sterilization and all that. And then we used to do the PD again, even for chronic renal failure patients. Acute, of course, this was the most important first line of treatment. At night time, it was not easy to get access to hemodialysis. Now most of the units, they are providing access to hemodialysis 24 hours. But at that time, even in PGI Chandigarh, after 5 p.m. dialysis means that you have to do peritoneal dialysis. So therefore, that was one thing. So during those 2 years, we sometimes talked a little bit that, okay, Popovich and Moncrief, these were the people with whose efforts this became a treatment which can be sustained for months and years. But then we never saw a patient being put on CAPD. And when I completed my DM, I felt that there was one major lacuna as far as this particular aspect of treatment is concerned. I talked to Dr. R.K. Sharma and Dr. Amit also at that time. And at that time, I went to Sanjay Gandhi PGI for about 1 week to see how the CAPD is being practiced over there. And it was very nice, as Dr. Bhalla mentioned, they have really state-of-the-art setup for CAPD. Of course, Gangaram has also got equally good, and with efforts of Dr. Bhalla particularly. But after 5 or 6 days of training over there, I felt that there was need to go for further some more training. And I was very fortunate when Dr. Ramesh Khanna, who was that professor of nephrology at the University of Missouri, Columbia, along with Professor Karl Nolf and Dr. Twardowski, they were there at that center, and I got the opportunity to work over there for 3 months. Dr. Twardowski, as many of you will know, he is the person responsible for PET test and also many University of Missouri catheters. He has more than a dozen patents in his office in these areas. After coming from there, I mean, my own experience as far as CAPD was concerned, when I came back, I was in GTB hospital for a number of years, and initially we put about 35 to 40 patients on CAPD catheter, and it was very nice to see how these patients were having freedom in their overall day-to-day life. But thereafter, now the number has again gone down, and that is the state of affairs elsewhere in the country. I hope what Dr. Bhalla is seeing, a recent surge, it is a universal phenomenon in the rest of the country also. Presently, after my retirement, I joined at Santosh Medical College and Hospital, where during the last 1 year, the number of hemodialysis is increasing month after month after month. 1.5 months back, I talked to them that I would like to start CAPD, because the training, if we are thinking of starting DM, the training of the postgraduates cannot be complete unless and until they know CAPD as an important modality of treatment. So I got one big room dedicated for this, and I made the entire plan how we are going to have bed, sofa, chair and all those things over there. And then I talked to Dr. Bhalla also, and one person was to be deputed over there.
Sir, I did peritoneal dialysis in Santosh Hospital in 97 when dialysis facility was not available.
Not available, exactly. That is it. And even I was talking to the head of pediatrics over there that we could start peritoneal dialysis last week only for the children. And I think we must do that. In fact, after that, I mean, after my training in University of Missouri, I went to Nepal for 2 years, where in the entire country, there was only one center, Bir Hospital, where hemodialysis facility was there. Nowhere else it was there. I wanted to start hemodialysis over there. They said it will cost huge amount of money. The money was, of course, coming from Government of India, but initially they were not willing. I could not see patients with septic abortion, AKI, dying. I just told them, give me half a room, I will start intermittent peritoneal dialysis. Finally, after a month, they gave me half a room under a staircase, and that was to be disinfected next day. But the evening before, the patient came with septic abortion, severe acidosis. I started peritoneal dialysis on that lady without even proper disinfection, and the lady survived. That was the first time when they realized that patient of kidney failure can survive also, can recover also. So you need to convince, I think that is very important. I mean, there have been real hardships in having this procedure get established. But I am sure if the nephrologist as such, the most important thing is that if they discuss with the patient various options in detail, and show them another patient, because the patient has to be convinced not only by the nephrologist but by his other patients who are undergoing CAPD, then they will be better convinced. I think this is what I had to say to begin with, and thank you very much.
Dr. Piyush, do you have any experience?
Thank you, ma'am. Thank you, Kulisa, for inviting me and listening from pioneers of CAPD like Bala sir. It was very academic delight for all of us. So, fortunately, I was fortunate enough to be trained at that time when PD was at its peak and 15 years back, and so we were dare enough to do certain experiments on PD, like we did ascitic fluid ultrafiltration and reinfusion therapy at that point of time. We also put some patients of cardiorenal syndrome with the ejection fraction of 15-20% with refractory heart failure with normal renal functions for simple ultrafiltration by methods of peritoneal dialysis with 1 or 2 exchange a day. So there were almost 15 to 20 patients at that point of time we had, and we published that data also. So it's a very wonderful modality which from 1950 to IPD to CAPD to automated and then to gradual unfortunate fading off, and now at the revival phase. I think that the DM students who are present over here should learn this modality today in this PD college, because this is definitely going to help us in our clinical practice, and we should, all of us should come together to revive this wonderful modality. Thank you.
Any questions from the audience?
The questions towards the end, your concluding remarks, Dr. Nero, you can give your concluding remarks. And
My experience that when I entered IKDRC Ahmedabad, there was 8-bedded PD ward, and I was told to do the PD in the night. So I had no experience. So I called my senior. We did the peritoneal dialysis. It was intermittent peritoneal dialysis. There was state catheter with the skeleton. We used to fill the abdomen, and yes, it was a difficult thing, but it was very helpful when I started my practice after clearing my TMB exam. So at that time, hemodialysis was not available in all the centers. So as you are going to pass out, if you go to some other places, if hemodialysis is not available, peritoneal dialysis is still a good option. At least first thing, you are going to save the life of the patient. You will give him time to think about the future course of action, and then a way forward about RRT, how to go about it. Thank you very much.
well, thank you so much to the speaker. Of course, as I said, no one better than Mr. Bhilla to give this keynote address, and we are really privileged to have 3 chairpersons for the opening rounds. No one better than them. So much of experience. And at this stage, I would like to call upon Dr. NP Singh. If we can get Dr. NP Singh, you are on speaker phone. We were struggling how to make you address us all. Professor NP Singh is currently in USA. He's our academic in charge of our curriculum. It's rather early in the morning there. I think it's close to 5:30, and he's been listening to all of us. Dr. NP Singh, over to you now. If you're on speaker phone and you're addressing August gathering people, your friends, your old colleagues. We tried, you can unmute and probably otherwise, I think you can go ahead, you're on mic as well. Please go ahead.
Thank you very much for this wonderful academic event, and for the last 1 year since the time I've been with Dinesh, I think we had a wonderful academic activities in Saket, and I think I really enjoyed the mesmerizing talk by Professor Bhilla. I really am happy and lucky to be with him for the last 30 years, trying to learn from each other. And I absolutely agree with Professor Kavna and Dr. Dinesh and Dr. Bhilla about the PD being second modality of management, which is actually shown and given to the patients. And this hemodialysis program, which was started by Government of India, is now extended to PD, and I'm very sure that this would be a game changer, provided as nephrologists we should be able to give this alternative of PD to to our patients. No doubt, the quality of life, the anemia management, the residual renal functions, all are much better. And why only for select group of patients? It should be offered at least to all group of patients, and I must compliment Professor Kular for taking this initiative. And the impact or the success of this program will only be born by the fact that how much our practice changes in terms of offering this modality, alternate modality to our patients. Thank you very much, Dr. Kular, and I, on behalf of MSN, invite you all and welcome you all to this August medical gathering. And I'm very sure at the end of the day, before we start our dinner, we'll be absolutely sumptuous with our academic activity as well.
And a virtual dinner. And a virtual dinner for you, Dr. Thank you so much. Thank you so much for those very encouraging words. And we move on now. We're running a little short of time. I think, Srishti, over to you now for the subsequent announcement. Thank you very much.
For the second session of the evening, on the topic of the science behind peritoneal dialysis, I would like to call upon our chairpersons, Dr. Dipankar Bhaumik, Professor and Head at the Department of Nephrology at All India Institute of Medical Sciences, New Delhi, and Dr. Deepak Kumar Panigrahi, Consultant, Department of Nephrology and Renal Transplant Medicine at Max Saket.
Next speaker needs no introduction. I would like to request Dr. Rahul Grover, who is the Associate Director in Department of Nephrology and Renal Transplant Medicine, Max Superspecialty Hospital, Saket, to deliver his lecture on the science behind peritoneal dialysis. The podium is all yours, sir. Thank you.
Podium and 12 minutes are all yours.
So, when one said that you have to speak on science behind it, then politely said, what all will you speak? Because science is huge and I have to really think. So I'll try to start with the science. And I think so it is more of an art, that's where I end. So let me start. So first, the definition of science as in Oxford dictionary is that it is a systemic study, structure and behavior. Over here we'll be trying to look at the structure, behavior of the peritoneal membrane and how it is applied and for practical purposes which is the dialysis. So this will start from. So I started putting something first is the effective peritoneal surface area. This is the most important thing that we have to know, whether it is solute clearances or the fluid shifts that occur during the peritoneal dialysis. So the area of peritoneal membrane is something 0.55 meters square to 1.52, some people say up to 2 depending on the modality, whether CT or autopsy studies. It's visceral and parietal. It is the parietal peritoneum where the absorption occurs more. You have to know about the vascular supply, mesenteric artery supplies the visceral, drains to portal vein, and the parietal, it is that the abdominal wall arteries drains mainly into the IVC. The blood flow rate in the peritoneum is around 50 to 150 ml per minute, and it depends on the recruitment that how much of them are recruited. And there's lymphatic drainage, mainly in the subdiaphragmatic lymphatic system, which is the other part which has to drain. Again, effective peritoneal surface area, the peritoneum is wide, but it is only, if it is recruited, it is in contact with the fluid, and that is the dialysated area, and the capillaries are dilated only then feeding as well. Usually in adults it is 2 to 2.5 liters, in children it is around 40 ml per kg. It is also by body surface area. When you put the fluid, the pressure goes up. Initially it was thought when the pressure will go up, it will increase, but when the pressure goes up, it transmits to the veins around it, so it doesn't really impact the shifts of fluids over there. So this was the first. Again, when we look at the solute transport over there, and as science it tries to look at what are the barriers to transport. So this is one of the classic diagrams in which they try to think what the potential resistance is from the fluid layer inside the capillary, the endothelial cells, basement membrane, the interstitium over here, the mesothelial cells, and the fluid layer, and beyond the mesothelial cells. So it is seen that the first and the sixth, that is the fluid layers, which are stagnant fluid layers, they do not contribute to any resistance. Again, the mesothelial cell layer also does not contribute to any resistance. The resistance is given to some extent by the interstitial tissues, which is the submesothelial compact zones, as well as the main resistance is in the capillary levels at the endothelial cell level and the basement wall membrane over there. Again, the compact layer is made up of collagen and mucopolysaccharide. It's like a hydrogel. The fluids the water can flow through everything, but the proteinaceous material will flow only through the water phase. So this is how the scientists try to look at it over there. And again, science is what measurements. It again goes by the two basic principles when you look at solutes: diffusion and convection. These formulas look terrible, they are not so terrible. So when you're looking at the flux, that is a diffusive flux over there, or diffusion, it depends upon the constant, which is the diffusion constant, as well as the distance a molecule has to travel. Again, the diffusion will depend on the molecular weight, charge, and solubility over there. It will depend on the area. Over here we mean the effective peritoneal area and the difference in concentration. So this is what will drive the solutes by diffusion. Same way by convection, it is again, we look at the water flux which is occurring over here through the membrane, which is the flux. It will depend on the mean concentration and the factor which is called sigma, which is the reflection coefficient. So if the reflection coefficient is 1, it means the solute cannot pass, it will be reflected back. If it is 0, it means can pass freely. Most of the time we study these when we're looking at peritoneal, we look at these flows for the small molecules, urea, creatinine, and glucose kinetics, which we'll be discussing a bit. Initial model that came for this was the 2-pore model. So they felt that 2 pores, one is a small pore, 4 to 5 nanometer, which was responsible for the transport of small molecules, and there were large pores, which are around 15 nanometer, which was responsible for clearance of middle molecules. The problem with this model came that glucose has a reflection coefficient of 0.02 to 0.05, which is very minimal. So glucose should not be able to cause ultrafiltration unless until there exists a third pore. So it was predicted that there has to be a channel, and it was only later, somewhere in 1990s, that we were able to determine that yes, the ultra small pore actually exists, and these were the aquaphorins. These are anatomical equivalents of these. So small pores are interendothelial clefts with junctional complexes, and they have partial sealing properties. Large pores are also interendothelial clefts only, that's what people believe, but with wider diameters. They are more in the post-capillary venules over there. At one time, and they tend to increase when the peritoneum is inflamed or it is regenerating. At one time it was thought that there may be pores for transcytosis or transcellular channels, but predominantly these are interendothelial clefts only, and ultra-small pores are anatomically active. So this was the 3-pore model, which is most commonly considered as a membrane as a flat membrane. Pores are sort of rigid, and the mechanism of diffusion for small molecules is diffusion, macromolecules mainly convection, and the smallest pores is osmotic pressure, which helps to clear the water over there. Okay, so while 2-pore and 3-pore models were there, they had some limitations in them also. They considered peritoneum as a rigid, flat membrane. So now we know peritoneum is not flat, so the capillaries are sometimes much far. There's more subendothelial, submesothelial compact zone. Sometimes they're closer over there. So also it was realized that there's something called endothelial trichocalyx, which is a thin and delicate layer, which also contributes to prevention of or gives some resistance over there. So distributive models is a complementary model in which it takes the 3-pore model as the base, but it says the spatial distribution of capillaries as well as lymphatic drainage is taken into account, and peritoneal leakiness keeps on changing depending on the glycocalyx and neovascularization. So solute clearances, when we look at small and middle molecules, we look at what is the limit to which it crosses. As we know that small molecules. So when we look at the endothelium, up to middle molecules, that's beta to micron, there is no restriction. So they can pass through the pores completely. But clearances are not equivalent. So middle molecules will not clear as much because as we looked in the distributive model, they have to travel a bigger distance. They are bigger molecules, they will diffuse more slowly towards the pores over there. So small molecules have a faster clearances over there. And so middle molecule clearance will depend more on time. So longer dwells will have more middle molecule clearance, and that's why in a CAPD as compared to a nocturnal APD, the clearance will be high. Again, we sometimes discuss this, the transporters with a high average, low average, or sometimes fast average and slow transporters, and they are actually just a reflection of effective surface area of the membrane. Phosphorus is a unique molecule which is close to us. So it is a small molecule by weight, but it is very well hydrated. It's like an aqueous shell around it. So it behaves more like a middle molecule. It's often complex. So clearance behavior is somewhere between small and middle molecules. Protein bound solutes, overall clearance is low. At one time it was thought that they are bound to albumin, so with the albumin leakage they will be clear. But again it is found that albumin leakage doesn't really contribute much, so overall clearance is less. When we look at the clearances of solutes in peritoneal dialysis, we always consider it along with renal clearance because residual renal function plays a part. And this figure shows the clearance of urea, creatinine, phosphorus, beta-2-microbial, and pericresol. So when we look at urea, fast clearance, small molecule, creatinine similar, this. Phosphorus somewhere between the small and the middle, which we are discussing. Beta-2-microbial, again, the clearance from peritoneum is not huge. Despite no restriction sizes, and pericresol, a marker of large molecules, again the clearances are low over there. So, but whenever looking solute clearance, we have to look at both of them together. So, after solute clearance, the second thing we look is at the fluid kinetics, how the fluid transports around the peritoneal membrane. Again, in solute it was diffusion and convection, in fluid it is osmosis. So, in small pores, all the three osmotic pressures, hydrostatic, colloid and crystalloid osmotic pressures take place. Aquaporins just provide crystalloid osmotic pressure. They have 2% of the pores, but 50% of water movement is because of them. Again, it depends upon the effective surface area. So that means what is the distribution and density of the pores. It depends on the hydraulic conductance, LPS. So that formula on the left looks terrible. It is not that terrible. So again, LPS is your the hydraulic conductivity, which is a constant depending on the membrane characteristics. And when you multiply with S, which is the area, that gives you the conductance. And then it depends on the next is the P's are the pressure differences between the plasma and interstitial fluid, and alphas are the reflection coefficients, and the pi's over there are actually just the osmotic pressure shifts. So by this you can actually calculate that which type of dialysis you are using, whether it's icodextrin, dextrose, and how much with the same area you get the hydraulic pressures out over there, and hydraulic conductance. So that is the method of behind it. Again, the principle for the fluid kinetics mainly is the hyperosmolar dialysis, which is for the glucose-based solutions. Again, the gradient is, as we say, the reflection for by small pores is very minimal. For aquaporins, 100%. So this aquaporin, because it reflects the glucose completely, in the initial period creates a gradient for the water to move out by osmosis. This free water, electrolyte free water diffusion causes the initial water coming out in the peritoneum. It also leads to a drop in sodium concentration, which is called sodium sieving. And till the equilibration, this goes on. After that, gradually the reverse occurs. Then after 2 hours in a 1.36% exchange, the absorption. Icodextrin, on the other hand, is the other solution which we use commonly. It has a reflection coefficient of around 0.5, and the some molecules are really big, so it doesn't have sodium sieving, and because of that, electrolyte free water is not coming. Sodium is always, the removal of sodium is slightly better, which leads to better extracellular volume control by icodextrin based solutions. So these are the graphs that we always see: 1.36, 2.27, and 3.86. And these are timings when the accumulation occurs and the fluids will get to start reabsorbed later on. The 3.86 to 4.25% solution will have the longest effect. And the other side is the sodium sieving over time. So it is the maximum initially and then goes down with the degree of concentration. This is when we compare the 4.25% dextrose with icodextrin, and over I see that this low sodium sieving with icodextrin, and icodextrin, as the time keeps on going, osmotic gradient is maintained and more ultrafiltration occurs. So it is best effective it is used with more than 12 to 14 hours. So again, these are two type of graphs that we see when we look at the fluid kinetics. Actually, they reflect the same thing. They're no different. One is showing the total fluid that is being removed, the net fluid, and the contribution of small pores, aquaporins, large pores, and lymphatics. The other one is showing per minute. So the difference is that in the first graph you look, it seems as if the lymphatics drainage keeps on increasing, but actually it is a cumulative. So when you look at the second graph, you see the lymphatics and the large pore clearances are nearly constant, while most of the shifts are because of small pores and the aquaporins over here. So this was about the basics, how the fluid shifts occur over the fluid kinetics and solute clearance. So there are two practical things that we are looking for in dialysis. When the peritoneum is growing, there are certain long-term structural and functional changes that occur in the peritoneum. Peritoneal membrane injury occurs because of high dextrose solution, uremic state, acidic pH, GDPs, peritonitis, and predominantly leads to two things. One is the fibrosis, and the other is a new angiogenesis over there. So this is what is occurring, that the A is the normal peritoneum with the intact mesothelial cells, limited amount of collagen and the cells, and the beautiful vessels in the adipose tissue underlying. And over time, the mesothelial cells get degraded, this epithelial to mesenchymal transformation, this more collagen laying down, increasing this, and a lot of neovascularization which occurs over there in time. So the impact of these changes are that new angiogenesis will lead to an increase in effective surface area. So it will increase solute clearances, right? And there will be a reduction in ultrafiltration capacity because of fibrosis and reduced osmotic conductance of glucose because of the same process over there. So that was the physiology, what changes occur over time. Then is, of course, you try to design the PD solutions. I'll just go briefly because these will be discussed later. Predominantly, so traditional are the dextrose-based solutions, which are acidic, have a lactate buffer, acidic to prevent formation of GDPs, and lactate is converted to BiPAP. Those are classical solutions, but they have peritoneal and metabolic consequences. I will go further into these. Alternate solutions are amino acid based solutions as osmotic agents. They prevent the glucose toxicity, are thought to have nutritional supplementation, but amino acids can contribute to acidosis, and they are used very rarely now over there. Then are glucose based neutral pH solutions, which the Trivac solutions out over there, which remove one of the component, the acidity, but the glucose toxicity swing. And then is the icodextrin based solutions. Icodextrin a mixture 13 to 19 kilodalton with some larger fractions having a reflection quotient of nearly 1. So it gives prolonged removal of your prolonged osmosis and fluid removal. It helps out over there. But thing is that it can interfere with glucose estimation and glucometers. The other thing in solutions is the electrolyte concentrations. So you look at the sodium, potassium chloride, calcium, magnesium. They're close to the physiological plasma concentrations. Because they're close, so diffusion will be less, and the removal is mainly convective. So in a patient, if the sodium is 140 and PD is 132, so diffusive gradient is less, and mainly the convective clearances will occur. Calcium, you try to use lower calcium solutions to prevent or keep them calcium neutral. Magnesium, you will use 0.25 in a 1.36, but magnesium clearance will more in a 4.2, so you try to keep it slightly higher. So those are some of the changes that you will think. Again, in science is modalities of peritoneal dialysis. This, I think, so will be discussed in prescription later on, so I will not just, so this is just for completion's sake, that we have different ways of using, including tidal PD, in which there's a break point when the fluid is coming out, so you limit and you are able to get a better clearance out over there. I that we discussed. Then science also says measurement. Again, this will be discussed in adequacy, but just to touch on it, that you look at the small solute clearances by KT by V, weekly clearances, and large solute clearances. The surrogates like albumin, immunoglobulins, and alpha-2 macroglobulins can be used. They are more direct measures. You do the peritoneal equilibration test, which we'll discuss later. You look at ultrafiltration failure. And so these are outcomes. But as I said that I'll end, that is the science behind it. But probably what you're looking at is what is important for the patient out over there. And this is by the song. So the patient-associated outcomes are what is perhaps the art behind medicine, which has to be combined over there. And these are the outcome parameters you have to ultimately see. And I'll finish with that the art of medicine exists since time of primitive medicine. Science keeps on changing. But as I've said, what is the science of it, what's behind the science is actually the art of medicine. And I think so you have a lot of people who are here to tell the art of peritoneal dialysis. Stop over. Thank you.
Thank you, Rahul. Very good job. I'll just make one or two comments. One is the National PD program, which you mentioned. Both Narayan Prasad and myself are there in that government committee. There are a lot of loose ends still to be tied, and let's hope it starts very soon. As you have mentioned, there are currently 2 active players in the market, and so let's see how it will divide into zones, and then accordingly contracts will be given. Like hemodialysis, we know, there's so many groups, and they're doing a very good job overall. In PD, of course, it's a little more difficult, but let's hope it gets going. Regarding the science, I think he has done an excellent job regarding the physiology and solutions. So, a couple of things I'll just mention, which shortage of time probably couldn't address. One is the catheter evolution, which I think is a very important thing, and we have come a long way from initially just a straight catheter, maybe a single cuff, maybe 2 cuffs. The intraperitoneal part could be coiled, the extraperitoneal part could be a swan neck, so that itself is a big talk by itself. Kinetology, Dr. Balla mentioned about the OSET. I also have worked with OSETs, and I had that in my room for many years, till it got destroyed, to show it to our PD students or DM students. It was very cumbersome and it was very difficult, but that was one of the first steps taken to reduce the peritoneal desensitization, because there was very high level. It was a spike system over there. It was a simple spike, and the patient carried the bag here. In fact, when this PD program was made, I was surprised when that program, that literature circulated. What happens to copy paste? There is still written that is a spike and patient will carry a bag here. So obviously that has gone 30 years back. So from the O we came to Y, and now we are the twin bag system. Kinetology, of course, is the anti-system called Infectious. So different companies have little different systems regarding that. CAPD is very costly. The material itself, the solutions is just namak chini, there's nothing in it. Just salt and water. But then why is it so costly? So actually the bags. The bags is what makes it very costly. So, and that technology somehow we have still not been able to do so far, but maybe we'll be doing it soon. So the bags has also been a big evolution, the collapsible bags which have taken place. Icodextrin we are all using now. I was involved in initial researches which were done 50 years back, which were around locals. So icodextrin, we have papers on that. So I mean, there are many students here. So from where does icodextrin come? What is icodextrin and from where does it come? He wrote there, it degrades to maltose. So that is right. But then what is the source of icodextrin? He mentioned molecular weight also, he mentioned all that. Yes? Yeah, absolutely right. So it comes from cornstarch. So that also is not a very costly substance. Bhutta we all eat every day. But then somehow even the competition in that field has not been there, and so icodextrin was back then I think almost double almost that of routine bags. So there is a lot in science which he has covered very well, and I think subsequently we can discuss. Thank you, Rahul. I think you did a very good job. So I think we can proceed to the next session.
For the next session of the evening, on the topic of PD catheter insertion and its care, I would like to call upon the chairpersons, Dr. Neha Singh, Senior Consultant, Park Hospital, Gurgaon, and Dr. Nimish Gupta, Consultant, Department of Nephrology at Metro Hospital, Faridabad.
Our next eminent speaker is Dr. S.K. Panda, Senior Consultant and Head of Nephrology, Department of Nephrology, Army Base Hospital, Delhi Camp.
सर मैं तो खाली साइड से सर अभी सब फ्री है ठीक मैंने सो जाऊँगा मैं 4 बजे जा रहा हूँ सर
Good afternoon, everybody. Thank you, madam, for the kind words. Sorry.
और ऊपर एक once you start sitting what's the minimum rate? It will go up after some time. It will go up once you start sitting.
Sorry for the technical glitch, and as Murphy's law is caught up, whenever we try to do something technical, we do anticipate problems, and the more technology, the more problems. So, excuse me. So, after a little prolonged delay, greetings from Base Hospital, Delhi Camp and Department of Nephrology, where we run a PD first, modified PD first policy, and in a month maybe we do 10 insertions of PD catheter within the department. So, and I am grateful for the Dr. Kulder to allot me 45 minutes, knowing very well that this is the Achilles heel of the whole process. If the catheter is not functional and if it doesn't remain well, and then the whole process doesn't work. And between the nephrologists, when we look deeply into this aspect, there is no one correct method of insertion. It is what you are comfortable with and what you have been doing or trained with. So basically, I will be dwelling on that. I may go a little backward and forward, which may at times sound disjointed, but once we see the first video, everything else comes in place. So I'll be stopping in between and discussing the finer aspects, and then we can go on from there. So, are there any real contraindications to PD for a PD naive patient of CKD? I don't think so. So, unless he has intra-abdominal adhesions because of surgery, abdominal abscesses can be treated and the patients can be put on PD. Pleuroperitoneal shunts, you will never come to know unless you have put the patient on PD. Uncorrected abdominal hernias, nowadays all of them can be treated and the patients can be put on PD. Ischemic colitis and inflammatory bowel disease, if they are present, why not put the patient on PD if it is a CKD? So the next question which needs to be answered is when? When do you put a patient on PD? We all know it is that the whole thing is individualized between the nephrologist and the patient. What is his vascular access? When does he want to do the renal replacement therapy? The role of residual renal functions, and all these concepts of early start PD, incremental PD, delayed starts PD, it is all patient and the nephrologist specific. So now we come to another question, that who should be inserting the PD catheter? So a nephrologist, radiologist and a surgeon, all are doing PD catheters insertion. But if you read, there are enough number of papers, I have not even put them on, because which shows that a nephrologist putting a PD catheter is equivalent to a surgeon putting a PD catheter. And with the kind of technologies and the kind of adjuncts which will be coming in and are already in place, the results are near comparable. So at the start, I could also like that my PD training started in All India Institute of Medical Science, where under Professor Gupta and Professor Mahajan, I had a good number of exposures of doing PD catheters insertion by open technique as well as the percutaneous technique. And over a period, I have evolved, and I think everybody of us who was using these methods have evolved and have found that what is the good set of space for us to do this individually. Now, among the three techniques which I have been discussing today, I have just mentioned one hybrid technique. I have not mentioned the percutaneous technique because although we use the percutaneous insertion kits, almost all the nephrologists use the percutaneous insertion kits, the kits had certain lacunae which we all know. For example, if you don't incise give an incision and then come to the fascia and insert it, the guide wire gets stuck in the fascia. So the guide wire, when you remove the guide wire, you have a problem. When you are inserting the dilator or you are doing serial dilatation, the fascia and the thickness of penetration becomes so much that you have problems penetrating it. So the dilator gets flanged, and the peel away sheath which we introduce, as we will see, that it becomes curtained off. So there this technique fails and has got a learning curve. So knowing the instruments is one thing, that how they handle in your hand. The next important thing is that if you get trapped or you are in the middle of a procedure, you may have to escalate to the next level. That is the mini lab. And finally, the holy grail of this, what I come to at the end of my conclusion, that there is still one organ which we have not looked at, and why laparoscopy keeps on scoring above the other methods. That is, we have considered the peritoneum, we can consider the anatomy, which is here, we can consider adjuncts to putting the tube in its proper place, but we have forgotten that there is another organ sitting inside the abdomen, which is the omentum. The moment it is injured, it takes its own course of action, and that course of action is detrimental to PD, as is my experience over the last 10 to 12 years of putting PD catheters independently. And this is, and whatever I am going to tell today is not my own perception or anything I have built up on my own self. It is what I've learned from my teachers, my seniors, my colleagues, my juniors also, and the intervention radiologists, and as well as the net and the papers which everybody, whenever they get trapped in certain abnormal situations and they have published a case or published a spoken about certain instruments, I have taken it from that. And as sir was already telling, that PD needs a space, and the PD room in base hospital I just have shown, and this is the facility which we have at base hospital, where you can see that we have a full operating theatre, and we are cramped for space because we have got so much amount of equipment now. And as we'll go through the process, we'll see that the equipment is there. When you get fixed, it will help you, but it is not a necessity. So without that also, the PD can be done. So having a cautery, having the C-arm, and having an ultrasound all help. So let's start with the procedure, and I am sure that those days are gone where the DM and DNB students and us have not seen a PD set, have not seen a 10th catheter. So you know that it is a 42 centimeter straight catheter, which is the common catheter available. I'll discuss the 63 and the problems regarding that later. The set which you can see in the screen is a 42 centimeter straight catheter, which has got about a 15 centimeter intraperitoneal length. And why this intraperitoneal length is important, we will cover subsequently, along with a guide wire, a peel away sheet, and a dilator. And one thing which, as nephrologists, we will have to sooner or later agree to accept is handle our own instruments. We don't give care that a mosquito has a peaked end or has a thick end. It is for a vessel, and if it is not for a vessel. And if you have to reduce complications and make the process successful, then we need to know our own instruments, and we should care for them. So this is a tray which has been laid out, and it consists of the curved mosquito, small size, along with a Langenbach L-type retractors and local anesthesia, as well as a beaked small mosquito for making the pocket into the rectus abdominis muscle. So let's go through, play the video. I will stop the video in between to discuss a few final points. And as I am just mentioning that these are not over a period of evolution, this has come. So this is still, so this, I'll just stop the video for a second. So just 2 words about the patient. She is a 51-year-old female. She is a case of ADPKD and has reached end-stage kidney disease. She has 2 liters of urine output, but the creatinine is 10. And PD was offered for renal replacement therapy as she has become symptomatic now. Now, after proper counseling, consent, preparation, we'll deal with that subsequently also once the video is there so that everybody is interested and is on the same page. We have done the incision planning and we have done the exit site planning, which we have selected as infraumbilicus. We have measured that we have to be slightly lower because her height is 5 feet 7 inches, which is tall for a female. So we are just 3 to 4 centimeters below the umbilicus. And the patient has emptied her bladder, and we didn't need a Foley's catheter because she was able to empty her bladder, and we have checked it on the ultrasound. So this addition of this technology, if you have that ultrasound in the OT where you are checking the patient prior to EA so that the bladder is not full, one complication prevented. Secondly, you have there one more thing. As we go through this presentation, we will come to know that for PD insertions we have a glut or a lack of support from the instrument makers, from the device producers in India. So once we have marked the site where we need to operate, after due draping and painting and local anesthesia, we are making an incision. Now I will just hold here. See, as I was telling you about the instruments, I'm making a trade-off right now because I know that the scalpel which is coming with the set has to be used. So I'm using a 11 number stab knife which was designed for a percutaneous incision to make a linear incision into the skin, the subcutaneous fascia, right up till the rectus abdominis. So I have taken 2 or 3 attempts to change the angle. Now if I was a surgeon, I could have used a 10 blade for this purpose and reserved it for the purpose of stabbing where it is designed for. So this is somewhat we need to get out of this mentality if we have to progress. And what is exactly that is what I have shown. So I have a cautery helps. So as you can see, my surgical field will remain quite clear, cauterizing the 3 bleeders which I found, and a gentle dab of the swab will enough for me to clear the dissection and open up and reach up till the rectus sheath. Once I've done the blunt dissection, the Langenbachs are inserted to increase the surgical field, and I can see the rectus sheath. Because it's not directly vertical, the videos may not be very clear. Local anesthesia is given into the rectus sheath so that the patient can go. Now here, I will just like to stop again. The set comes with a needle. Most of us don't use that needle because that needle has a bevel and it will remain. We don't know while going in that whether we will hit a part of an intestine, a blood vessel or a peritoneum. So most of us, whoever does interventions taking from the vascular EA, we take a 16 gauge intracat because the intracat sheath, the needle remains only for a particular period of time. And here people have different experiences while penetrating, that they have found that they can use a Varies needle, but the Varies needle has to be unscrewed from the top, and then the edge of that needle, as we can see later, will still keep protruding inside the peritoneum cavity. So use of this device is as per the local training which you have got and how well you are comfortable with it. So once the patient is asked to stiffen the abdomen, and once this is there, the needle is in place. So because it's a closed cavity, some amount of this is just to make sure that the needle is in place. So one of the techniques is you suck. The other technique is that you fill saline into it, and the flow, as you will see, that should be very smooth. People have been filling 1.5 to 2 liters or thereafter saline to see that the anterior abdominal wall lifts up. But Abdomen is such a huge space that 1.5 liter will go into the flanks and still that ear will not lift up. Now here again, as I already mentioned, let's see if you can see I'm using a thermo guide wire, and the ones which I salvage out of the vascular procedures are reused here for 2 to 3 times. And the reason why I'm using a thermo, as I told you, that the coiled stainless steel wire which comes along with the kit gets trapped in the fascia, and many times when you pull it out, which you may have and each of us may have experienced, that it drags along. Once it drags along, it is of no use. It is an impediment, it may break, it may go into it. I have been after the Medtronic company that why are you giving it like this when the kits which are coming in India should have something like this which has to be more resilient if you want the procedure to be. The answer is always the same, it's the cost. That to bring the cost down, we have made it into the stainless steel, and the economics of effort is there. So we are providing a lesser cost gap. Now this guide wire, interestingly, is also very good for the peritoneum because the J tip is very, very malleable and it will not injure anything. While if you reverse, if it is not going in a straight line and then your approach into the peritoneum is a problem, and you think that by changing the direction, the other end of the catheter, the other end of this guide wire is very stiff, it may create a problem. So the ideal situation is that J tip should go in. And here now comes the role of the adjunct of a C-arm. Well, if you are in doubt, you can straight away inject contrast and see where your contrast is going. So just because of the, I was not able to master this technology of putting it in the right place. This is the flow of the saline. I am usually using 200 to 300 ml only. And if I have doubt, I straight away go. And why I am not using the C-arm? Because if you have used a C-arm, it has a continuous timing of 300 seconds. So I plan to use it when I think that I can have the maximum benefit or I get trapped. So here the catheter is, the guide wire is being inserted. It is a smooth insertion, and as in vascular we keep on wetting it because it's a hydrophilic guide wire. The passage is better if it is wet. So and the guide wire, I'm not worried about its position where it is going because the initial 4 to 5 centimeters of the guide wire is all I require. I have given local and it is my site of entry and my point of entry into the rectus sheath and to the rectus muscle. I'm trying to be as near as the midline so I'm not facing the bulk of the muscle. So with a 1-2 centimeter incision, now I take the dilator. The dilator is rolled over the guide wire and with a downward and with slight twisting action at the same time at the wrist. It is in the midline, so I am trying to do it in the midline, but exact midline, as I will tell you, is not correct. So with the midline and towards the ear, I am not putting it full, I am putting it for the next 3 or 4 centimeters and directing it towards the side where I require the catheter to be in. And just stop. Just a second to highlight few points again. I am using my left hand because I am used to holding the needles or operating from the both hands. Suggest that whoever a right-hander can change to the other side and introduce the catheter, introduce this dilatation from the other side. One important point over here is we have one size of dilator, which is 16 French, which comes away with the peel-away sheath. In foreign countries and even Medtronics makes available dilators which are of different size. So a little big dilatation in this case doesn't harm. One more small point regarding once my teacher told me that don't worry on the incisions. You can have a bigger incision better view, it's good to put catheters with bigger incision. But when you look on that once you can do things in a small hole, why do it in a bigger place? And the more you are using a smaller place, you are keeping the rest of the surface area available for future. So if you need to reinsert, you need to do a re-catheter, those spaces are available for you. So that's one small tip which was told to me, but as we got. Now the peel away sheath, which is 0.3 millimeters bigger than the dilator, is taken, but please don't have a twisting action on the peel away sheath, because then you will have the curtain effect. If it catches, the edge catches one of the fascia, it will bundle up. Now on the peel away sheath in the direction, I have removed the dilator. Now I'm checking that this is the direction in which into the pelvis my peel away sheath should be there. And this is the direction which I am now sure that the catheter will follow. So that red light which you see is the laser for the CR. The peel away sheet has been inserted, the catheter has been inserted, and here comes the operators, the assistants, that while it is smoothly being peeled up, he tries to put in as much as he can. So once that is inside, the clamp comes along with the catheter. So we just clamp it till the time we have seen that our homeostasis in the incision is correct, and the catheter also we are checking right now, because already we have that CM plan that it is going in the correct curve. And there are no kinks. We check the fluid which is drained out, that it has no fecal material, it is not frankly hemorrhagic, and the flat globules are present. And now is the critical step where we need to create a small pouch in the rectus sheath, below the rectus sheath in the muscle, where the internal cuff will lodge in. And as I speak, one of my teachers have also entered, So once the rectus sheath, see this takes time, and of the 15 minutes of the whole procedure, about 3 or 4 minutes were taken for me to create this space, go below into this pouch, and once you are there, you get a pop-up sound that you are in the space. So this is the learning curve that you have to be there. So once this is inside, this is where and at this point, if I'm not able to do, I should need to escalate. Now here is where I'm approaching the point of stitching. Now various papers, various center related studies all have told that if you take the stitch of with the cuff in between the stitch, 2 heads of the rectus sheath as well as a bite of the cuff, the torque on the catheter is less and the catheter moves less. So migration happens less. I don't believe it in, but however, being trained in that, I am still taking a stitch out of the cuff, both the rectus sheath along with the cuff. And at this point, I like to emphasize that little care is needed, otherwise you will nick the catheter. The plane looks little here, but I have control of the needle. I know that where it is going. So with proline I have taken so that there is no hernia, there is no leaks. The catheter is in place, and likewise it should not migrate. But that is not so. Many times it does, and the reason we will discuss. So without leaving any extra proline, I cut it off. Do the same procedure on the other side, because I have taken time to make the pocket go down as deep as possible, and insert the cuff into that. can use it with the needle holder also, but doing vascular procedures, I feel that the more control is there with the arm, hands, and you know what is the tension being exerted at the site, so I use my knee. Now we are creating the tunnel. Local anesthesia is given in the line where I had planned my exit site. I just weighted the Dacron cuff, and along the site I have put the tunneler. Local is given at the site when it needs to be brought out. A small incision is given, very small. And this is the time where you require a little bit of force to be applied with, because the one who pulls the catheter has not to increase the size of the incision so that the exit site is as small as possible and as lateral and down, facing downwards. So the catheter is mounted onto the guard, and at this point I have stitched the catheter. I have some amount of control, but I need to know that how much will he pull. If he pulls too much, the catheter may even come out. So that has to be, and if it is not settled, then you will have a kink. So here it goes that a little bit back and forth movement is required, and once it settles down, you can have a feel. So that feel cannot, like suddenly you had a feel and that the catheter is settled. And one more important point, that whenever we insert the catheter, we don't, here we are again checking the flow, that the catheter is flowing properly. And on the C-arm we have checked that it is into the pelvis and there are no kinks, it is smooth curve. The C-arm, and I followed it up with the stitching. This is done in the surgical manner. The next layer is closed opposite to the first layer, and it is with delayed absorbable sutures. So we use PDS as the surgeons could have done it. And this is, we have taken it from the surgeon. 2 or 3 stitches enough for a 2 centimeter incision. And finally, we are using staplers. Staplers are much simpler, less cumbersome, and easier to operate also, and saves time. And finally, we have checked the catheter, that the position is there. So one more important thing when we start the catheter, even if I have done 10 catheters, the intraperitoneal part is almost identical to the extraperitoneal part, and the holes are not visible very properly. So it is, while inserting them, it is important in surgery. They call it a stop moment, to stop and check that 2 people have checked that which catheter end is towards the business end. So we are not faced with any, that you have inserted the proper capillary, but you have inserted the wrong end of the catheter, and you have to reverse all the procedure because of that. So now we come, before I tell the next technique, since now with this in the background, we also can see that we have other options for the incision making. Besides the midline, which is the preferred incision, and where we are afraid of only the inferior epigastric artery, and if we stick to the midline, we are away from the inferior epigastric artery. But you can have variants, and over a period of time, I've seen that there are a lot of variants which have come up. And that's why having good instruments, that even if you call for help, you are able to clamp and wait for help. So that is also very important. And the next is that we all are aware of the McBurney's point and the inverse on the other side, just medial to the McBurney's point. So that is the paramedian incision. What is important is that in the second diagram we can see that the muscles in that part are 3 muscles: external oblique, internal oblique, and the transverse abdominis muscle, along with its fascia. These muscles are all very bunched up together, and the Langer's line all meet towards the pelvis from outside to inside. Langer's lines are those lines along which we make an incision, and the healing process are better because the collagen fibers are so arranged. So if you are making a paramedian incision, so what is known as a lens incision, in that case if you make a curvilinear incision and away from the midline, we are safer because inferior epigastric artery is medial. So unfortunately, if we have to do this with certain amount of certainty and reproducibility, some amount of surgical anatomy has to be known. Now, enough number of papers have been produced by different centers that where to tie the cuff, whether it is within the rectus sheath, whether it is within the peritoneum. So everybody is using a different method. If you are going deeper, you will require a deeper exposure. That much is very clear. And deeper exposure means the anatomical field, as we will see in the next video, which is from Seoul, that why the deeper exposure and the clear anatomical field for going anything is required. This is one sad part which I am also not doing, because I have only two choices of catheter, and I know that I have 62 centimeters and 42 centimeters. 62 point. This is the planning of the site. It should be done in the standing position, and it should be stenciled onto the patient, so that this operative field remains when you take the patient to the OT and you are very clear that what you are going to do. But with two sizes of catheter and only centimeters to play in, I do it on the table. I am not doing it in a standing position. But the exit site planning is very important if the catheter has to last, so that you know that the handedness of the patient, the cognitive balance, the other things are also taken care, so that the patient is able to take care maximally of the catheter themselves. Now coming to the second video, this is from Seoul University. I didn't have a time to select a patient for this. So this is what they have done. I will give you the plate. They are doing it in a male who is slightly obese. Here, as you can see, in the paramedian position, in the lens incision, they are doing giving local anesthesia and just giving a curvilinear incision in the Langer's line. They have better instruments. They have a bipolar cautery with cutting. So they have gone through the initial layers, infiltrated directly onto the muscle, and given a neck, splitted the muscle and the fascia around it. Here. All this muscle, as we will see later, are in a bunch, so they are not really thick. The rectus abdominis can be thick, because if you are not in the midline, you may even face going up to 2 to 3 centimeters deeper. So here they have cut out, splitted through the muscle. They have not cut the muscle, they are splitting through the muscle, and they are using, now the C-type retractors were used deep into the muscle. They are using the L-type of retractor. So knowing your instruments and the planes will be also here. They have reached the transversalis fascia. They will lift it up. And they give a small nick into it. And you can see the peritoneum below it. So however, they will again expand the incision. Now you see A2 and taking a bite into the fascia along with the peritoneum and a purse string suture. There we were ending with 2 sutures, not at this big field of exposure, similar outcomes. Here, but the differences will come later as we, so once they have taken this purse string sutures, and they will be leaving out the mosquito forceps for their plane. The catheter is simply treated into the hole, and the purse string is closed below the cuff. Now the rectus, the external oblique muscles are allowed to fall back onto the suture, and a hole is made into it. And the second cuff is again treated through this hole, and then they bring it out laterally in the same manner in which we do. And they are being using skin tapes and fibrin glue, which is not available to here, but it's a good idea that if we have this, instead of taking sutures, we can use the fibrin glue inside. So the important thing which they have and we don't have is the length of the catheter. It should be intraperitoneal. So we have very little area to play, and they have good amount of catheters and adjuncts, so they know that exactly what length they are important. Now between the two process, if we see that one slight differences rises up. In first, I have no control that whether I am piercing the omentum or going through it. Here, because he's lifting the peritoneum and he's gliding the catheter over the peritoneum. So the omental injury is less. Now we come to the next technique, which obviously has to be under GA, and taking a patient, nephrology patient, and getting hold of the OT, getting hold of a surgeon who's ready to do it with you, because he's asked what I have to do, because they are also not trained. So I'll just briefly here, but this technique is the future, because one thing which is happening is the creation of pneumoperitoneum. The creation of pneumoperitoneum, I've realized, pushes the omentum down, and you have a clear field, and you are not injuring the omentum anywhere, so that the catheter can wrap around it and migrate it. And this is where the EA is, and the initial success of the laparoscopic technique stands out. So around the umbilicus, they use their camera port, and nowadays the good laparoscopic surgeons, they give a curvilinear incision around the umbilicus, lift up the rectus sheath, and as you can see, these instruments are built to only 2 companies make them, so they are absolutely wonderful instruments to insert. So one sir was telling that we insert acute PD. Now acute PD was based on a stiff catheter with a stillet. So this comes with such a good stillet that it just goes through the ear without any problem. And once it goes in and you have just pulled it back, you have filled the peritoneum with gas, but that in CKD patients does have complications, and you will have the anesthetist on your back. How much time? The BP is shooting, the BP is coming down, this is happening, ventilation is not going through. And these are the patients which we put for the laparoscopy. They are obese, they have difficulty. So otherwise the instrument is pretty much simple. You will at least require 3 ports. One is 7 mm port. If we realize our catheters are 5 mm thick, so they easily go through a 7 mm catheter, and there is a grappler which you can hold the catheter and pull it inside and push it into the above the bladder, into the pelvis, without doing anything to the omentum. However, there is a problem that as soon as this catheter goes in, there is a potential space and gas starts leaking out. And the advantages go, and they want early closure. So the surgeons are more used to using clips rather than sutures along with this needle holder which is there. So, and with the gas coming down, there is a technical difficulty that you have to be very good and practiced, so that you can take the cuff, and this time the cuff is sutured inside the peritoneum. It is not external. So to remove it, also you'll have to reverse the process. So that is a drawback. And the second thing, that once the trocar is out, the port is out, this gas can even leak subcutaneously, so destroying those planes. So this is one big challenge along with this. Now, a lot has been told about omentoplexy, but I have not seen it, and never have been able to convince a surgeon to do it, because the first thing is that where I will hike the ear and which part of omentum I will take the stitch from, and telling me that if this acts as a volvulus site, then the intestine may turn around it. So the only thing where it scores and routinely scores, and for Indian patients, I mean, the jury is still out, but still I also feel that we have more subcutaneous fat and we have more visceral fat for the same BMI compared to the. So laparoscopic way is one way forward, where we can have greater catheter success without more harm. Now this is a part which, again, as I told you, I will be going back and forth, which is not looked into much, but very important, that if you have good bowel preparation and the bowel are moving, the catheter relocates to the pelvis. Scrub bath, mucurocin, antibiotics, bladder empty, light breakfast, because we don't know when our patient goes, and mostly we are doing it under local. But if it is a GA based procedure or you are converting, then best to stay neurally, or we face the wrath of the anesthetist, which I can understand going to the OTs, what the surgeons feel like. And dialysis, if you are doing it on the same day, it should be heparin free. Now, as we have lots of things have been told about the catheter design, but again, no study. It can be a center-wise study where everybody has experienced that somebody has better outcomes with a coiled catheter, somebody has better outcomes with a straight catheter. So, or with a swan neck catheter, or with a Missouri catheter, or with a Zillerman variant of that catheter. They keep on adding more gadgets or devices to the catheter. But one thing is definitely there, with the coiled catheter which we have, it will be better if we deploy it over a stillet. So once the sheath is inside, as I will show you, and Medtronic, only when demanded, supplies this stillet, the catheter can be straightened out. And as of today, I am very sorry that there is no catheter in Delhi. I have one set and I have to use it on a patient. But to open and show you a set, I don't have it. This catheter has one peculiarity that at 20.5 centimeters, it takes that coil starts. So where you are deploying of the sheath, it is possible for the catheter to go in. But once it goes in and it takes a wrong turn, it can, the further progression may be a problem. So like a balloon deploying over the stillet and gently withdrawing the stillet is an answer. So this, as of this debate will always be there about the catheter design. And everybody comes up with that, and unfortunately, we are not made. Indian nephrologists, they are not interested in us participating in any of the catheter designs. So, to make life simpler, these are few of the adjuncts. As people have been using, I am using a 16 gauge cannula to create that ascites. You can use a Veris needle. But remember that Veris needle has to be metallic because it can be screwed out. The disposable one cannot be screwed out. And this is the 62 centimeters stillet which is available. The roll of fluoroscopy you have already seen, also the hydrophilic wires. Now this is something which is not available to us. On the left hand side of the image you can see that is a Missouri catheter with a 20 centimeter intraperitoneal length. But they want to do a insertion which is quite up. So they have something known as a two-way connectors. These are connectors, and when you cut two catheters and you can join it over the connector. And then the technique remains the same. So you are now positioned for success because you are going intraperitoneal, not extraperitoneal on it. The next you can see that these are devices which have less amount of curtaining effect. The sheath will roll back on itself if not properly inserted. So in this device has been developed by Quinton based on based on things which we are devised in Korea, and this gives us that entry, but then this entry comes at a year because you can see the trocar which is very rigid. It may puncture. Last few slides which are important, we may have complications. That much is clear. So if we have functional catheters of around 80%, less than 20% are non-functional, that is very good. Significant hemorrhages, exit and exit site infection, peritonitis, bowel perforation, bladder perforation, hernias, and leaks. I'll just dwell on the functional problems, which as per the literature and as per the various studies which are gone through are in the terms of 30 to 40%. And this functional progression is primarily because of one factor of migration. Even if I've done everything well, in a hybrid insertion, migration still remains a problem. Kinking, you can see it on table with the fluoroscope and remove it. Blocks, fibrin clots, this can be, we obviously insert heparin into the catheter, so the blocks and are not formed. And if necessary, you can use tenecteplase for fibrinolysis. Breaks and subcutaneous placement, if you are very clear of the planes, are very unlikely. So the only thing which we deal it is with migrations. So if you are a migrated catheter, what is the best way to do it? I prefer that the catheter has a memory, the longer it stays. So the earlier you have a migrated patient, we reposition the catheter, reinsert the catheter. Cost definitely adds on to the issue. But the fibrosis is less and the catheter memory has still not settled. So how do you do it? There are many techniques. One of them is that the same catheter can be replaced. For this you require the special disposable peel away so that you are not opening a new catheter. So you reverse all the procedures which you have done, pull the cuff back, find the first sheath, find the first exit port and insert your guide wire. The catheter is out, then redo the dilatation and re-put the catheter in the same manner. You can change the catheter design, you can change the catheter site, you can change the fresh, you can use a fresh catheter source. Removal of catheter technically for me is the most difficult time, especially if the catheter has passed the length of time and if repeated episodes of peritonitis have occurred. The same procedures are reversed and we don't keep, I myself don't give notes that how I have inserted a peritoneal catheter. So they don't, the removing surgeon doesn't know where the sutures and where the non-absorbable sutures are lying. And the catheter becomes very friable. I just heard madam telling about plastics and other things, but the technology has not changed. For the last 30 years, it is the silicone and nothing better has come out. So this is a small video about the same patient. The next day of the insertion when we did the flushing and we are doing the catheter care. And I'm just, sorry sir, I'll take 2 more minutes, just ending up. At the same time he's doing the training and so this is basically reinforcement and as sir told, the son is also standing in attendance. Yeah. So the way forward, I think, as nephrologists, we need to take up laparoscopy as the next challenge level. The reason is the instruments are there, the methods are very formulated, and mannequins are available for the training, which is not there for any other purpose. We don't have a percutaneous exact mannequin which is available for training. Insertion kits have to be better and we don't have access to foreign kits. Only 2 kits are available in India. There is a learning curve and the better catheters need to be available. Thank you so much for patient hearing. Any questions?
Thank you sir for such a meticulous talk and such a beautiful display of the video and all the complications. So I think so because of paucity of time we move forward and we can take questions in the end. I think there will be a lot of questions but we'll take in the end.
For the next session on PD adequacy, I would like to call forward the chairperson, Dr. Vishal Singh, HOD Department of Nephrology at Army Research and Referral Hospital, New Delhi, and Dr. Saket, Senior Consultant Department of Nephrology at Metro Hospital, Faridabad.
Thank you everyone. I would like to welcome our next speaker, Dr. Renal. I think all of us know this young and dynamic nephrologist. He is a senior consultant at Sir Gangaram Hospital and he'll deliver the talk on PD adequacy. Thank you, Dr. Renal.
What we'll do is we'll disperse for tea after this and then join back for panel discussion.
Thank you, Sagar, for this introduction here. And today and I think it's a very important thing that we discuss about this topic. And why I've put adequacy and inverted commas is, you will see when I go through the flow of events. But before that, let's look at this gentleman over here, William Osler, who has given us a lot in medicine. And he has said very importantly that you should listen to your patient, because that's where you're going to find your diagnosis. And when you go ahead, you'll understand why we're talking about this. So today, ladies and gentlemen, I'm going to talk to you about adequacy of PD. Then I'm going to let you go off the term adequacy in PD. I'm going to let you understand what goal-directed PD is. We'll talk a little bit about the ISPD practice recommendations 2020, and then I'll conclude. So what exactly is adequacy of peritoneal dialysis? So does it involve solute removal? Is it to do with nutrition? Is it to do with fluid balance? Or is it just a 24-hour dialysis process that has nothing to do with anything that we are going to discuss today? Or is it just guidelines, and guidelines? So to take you through, let's go to the background of this study, which is a landmark trial, which is called the CANUSA study, and that's where it all started from. To take it back in perspective, let me introduce and tell you that peritoneal dialysis actually started before hemodialysis, but unfortunately peritoneal dialysis didn't do well, and hemodialysis went above peritoneal dialysis only because of the fact that there were too many associated complications with peritoneal dialysis. So the CANUSA study for the first time told us and guided us that it was the solute clearance, that is the renal and the peritoneal together, not just the renal, not just the peritoneal. And they showed in that study that for every 0.1 unit increase in KT by V, there was a 6% reduction in the relative risk of death. It also did show that solute clearance was also correlated with creatinine clearance, and that for every increase in 5 liters per 1.73 meters per body surface area of creatinine clearance, there was a 7% decrease in the relative risk of death. So then what do you do then? Do you keep on increasing the KT by V? Do you keep on increasing the creatinine clearance? Well, you had another study which came April in the same year itself, which was called as the ADAMEX study. And here they showed, and they again told us that it was both the urea as well as the fluid removal. So here the point is the fluid removal that is important, because they looked at people who were Mexican population. They also looked at higher volumes of exchanges, and they did prove that if you had a higher volume of exchange, then you could achieve better adequacy in your patients. And then came the Hong Kong trial, which said nothing doing. It doesn't make a difference what's the volume of exchange that you do. What is important is the fact that you should not hit the KT by V above a particular value. So they showed very clearly over here that the KT by V of 1.7 to 2 was the area where they studied the patients, and they found that this was the area that you should look at. So what is the exact KT by V that we are actually talking about? So the KDOKI looked at all of this data and they said, okay, now let's just keep the lowest possible KT by V as the PD adequacy target, and they said the KT by V of 1.7 per week that's the weekly KT by V is the definition for PD adequacy. So then they did an analysis again and they said, is that all? This is just the KT by V which is in PD adequacy. And they reanalyzed the data of the CANUSA study. And they found that it was not just the solute clearance or the KT by V, it was also the residual renal function. That is the amount of urine produced by the patient, because it was seen that all these solutes that were excreted in the urine had a good survival advantage for the patients as compared to the patients who had lesser residual renal function. So for every 250 ml increase in the urine, you could achieve better adequacy and you could have a lesser relative risk of death, and over here it's about 36%. So now I'll just take you through this slides, which is given in Dugri Dastu, and this is about how you calculate the adequacy in your patients, and then we'll see why this is important, why it's not. So when you're looking at your prescription, first you have to choose and you have to say, okay, fine. There's a definition that says 1.7 KT by V. How do I achieve my 1.7 KT by V? So to calculate KT by V, you have to have KT, which is the total KT, which is the peritoneal KT plus the renal KT. So the peritoneal KT is calculated by collecting your peritoneal dialysate fluid over a period of 24 hours, and then you measure the urea concentration in the dialysate. And then you estimate the total urea content with this formula, which is the total urea concentration and the volume of the e-fluid. So peritoneal KT is the urea content in this dialysate divided by the serum urea level. Then you go ahead and you do the renal KT exactly in the same way, but here you do a 24 hours collection of urine, and you measure the urea concentration in the urine, and similarly you calculate the renal KT. So the volume that you have to assess in your patient will be done by the Watson formula, and this formula is also given very well. So once you've done all of this, you have your KT by V, and now you also need to know the creatinine clearance, because now the Canusa study has said, and there are other studies too which have said, that you have to aim at a minimum of 5 liters increase. You have to hit a value of 50. So the creatinine clearance, total creatinine clearance, which is corrected for 1.73 body surface area, has to be calculated with the peritoneal creatinine clearance plus the renal creatinine clearance. The peritoneal creatinine clearance again involves a peritoneal dialysis collection of fluid over 24 hours, and you see the creatinine content and divided by the serum creatinine. And the renal creatinine clearance is a half of 24 hours urine creatinine content divided by the serum creatinine, and you add it to the 24 hours urine urea nitrogen content and divided by the serum urea nitrogen. So body surface area is then calculated, and then you have your own, you define and you decide for your patients how you're going to hit the value of 1.7 kT by V, which I don't think is it's not a very achievable thing for most of our patients with the kind of facilities that we have and the kind of nutritional parameters that we have in the patients. So there are several other factors which determine clearances in peritoneal dialysis patients and will obviously affect the PD adequacy. Apart from the fact that we talked about creatinine clearance, residual renal function, there is also a concept of the peritoneal transport characteristics. So you have high transporters, you have low transporters, and they will have a different goal of KT by V. The body size is very important. You can't have a standard definition depending on a standard body size. So depending on the body size, your goals will keep on changing. Apart from that, the kind of modality that you have in your peritoneal dialysis, whether it's a CAPD or whether it's APD, you are going to be having different prescription factors that are going to be taking care of your adequacy goals. So frequency of exchanges, what is going to be the dwell volume, a higher dwell volume, lower dwell volume depending on the peritoneal characteristics, as well as what is the tonicity of the dialysis solution. APD, it gets a little bit more complicated because here you have to calculate the number of dwells. You also have to calculate how much dwell you want per dwell, what is the volume, what is the tonicity that you're going to be calculating. There are going to be two tonicity bags which are available, 1.36%, 2.5%. What is the time on cycler, what is the frequency that you want to put on the cycler, and what is the tonicity of the cycler solution. So this is a very, very concentrated slide on the kind of recommendations that have been made, but you will see here that the recommendations are mostly around what we've discussed till now, which is the total KT by V, with the Australian guidelines saying that even up to 1.6 is okay. But then when you look at the creatinine clearance, I think that's where they make it up for. They say that you need a creatinine clearance of at least 60 for high transporters and at least 50 for low average transporters. But what we understand from the guidelines here is, I think in our patients, we don't have our guidelines, but I think what we should aim in our patients is at least a KT by V of about 1.7 and a creatinine clearance of at least 45 to 50 liters per 1.73 meters per body surface area. You should also be looking at the ultrafiltration or the residual renal function in your patients. So if you have more than 750, you should have an ultrafiltration of at least more than 750 ml for anuric patients and more than 250 ml for patients with residual renal function, which is calculated by the volume of urine excreted by a patient. So how do you actually achieve adequacy in your PD patients? Going back again, we've discussed about solute, we've talked about fluid, we've talked about some guidelines, we've also talked about APD, 24 hours dialysis. So, but what is important here when you're looking and hitting at a good dialysis, CAPD, and looking at adequacy, is this slide over here, which talks to you about the fluid management. So the goal is actually to achieve a normal fluid status in your patients, and you have to look at both the urine volume as well as the ultrafiltration. And why is this value of less than 750 ml so important? Because it has been shown that anything less than 750 ml per day of ultrafiltration in an anuric patient correlates with actually a poor survival. Hypertension is a very important marker of PD adequacy. So if you have hypertension in your patients, then obviously you have a volume overloaded state, and so you don't have a well adequacy in your patients. So there is no mention over here of the parameters that we've talked about before, and that is the reason why I will just take you further in the slide. So the guidelines again is to look at your volume status of your patients, look at the PET status. You should protect the residual renal function. There should be good counseling of your patients regarding appropriate salt and water intake. You can use loop diuretics to induce more urine so that you have more residual urine function and get more solute excretion, better adequacy. Enhanced compliance, very, very important. You have to educate your patients so that they are very, very compliant with the kind of exchanges that they're doing, because you will not be able to assess the adequacy adequately if you don't have a patient who's compliant to the prescription. Apart from that, very good hyperglycemic control, because most of the PD solutions that we have, in fact all the PD solutions except for the icodextrin that we have is actually all glucose-based solutions. So if you don't control the blood sugars well, then it's going to really impair with the ultrafiltration. So this is a very small slide about what you're going to do with your patients to achieve adequate ultrafiltration, especially in the long well. So the long well is anything above 8 hours. So if you have a high transport status, you should try to use the daytime dwells, shorter daytime dwells, so they can get more solute clearance as well as ultrafiltration. And if you have a patient who is a low transporter, you should either increase the dextrose solution, which is not going to be good for your peritoneal membrane, or you can increase the fluid volume, the fill volume of your patients. Unfortunately, we just have 2 liters bags and we can't do that. And in patients who have an ultrafiltration problem in short dwells, and if they have a high transporter status, you should try to move these patients to either APD or maybe increase the number of exchanges like we discussed before. And in case of low transporters, you can increase the total time on therapy, or you can also consider increase in the fill volume, exactly as before. So moving on further, what else is going to tell us about the adequacy is anemia control. It's been very well defined by KDOKI, whether it's hemodialysis or peritoneal dialysis. You have to aim in your patients for adequate, for assessing the adequacy with a hemoglobin of at least 11 to 12 and not to go above 13 even with erythropoiesis stimulating agents or with the newer agents. Apart from that, you should also be aiming at looking at the mineral and bone health of your patients. And there are good guidelines, we'll not go through that. Apart from that, nutrition is very important, and this is what was left when we looked at that pictorial right in the beginning. So you should be assessing the nutritional indices to assess PD adequacy by any of these parameters. But I think what is important and what is more simple over here is to look at the serum albumin of your patient on a day-to-day basis in patients that come to your clinic. You should be using different agents so that you can increase their appetite, and also try to see whether their nutritional parameters and their interventions are actually correlating into some outcomes by looking at the subjective global assessment. Apart from that, it is also important to at least aim for a protein intake of at least 1.2 grams per kg per day, and once you achieve that, only then you should move to about 1.3 grams per kg per day. As well as the caloric intake has to be a minimum of at least 35 kilocalories per kg per day, per body weight per day, in patients who are less than 60, and between 30 to 35 kilocalories per kg per day if 60 years or above. So all of this has been put into the PD adequacy goals. Also, there is this slide I think was very important, because this tells us, this is the question that's asked by most of the examiners, especially when I was taking my exam. I was asked this question: what is the amount of glucose content and how much glucose will be given to your body? So as you see, as the bags are increasing in tonicity, you will see that even up to 60 grams of glucose can be given per exchange for a 6-hour dwell with a 2-liter bag with these kind of solutions. So to summarize, adequacy of PD is to maximize well-being, to minimize morbidity, and it's not just simply a target dose and clearance. Well, that's not the end of it. So now we move on to something which is called as the new age adequacy. So the new age adequacy says that there is nothing called as adequacy, and that you should be looking at centered goals. So patient-centered goals are very important, because of the fact that we still have very less evidence that says that KT by V of 1.7 is actually going to be very good for your patients. In fact, there are countries where reimbursements are not given to the companies or to hospitals, especially if they don't record a KT by V of 1.7 or more. And when you look at this questionnaire that was floated all across the world about what was the top 10 outcomes when we're looking at KT caregiver priorities, that is, when you're looking at me, when you're looking at the patient, where does KT by V come over here? Which of these outcomes is actually related to KT by V? You see over there, it's just that much part over there. So I think we have to move further from PD adequacy to the fact that you have to understand something called as a goal-directed PD, which is the most important thing nowadays, which actually is shared decision making between patient and care team. And this is to establish realistic care goals to allow the patient to meet his or her own life goals and allow the clinician to provide individualized, high-quality dialysis care. It engulfs a lot of things, which is either directly affected by dialysis treatment or not directly affected by dialysis treatment. But what is important is to look at these guidelines over here, which have been just given by the International Society of Peritoneal Dialysis on prescribing high-quality, goal-directed peritoneal dialysis. So what is important is not just to look at the guidelines as such, because they also say very clearly that you should look at the volume status, you should look at the nutritional status, the small solute clearance, and also what is important is the quality of life. So we're not looking at things like KT by V, not looking at things like creatinine clearance anymore. We're looking at the symptoms of patients, we're looking at the volume control, and we're looking at the nutrition. If with all this, you're reaching a point where your patient is happy and you're happy, and he's well nourished, then I think you should not change the prescription. And especially so, this is important in patients who are old or frail or have a very poor prognosis. You cannot just keep on aiming at numbers of KT by V of 1.7. You would like to bring down the goals and reduce the dialysis prescription in these patients, especially so in patients who are from the low or middle income countries. So these are patients who are not going to be able to afford PD to the fullest. So you will make some changes in their prescription. For example, look at this patient over here, who's a 74-year-old patient with myeloma. He's got AKI and he has a very low GFR. Now the problem with him is that his wife is from Kerala and he wants to keep on meeting her, and he says, I want to do that on the weekend. So what do? You ask the patient what do they want to do, and the decision is to start the CAPD with 3 exchanges but just 6 days a week. So on the 7th day you keep it free. Now if you do this, you're not going to be achieving a KT by V of 1.7, but I'm sure you'll be achieving some good quality of life. This is a very, very busy slide here. I just wanted to tell you that this is available on the Peritoneal Dialysis International. I think you should look at it, because if you get a question in your exam on goal-directed PD, you should be able to reproduce at least 40% of what is said over here, which talks about the potential elements that you have to consider. Most of the things that we discussed today, what are the potential interventions that you should do in your patients using solutions, PD exchange modalities, which we'll be discussing later on in this curriculum today. And also important is to evaluate your goals again and again, not just with numbers, but also looking at how your patients are doing, whether they're failing to thrive. Try to assess how they're failing to thrive. Is it because of volume control problems, solute removal problem, and then and this is the way I think the world is going to be taking leaps forward, is to first look at the adequacy guidelines, looking at small solute removal, ultrafiltration, and then important is shared decision making. You should look at your local resources, and you have to look at high quality PD apart from PD adequacy or goal directed PD, and you have to look at also the people who are the children, pediatric population at least, in which it is very difficult to achieve a KT by V of even 1.5. In the end, ladies and gentlemen, always observe. This is can anybody just recognize what this is? So this is Pasteur. Yeah, Pasteur. So he's just observing, and he's just looking at the changes after he's given the vaccine, and that's where I think we should all end it. We should keep on observing, and then we should and direct yourself towards a good PD for your patients. Thank you very much.
He's covered all the points. Just remember one thing, don't chase your adequacy. That's the most important thing. Sometimes what happens is in APD, we increase the number of cycles. Please remember, the inflow and the outflow takes about 20 minutes. So if you increase the number of cycles, your dwell time is actually going to come down.
Thank you, Dr. Renal. That was a wonderful talk. I think one thing, like many of us are young in the room here, if you've not done a PD prescription, we're going to cover PD prescriptions and incremental PD. all these formulae, all these signs, some of these numbers you have to remember. Like for your hemodialysis, what is the single pool KT by V, and how you are calculating your standardized KT by Vs. These numbers are a good guide to starting your PD prescription when your patient is new. The effect of residual renal function, that can play a very huge role in the incidental PD patients, and you cannot ignore that. For example, like I don't know if anybody knows, the contribution of GFR, 1 ml per minute, is almost to the tune of 0.2 KT by V standardized per week. So imagine if you're trying to hit 1.8 and your residual renal function is there, you can achieve maybe even half the clearance you want through the residual renal function. So you have to learn a few formulae, you have to keep a few numbers in mind so that you can learn how do you start a patient, what is the impact of renal function, and how then on to incremental PD. I'm sure Dr. Huller will cover a lot of these in the next few sessions, and maybe we can have like a 10-minute workshop for the students, how to start prescribing, give them numbers and say like, for those things you have to know the PD adequacy numbers as well. Thank you, Doctor.
Thank you, Vinod. That was excellent, as expected. So let's vote. Tea now or after the panel discussion? So raise your hands, please. Tea now or? So Dr. General Verma wins. So we'll have the panel discussion now and then discuss. So, yeah, please.
Panel discussion, I would like to call forward Lieutenant General Dr. P.P. Verma, who is the Director at Department of Nephrology at Venkateshwara Hospital, New Delhi. I would like to call forward Dr. Professor Dinesh Kuller, sir, and all the other speakers of this session to please come on the stage.
So we have call upon stage Professor Billa, Rahul Grover, Vinod, and Dr. Panda. Please, General Verma is already here. So, I'm sure you'll all agree, we've had some excellent discussion about starting from the basics to what we are wanting to achieve via effective peritoneal dialysis. So I would want to reiterate that this program of today is basically keeping in focus the needs of the budding nephrologist, and we, as I said, as I promised at the outset, it will be the brass tacks. So basically, we will just initiate you and again mentioning that word again, reinvigorating peritoneal dialysis, because it certainly needs that use. So I'm sure you've been enlightened. You have the basics in the that session preceding the didactic talks. You had access to how to set up the peritoneal dialysis exchange. So I'm sure the kind of interest which is going to get generated with today's discussion and what you learned from today, all the youngsters, you are definitely going to become passionate about peritoneal dialysis. I can tell you that, and especially when over the years you encounter great results, I think your passion will certainly get enhanced further and further. So I think before we begin, so we, as you can see, are little disappointed, as you can see from where we have reached. There was a lot of excitement when finally twin bags became available to us, and the numbers grew. And at one point in time, we were told there were good about 9,000 patients on peritoneal dialysis across the country. So why did the numbers not grow up further? Why has actually there been a decline? Is it because hemodialysis became more accessible, became more popular, or are there few factors other than that what may not actually be known to many of us? With that in mind, may I begin the discussion by asking Dr. Balla, why do you believe PD has not been successful.
Yeah, the same question, but before I say that, it's very encouraging that 7 of Army nephrologists are sitting here. And I must say that PD is very, very popular in armed forces. As a matter of fact, this is a record that there are more patients on PD in armed forces than on HT. It may be a news to many. We were just compiling a data on nephrology services in armed forces, and it was a surprise to me also that even today there are more patients on PD in armed forces than on HT. The PD services, if I look at it, Army, we are pioneer in PD. Started way back in 60s. Just for historical interest, Dr. Akhil Mishra possibly is the first nephrologist who had a dissertation on PD in 1969 at AFMC. And he took 20 cases of PD, of 20 cases of AKI, and gave PD to them. So that is as old as that. And as you rightly said, globally, I think till 8 years back, 7 years back, 11% of the global population was on PD. Today, this figure is reduced to 7%. In US today, only 7% population is on PD. As you rightly said, why this has happened? Because there has been some advances in the equipment, in flu, in delivery system, but why it has dropped? I think Dr. Bhalla.
So you already have answered part 3 in the sense that already that hemodialysis is a very, very established procedure from the day renal replacement therapy, chronic dialysis. So for chronic dialysis, hemodialysis is established procedures over the last almost 6-7 decades. As you said, US, so it was varying from 11 to 14% maximum, and now it is again less than 10%. So same story happened in India also. So maximum went to almost maybe 11 or 11%, and now it is down to 5%. So now what Dr. Kuller has asked, that is a very, very pertinent question. So why this decline in the adopting PD as a renal replacement therapy? There are various factors. So number one factor is how you are trained. So if you see the training, in your training there are hardly few centers which actually have proper PD as a modality of renal replacement therapy. So there are very few centers, only bigger center, and that ideally it should be in every government hospital, but it is not there. And in private setup also, there are so many factors why they should promote PD or they should not promote PD. So in private sectors also, not every center where DNB training is there, they are having PD as a facility available. So if your students, DNB and DM students are not trained, so obviously they will not have any training, and wherever they go, they will only practice hemodialysis. No, that is number one. Number two is hemodialysis is a very, very established procedure, and as Dr. Verma said, lot of advancements have gone, and it has become a very safe procedure. The fluid quality, RO system, and this dialyzers, safety of machines. The machines have become very safe. Gone are the days when we used to see air embolism or lead. So all those things you have not seen. I have done dialysis with a kill dialyzer. So that is how the dialysis was done. Then third is financial reason, and money is important for everyone. In dialysis, you get definite remuneration, good amount of money per session. Whereas in PD, there is still not a proper system of giving financial compensation to the nephrologist who is practicing. In US, they have a bundle approach where they give that for so many patients, for so much prescriptions, you will be paid. But in India, it is considered as a malpractice if you expect any money from the company. Baxter used to, I have no hesitation in saying, that Baxter used to compensate the nephrologist depending on the number of insertions. And so, but that was somehow considered as a malpractice or illegal. So that has stopped now. So that is not the, you have to have some system of reimbursement to the nephrologist, not equal, maybe not equal, but at least some way equal to what he gets on hemodialysis. So financial remuneration also is very important. That is also one reason that if you are clearly getting in a private setup, if you are getting between 500 to 1000 rupees per session as a nephrologist, and if in CAPD you get nothing, so obviously the choice is that you should ask the patient to go for hemodialysis. Then one of the things which is there is PD is synonymous with peritonitis. The moment I tell 10 patients, out of 10, 9 patients say, I don't know from where they have learned this, that उसमें तो infection हो जाता है. So they are not considering the infection in IJ, infection in peritoneal, infection in femoral, infection in fistula, or otherwise infections in hemodialysis units. Has anybody calculated that what is the incidence of infections in hemodialysis? The way those who practice PD, they openly say that 1 in 24 months, and now today we say 1 in 60 months. At least we are bold enough to say that it is 1 in 60 months. But PD means synonymous with infection. That is how the patient's perception is. Then next is, I think, if you see that if a hemodialysis patient is busy for 4 hours twice a week or thrice a week, whereas PD patient is busy throughout the day, 24 hours for whole life. So this is a fact. A PD patient is busy throughout the day. And if you see cycler, it is not very easy. It is easier said than done. A cycler also, after all, you have to set it right, electricity has to be there, helper has to be there. So it is not a difficult procedure. And another thing is our mentality. In Indian patients, we want, once we are sick, we want to keep our life in the hands of doctor or physicians or nurses, whoever it is. We don't want to take this treatment on ourselves. And best thing is that you pay money and then let the doctor and technician do their job. So whatever it is, you come for 4 hours, get the hemodialysis done, and then for 2 hours you are free. Then next part is insurance. So there are so many companies still, they are not accepting this as a modality which can be paid through insurance. I face this problem every day. Not every PSU company gives them reimbursement on it. They give reimbursement on hemodialysis. So all these factors are there, which are genuine problems, which I am the peritoneal dialysis PDSI president at present. Ideally, I should have handled all these problems at society level. So these problems we have to address. But it is already we have seen, I have been practiced for more than 30, 40, 35 years. So it is a modality which is available there, and still we should continue to use this modality. There is a huge gap, 95% versus 5%. That gap, it will not be easy to fill. You will not have equal distribution as is globally there.
Dr.
So I think I have answered my question.
You are addressing, basically it is an attitude of nephrologists, number one. And second, possibly the reimbursement by insurance is lacking. Otherwise, all the other parameters were existent 7 years back, infections, whatever it is. I think Dr. Vinant also did a survey on South Asian countries and he published the data. What do you think in addition to these two, personal attitude of nephrologist, as he rightly said, possibly the compensation to nephrologist is not there. He is not interested in giving CAP. And secondly, the reimbursement by the insurance company. Anything else?
So, first of all, thank you very much to all of you for participating in the survey that we published from this area. And what was recognized in the survey is an echo of what you all think is the most important thing and the most important impediment factor of patient going into PD is the easy accessibility to hemodialysis. So hemodialysis is you have hemodialysis every half a kilometer, 1 kilometer, maybe 2 kilometers in some cities, and they're very easily accessible by these patients. Apart from that, I would echo whatever Dr. Balai said till now, because these are the common thoughts that I think are going through all of our minds. And but the accessibility to hemodialysis being more than the accessibility to PD, lesser PD training, I think these are the two things, apart from obviously the things that we've discussed.
How can you reverse it? Attitude is one.
So I think
How it can be reversed?
the most important thing I think to reversal for this is, we had a sub question over there too, that what is the we didn't put this in the final publication, what are the comments? So everybody came up with just one comment, is to improve the reimbursement policies in this area. That was the most consistent answer that we got in the service.
Just one point, Dr. 80 to 90% of the chronic maintenance dialysis facilities are in private sector in our country. So in a private sector, out of these private, majority are corporate hospital now. A corporate hospital will look for the returns, and they see better returns in hemodialysis than in peritoneal dialysis. That is also one fact which I think we must remember, that in corporate hospitals, the returns for the hospital are better in hemodialysis as compared to peritoneal dialysis.
As the things are, there are going to be more corporate hospitals and similar things are going to persist. How do you think we can revive it?
It ultimately boils down to nephrologists. If today Dr. Fuller has got the guts and this thing will to organize PD college and promote peritoneal dialysis, you have to convince the authorities, you have to convince the management.
Yeah, anybody.
Can we see, provide a mic to
Very simple reason, especially in our country, if you want to increase the PD, make the PD free like Pradhan Mantri Yojana. I talked to Vivek Pute, whatever patient they are getting dialysis at Ahmedabad, near this. Patient after hemodialysis, they are being paid 300 rupees for food and family everything. And the government is providing every 20 kilometer hemodialysis center free of cost. So if the Pradhan Mantri Yojana will get the free peritoneal dialysis at a poor class of patient, then we can increase the number
very
of PD.
very valid point. Either you make it free or you have a wider coverage of the insurance company. Piyush, if I may ask you, we hear some great stories about Rajasthan as well. What is the model there? Do you get dialysis free of cost in Rajasthan, or what about PD there?
Yeah, things are this. In Rajasthan, what is happening? All these government schemes, the Ayushman Bharat and the Chiranjeevi Yojana, they are providing dialysis free of cost, including erythropoietin, including all the stuff. So patient is coming to all these centers where these schemes are empaneled. So patient simply goes there, get dialysis done, no need to pay anything.
That's the key point. You see,
so that's the problem.
We are being unfair to peritoneal
Just
dialysis.
one thing, I run a dialysis center. That's a philanthropic work where we provide dialysis free of cost to the patients. But patient has to get erythropoietin at his own. So people are not coming there for dialysis, rather they are going to the government sector for dialysis because they are getting 200 rupees erythropoietin free there. So that's the irony of the situation.
Yeah, so it's all about cost. Yeah, let's admit, it's all about
That's
cost
all
in our
about cost.
country. And unless we have the cost issues at par with both PD and hemo, I'm sure you will all agree, PD will not become that popular, because who would want to pay 30,000 to 50,000 from his own pocket every month when the hemodialysis is going to be reimbursable?
Dr. Narayan Prasad is in the committee,
yeah.
Dr. Bhaumik and he, that is there a proposal in between Dr. Jha brought an article that if the cost of CAPD bag goes down to 70 rupees, possibly it will become cheaper than hemodialysis.
So we are going to hear a lot from Dr. Narayan, and this is the beginning.
Sir, actually, when this has been proposed in 2016's document of the Pradhan Mantri National Dialysis Program, when we, Dr. Jha, were all in the meeting, there was no information at all to this ministry that such a modality of dialysis is existing. So that was this error. Then we have convinced, no, this is the one modality in which we can include, and this can go to the remote. Then indirectly cost, when you look at the cost of your electricity, cost of the water which has been disposed of during the dialysis and everything, cost is almost equal when you look at the erythropoietin cost or any other. So then they have convinced, and we have made the first draft. actually what happens when this blood flow, you can see number of peritoneal dialysis patients is not that decreased. Somewhere we have decreased in northern part of the India, but in southern part of the India, many of the centers have started doing this PD. You can see, look at the CMC Road, they have started doing PD. In Kerala, we have never heard of the doing PD in Kerala, but a lot of patients in the Kerala are initiated on the PD. Tamil Nadu has adopted these NHM programs now, and they have the free dialysis program. They have free delivery of the PD fluids to the door of the patients. So that kind of things is coming up. Again, this is being revived. Last time there was a meeting, we, Dr. Bhomik, unfortunately there were 2 persons who were all the hemodialysis pro persons in the meeting, and they were telling this is not going to survive, this is not a modality. So then I came forward, oh, you cannot, still there are many patients who are forced to put on the PD. If every vascular access is exhausted, when you have so many programs, you might have every week we have some patients who do not have any vascular access left on. Then you have to put the patient, you cannot leave the patient dying. So that kind of things are there, and this is the things which you have to brought in. Then he becomes convinced, but fortunately Malik from Gangaram Hospital
in that
was
committee
there.
only, the 2 people were firmly opposed to PD.
Yeah. So one of the
then Dr. Malik or I was there might have informed you. Then I have strongly condoned these things. No.
There is a provision of 5 lakh rupees.
Sir.
So, I mean, a person in a family, either on 1 person or 2 persons, total 5 lakh rupees per family can be provided. And in that, easily a person can get CAPD. So what is the difficulty?
It was not the difficulty, it is again the attitude of this.
Administrative.
Sir, actually when through the NHM, almost every state has been offered that they have transferred some money, even including Uttar Pradesh. 12 crore rupees has been transferred to Uttar Pradesh government to start on peritoneal dialysis program. What happened at that time, hemodialysis was evolving, so every district now have the hemodialysis machine. On peritoneal dialysis, there was one nice officer sitting on that, and she was not at all willing, and what she has told us, they are going to do it in the same fashion, how this hemodialysis is working in UP. So somehow it broke again. We are making efforts. I think in next few months this will be done.
And secondly, Dr. Kala, exposure is like in DNB, rightly Dr. Bhalla was mentioning. So now, if you look at 80% of the centers are not doing any PD. You look at the student, they do not know what is PD.
I'm sorry
even in USA, 60% of the centers are not.
I think this discussion certainly can go on and on. We know there are a lot of factors which ail peritoneal dialysis in our country.
Dr. Khulla, what I'm trying to say, whosoever is in the committee, whosoever goes to the committee, once I was in committee, Dr. Mani, myself, Dr. Sanjay Agarwal, and Dr. Raja Porkar, we suggested to DNB that every student before passing should have at least exposure to 5 CAPDs they should have done. But
that's a
that proposal
important point. That's a very important point, and I think we need to have some solutions to, once we accept that this is a wonderful opportunity, wonderful modality of treatment, we need to promote it. Then of course we'll have to find ways to promote it. But I think at the end of the day, the whole theme for today is to tell the young impressionable minds that this is a great opportunity, and let's learn from the experts. Rahul, you spoke beautifully on the science, and that was, I think, a very nice talk which you gave. Any comments which you want to give when Dr. Bhalla said PD first policy? The 2 questions I have in mind for you. What is the timing of peritoneal dialysis? That's one which you would want to advocate. It is similar for both our hemodialysis patients or PD, one. And secondly, would you also agree with that policy of PD first, which means that supposing government was to come out with free dialysis to everyone, would you say that yes, all our patients in India should be put on PD first, the way it's happening in Thailand, Mexico, or Hong Kong?
Taking out PD first. One is that
Yes, PD works best, the outcomes are best when the residual renal function is there. So that is one part which is we are very well aware that the patients do well.
Plus it preserves the residual renal function.
And yes, the water quality is good, so that is over there. So it does help to preserve. So it definitely that early this is, and there's a acute start PD initiative also that you can immediately try to start it out over there, because if people are initially go on hemodialysis, then it is more difficult to shift them back to it. So that also depends on the dialysis planning. So probably we are even in hemodialysis we are lagging behind. We don't have fistulas ready. We start with catheters. So in PD also the planning has to be there. So when you're planning probably 6 months before the onset, you should be discussing all these things, going ahead, giving them the choice over there. So probably
So talking about that planning, Dr. Panda, that was is for you. There's a concept called burying the catheter. So if we have to plan, let's say 6 months in advance, and we are saying, okay, the family is for PD, and the GFR has already touched 16 or 15 years. So would you want to do the catheter insertion then and there itself, and for the residents you can actually bury the catheter under the skin, which you just give a nick, take out the catheter after 6 months at the time of actually initiating your patient. So would you advocate this kind of approach?
Definitely, if PD is a choice, and as it comes down to planning, you have the patient, you have the nephrologist to know what is to be done, and what is the best possible outcome for the patient. I have personally seen 2 catheters while I was doing training, that these were very important people who have renal failures, and 6 months before, the treating nephrologist had decided that the catheter will be inserted and buried. So as part of my training, I'd seen that it was not required, and the patient had got a buried catheter. He went home, came back after 6 months, and it was taken to the catheter to be used after 6 months. So it's a very, very prudent thing, and it is part of the training. Like fistula, most of the patients don't end up with a functioning fistula, or the fistula has not been done on time. They go on catheters. So this is what I meant.
So talking about adequacy, I think Vinant talked about something which we have been advocating all these years. I'm sure Dr. Bhalla would also agree. I mean, we were, I remember, I mean, that's long, I don't even know whether Dr. Bhalla would remember that or not. This was 1994, North Zone Indian Society of Nephrology, Ludhiana. Dr. Bhalla was giving a talk on peritoneal dialysis, and my question to him was, Dr. Bhalla, how often do you do PET? So of course, he said, we all know this is all theoretical, but he confessed, we don't do PET. And we have stood by that statement. We have done it occasionally for the kick of it, for the sake of it. I mean, I'm not saying that all these theoretical things which we are discussing are of no consequence. They are. But at the end of the day, it is the patient in front of you. Whether the patient is being brought to your OPD or is walking into your OPD is what is the difference, whether the patient is on adequate dialysis or not. So, Vinod, I'm glad you reinforced our belief. At the end of the day, it is a composite of effective ultrafiltration, achieving the dry weight, anemia, nutrition, and more importantly, one thing leads to another, is the albumin. If you have serum albumin of your patient less than 2.8, mark that, it may not be there in many of the textbooks, but it is also coming from personal experience, less than 2.8, the life of your patient becomes very difficult. So try to improve the patient's albumin to beyond 2.8. Of course, you may argue, why not 4? Well, yes, better the merrier. But then at least 2.8 plus onwards, 3 onwards will make it will reverse the whole cycle. Otherwise, achieving ultrafiltration and at the same time remember about the role played by hyperglycemia. You may struggle if your patient has hyperglycemia, you will not be able to achieve ultrafiltration, and that is the big problem. Now, of course, when you start doing PD, you will then understand the nitty-gritties, and you will be able to compare. You'll be really very worked up when you have patients, consistent patients coming in as high transporters, because you would enjoy patients who are low average, low transporters, because they are like chronic interstitial nephritis patients. They're dry, the ultrafiltration problem is not there, and they tend to do better. As Dr. Bhalla said, not too many diabetics do well. Our patient who was 21 years post PD, is not a diabetic.
Not a diabetic.
I can't recollect any of, except one who lived for 12 years who was a diabetic, and that lady was on APD. Then again, I think before we proceed, the resident should be well familiar with these terminologies, and just for the sake of, at the risk of sounding very, very basic, CAPD is what we are talking about. CAPD means you are doing manual exchanges throughout the day, and there is fluid in the peritoneal cavity even at night. And what the residents must remember is the difference between APD and other modalities with cycler. CCPD is when you are using the automated machine, but you are also instilling the fluid during the day. That becomes CCPD. Otherwise, if you are doing it only with the help of the dialyzer, with the machine, and having the PD exchanges being performed only at night, that will be labeled as NIPD, nightly intermittent peritoneal dialysis. So there is a difference between semantics, the difference between these definitions, so you must know what we are talking about. DAPD, day ambulatory peritoneal dialysis, where you are by design leaving the fluid empty from the peritoneal cavity overnight, and of course you can do a whole lot of innovations and try to fit into your patient's requirements. But at the end of the day, we have learned is the role played by residual renal function. You typically would be wanting to achieve a peritoneal effluent of about 11 liters if you want your patient to do well. But this could come down to something like 6.5 or 7 liters if your patient has significant residual renal function, because every point, as Sagar had mentioned, counts. Because to make KT upon V, if you are now wanting to give some importance to KT upon V of 1.7, to make it 1.8, that extra 0.5 can come from the residual renal function times into 7. So you can see what 0.2, 0.5 can make a difference. But what you must remember, if you are wanting to chase KT upon V, there is no point taking it beyond 1.8 or 1.9. That also is clear. Less than 1.5 is bad. 1.5 to 1.7 also is not very good. 1.7, but all would depend upon the total, what you are achieving through PD and what the patient's residual renal function is all about. General Verma, your comments on if anything we have not missed before we, yeah, and now residents, please be ready with your questions. We expect a lot of questions, and please remember, no question is ever a poor quality question, is a wrong question. Please come out with, have no fear of asking even what you may feel could be an awkward question.
Just one thing, that we had a lot of effort of all the CAPD nephrologists, because they had done a lot of effort and convinced that to put a plant in India. Then in Gurgaon, the plant was installed. So after some time, they closed suddenly. We came to know that they have closed that plant. So that is that irony actually, that we were all expecting that once the fluid will be made in India, it will definitely be cheaper. Because ultimately comes down to cost. All of us, we are saying that cost should be less. Even when they started making in India, the cost was same. Whatever international cost was there was no difference. Same thing is happening in other companies also made in India, Mitra company. Almost same equal cost. We all know Nipro, they started making dialyzers in India. They were all importing those dialyzers, making in India, using cheap labor and exporting. And the cost was again the same and exactly same and not cheaper. So I don't know how these companies also work, that they don't want to bring the cost.
You're absolutely right, sir, and I'll relate a very interesting incident which few of you may have heard before as well. India is never ever given its due importance. We may have numbers, everyone understands, but I'll tell you, there was this debate in Hong Kong. There was a meeting, and I was one of the speakers. And there was this question: how would you treat a given kind of clinical situation? And my answer to that particular situation was, well, 4.25%. I mean, we had been using 4.25%, fully realizing that glucose is bad for the peritoneum. But it is like using K-bind for 7 days, 10 days, 15 days, heavens are not going to fall. We know how to judiciously use. So the same was 4.25% dextrose, and one Singaporean got up and said, I will not use 4.25% even in my mother-in-law. I still remember those words. Even in Then I countered, I said, well, I don't know what is the state of affairs in Singapore, but we in India respect our mothers-in-law equal to our mothers, and we would want to do the same kind of treatment which is ideal for our mothers-in-law. So I don't know if things are different in Singapore. We were about to have a detailed discussion, but unfortunately that hotel caught fire. Otherwise I was well prepared. I was well prepared to have countered that gentleman, because this is what, and what Vinod was saying, it is the patient in front of you. You have to take care of the fluid overload, fully understanding that, well, I gave you an example of K-bind. You know, colonic perforation may have happened. I may have used K-bind in about 100,000 of people. I've never encountered a single colonic perforation, but then that doesn't mean that I'm given the liberty of using it endlessly. Judicious use and looking at the patient in front of you is what matters. So why I highlighted this was, India will never be asked, what do you want? Yes. Ultimately, 4.25% is back. It was out of the market.
Why suddenly we came to know that 4.25% has been withdrawn? And why we are forced to use adequacy? Why? Because the policies are made by international people, and India is given, as he's rightly said. The same thing as Astira's program. India is not a market for us. So we are number 3 as far as transplants are concerned. We are number 3. We are soon going to be number 2.
Number 2.
It's already number 2.
Yes.
Number 2.
Yeah. So the whole idea is, rather than getting swayed as to what. So the whole, you would have seen, we are the people who have some experience in PD are telling you it is a safe modality. Let's not bring cost into it, and let's not bring the remuneration to a nephrologist also. I would certainly want to say that, okay, hold your head high and say that yes, we will do it even if it comes as a free of cost, because this is what differentiates us as nephrologists. So even if you have to do few PD treatments free of cost on a yearly basis, accept it. But yes, we do need to look into the financials as well. But till then, what is important is also the fact there are no care providers at home. We used to have those well-knit families. There will be 10 people. I know a lady, Ayodhya Devi, her 10-year-old child from Aligarh used to do a PD exchange for the Dadi. So that is the kind of involvement of the families we had. Now with the nuclear families, who do you expect to do the exchange on a person who's hardly able to walk? And that's why all those patients, if I recollect, those who have lived for longer than 10 years, survived longer than 10 years on peritoneal dialysis, were the ones who were either doing by themselves or the intelligent spouse or some good family member who was willing to do that. Now, we can't criticize them. There are 2 children. Both are working. The spouses are working as well. Who do you expect to do the PD exchange middle of the day? You will employ someone and that will add on the cost. So a whole lot of discussion, but then I'm waiting for, Saurabh, you want to say something? Sorry. So please come out with questions. I'm sure you have some basic questions which you want to learn from the experts. As I said, I can't think of a better faculty today for to help you out. Please come out.
Can I have a comment?
Yeah, please. Students, please don't be shy.
Regarding Dr. Panda, he told catheter insertion prior to 6 months prior to start. He has suggested CAPD catheter insertion prior to 6 months to start the dialysis.
Exceptional.
Exceptional, because that is going to be PD related catheter complication and maybe
it may not be. So what he was trying to say, and this is the question which I asked him, was that so many times we say, okay, everything is fine, patient is healthy enough. Why wait when the patient becomes sick? So you do it and bury it under the skin. So it's going to be safe. So there's going to be no possibly scope of any kind of peritonitis, at least what the literature says. And then you just give a nip, take the catheter out, and it's ready for.
Second comment regarding catheter insertion, our personal experience. In coil catheter, patient used to be more comfortable. There are less chances of migration, and second is the jet effect is not there. There are so many patients they are having jet effect in non-coil catheter. So we used to put coil catheter by taking the electric guide wire and just.
We still do that. We are very comfortable with coil.
Both are equal. Evidence says.
Evidence says both are equal. I think we can stop here.
Yes,
If
last
there are-
words from General
If there are
Verma.
no further questions, yeah, we
We
can
deserve a
just
cup
take
of
a
tea now.
call that we must train our students to put how to put a catheter. Because you can save many lives. I remember in army we used to hand over 5 catheters to our MD students. After they were passing MD, they were going to remote areas. We used to hand over catheters to them that in emergency do PD. And they used to do IPD. They are still doing in the border
You
areas.
must request all the centers to have rigid catheter also at there.
Yeah, because at least in emergency, I remember my daughter, she's a nephrologist, she was in US. During COVID times, there was no machine available, and that is the time they resorted to PD. They did not know how to put the PD catheter because 60% of the centers in US are not practicing PD. So they called the surgeons, surgeon implanted the catheters and the PD was started. It is required as emergency many times.
General Verma, you are forgetting that you were also passing on the same kind of command to your junior resident at PJ Chandigarh, giving that junior resident, that senior resident being myself, that there are 10 catheters to be put in the overnight, so if you do it. So that kind of volume of work used to be there at PGI.
Oh, yes.
That PDs, 10 PDs, there was no hemodialysis available at night, and you can see the amount of the work at PGI. Dr. Kalra, all my seniors here, Dr. Narendra sir. Yeah, so this is
Even
Only thing I wanted to say, we should not project laparoscopic insertion as that should not be there, because we should not encroach on this. First of all, we nephrologists should understand we are physicians, and we are supposed with laparoscopic, if you are putting 2 ports through the dimension of the 1 port, you can put the catheter. So injury would be less, and then you are giving it to in the hand of the others. So always as a nephrologist, we pull apart, say this technique is the best, and only otherwise this is the midline, that was the good enough, no bleeding at all in the midline, and always it is safer. Even you are not putting any sutures, just leave it as such, everything would be healed. There would be fibrosis. So many times we practice whenever you have difficulty in putting sutures, leave it as such. Make a tunnel, leave it as such. So that's all.
But intermittent PD has saved so many of lives, and I still remember Dr. Balla telling me, "Oh, ये क्या कर दिया?" मैं क्या बताया बेटा, तूने लिफ्ट में PD शुरू कर दी. So he told me there's an urgent PD hyperkalemia. I couldn't control myself. Oh, lift रुकी हुई थी, PD शुरू. So that kind of
it used to take just 1 or 2 minutes to start a PD. Just 2 minutes you start the PD.
Okay, I think we well deserve.
Many times people say,
tea now.
No, Dr. Fuller, many times people say that in cases of malaria, PD is not very effective because the capillaries are parasitized with that. But I remember in remote area, one of the remote areas, I just saw a malaria patient and there was no work for me, so I used to go to lab, 95% parasitized heart disease. And this guy in front of me, one day, one finger fell down. Second day, second finger fell down. And that is the time we were giving PD to him, knowing it's malaria, parasitized capillaries, but we could see.
So I think we well deserve a cup of tea now. Please, you're all welcome. Thank you very much.
Hi Rahul, how are you? It's good to see you.
सारी जगह फोटो छप रही है, सारी फोटो छप रही है, फोटो छप रही है।
Tea break session now. Two sincere requests. We are running short of time. So my request to all the speakers is please abide by the time. We will have about 12-13 minutes allotted to each talk, followed by a few minutes by the chairperson's comments, sharing their experience. And another sincere request is please do stay on for dinner. We would love to have some more interaction during dinner and learn from each other as to what the way forward should be in conducting more such meetings. So please do stay for dinner as well. Thank you so much.
Session, I would like to call upon our chairpersons, Dr. Manish Jain, Director Nephrology at Medanta Medicity, Gurgaon, and Dr. Sajay Bhagat, Senior Consultant Department of Nephrology at Fortis Hospital, Manesar in Gurgaon, for the session on PD prescription.
I would like to invite Dr. Manoj Singh. Everyone knows him very well. So, sir is a principal director in Max Hospital, Vaishali, and sir will be dealing with a PD prescription. Again, a very vital topic. So, PD prescription should vary according to the patients, and there are lots of things in the PD prescription. It's not like a hemodialysis that you write 4 lines and it's over. So, all to you, sir. Dr. Singh.
Thank you, Manish, for this introduction, and I thank Dr. Fuller and the whole team of Max Saket for inviting me here. One assurance, I think so far I had a feeling that the PD is a very complicated thing. Let me just assure you, it's not at all complicated. It's a very simple modality and it's an awesome modality. Once you get to know it, you will love it. So in my talk, what I will discuss today, I think first part is we all know that it is used in 11% of the patients. The cost for peritoneal dialysis is lower than hemodialysis. Let me tell you, we are talking of so far out of the pocket cost which patient pays. Right? But we have to look at it from the healthcare perspective, how much is the cost for healthcare system. The PD is much lesser as compared to hemodialysis. So it should be used more often in patients where the burden of poverty is high, and I think India somewhere fits into that category. Initial hemodialysis prescription is relatively very uniform and standardized. We all know 4 hours, 250 ml of blood flow, so much of ultrafiltration target with. Same prescription for all the patients. Whereas PD, you can individualize the prescription to the particular patient. So that is the strength of peritoneal dialysis. Right? So we will review what are the principles of incremental dialysis, how do we start dialysis, and how do we escalate the treatment in most of the patient as they require. We will also review the concept of adequacy, which Renal has already discussed, but we will look at the practical aspect of adequacy of dialysis. Just to recap the basic physiology of peritoneal dialysis, PD is a process where we instill the peritoneal cavity with sterile fluid through a silicone catheter, which is placed, and we do an exchange or cycle. Exchange is used for manual dialysis like CAPD, and the cycle is the term which is used on automated dialysis or cycler. So the transport of molecules and fluid across the peritoneal membrane occur through 3 ports, which Dr. Rahul Grover has already discussed. Ultra small pore, we also call aquaporin, so small pores and large pores. Higher dextrose concentration in the PD fluid will have higher osmolarity, higher osmotic pressure gradient, and it will induce higher amount of ultrafiltration, that is fluid removal from the patient. Right? Exchange of solute and water occurs through the peritoneal membrane, which is surrounded by capillaries and which is in contact with the dialysis fluid. So not the whole peritoneum take part in dialysis, it's the part of the peritoneum which is in contact with fluid participate in dialysis. So that's what we call effective surface area of peritoneum. So, and that again varies depending on the vascular resistance and the amount of dialysate which we fill inside the cavity. So as we increase the fill volume, effective peritoneal surface area increases and the solute clearance also increases.
This table shows the various fluids which are available. The different concentration of glucose, 2.5, 4.25 as you've seen is not available now. Icodoxin 7.5 and the bicarbonate buffered solution. Bicarbonate is a neutral pH. If you look at the bottom line pH, this is 5.2, the bicarbonate is 7.4. The first thing when we prescribe PD or start PD is to discuss with the patient what type of dialysis do they want, what is their lifestyle, how do they function, what time they get up, what time they go to sleep, what all they do during the day, and how do they want dialysis to fit into their lifestyle. Right? So that any treatment or prescription is not very intrusive in their lifestyle. The basic aim of any treatment is to make their life simple or comfortable. Right? So CAPD, as we all know, it's a manual peritoneal dialysis where we do the exchanges manually. It's an excellent option for patients who do not wish to be connected on machines. There are patients who are not tax savvy. I don't want to be tied up to the machine. I have to get up to go to toilet for 2 times in the night. So how can I be tied to the machine? Right? They may have any other reason in the world not to be tied to the machine. So for these patients, they would prefer manual exchanges. There are patients who are free in the daytime. They can accommodate the schedule in the daytime, but they don't want anything to be done in the night. So that's how we discuss with the patient and decide what type of dialysis they want. CAPD again, it affords portability. Patients who want to travel, they want to go on vacation for 10 days to say Shimla, they can take their bags in the car, they can go there, continue their dialysis there and come back. They don't have to take their cycler or machine along with them. As I said, it's very cost effective. You just need to get the bag, which costs around 275 or 300 rupees. No extra cost of anything. Right? So for a country like India, I think that's the way to go. That should be utilized to the maximum, whatever is possible. Automated peritoneal dialysis, which uses cycler, although the number of exchanges it does, it can achieve effective solute clearance and fluid removal. It's a very favorable option for patients who are very busy in the daytime. We have patients who have been executive in various corporates or in other offices. They have to work throughout the day and they come back in the night, attach them to the machine, and in the day again they are free to work. The students, they have to go to college, they have to attend their classes. They can again use this type of dialysis at home in the night, and in the daytime they're free for all type of activities what they want to do. We have a newer versions of cyclers which have a great precision, and it can be remotely monitored. So sitting in the centers, the PD nurse or the technician can monitor their treatment protocol. If there is any problem in the night, they can troubleshoot from the home, from the center. Okay. So that's a type of facility which is now available. However, the utilization will depend on the availability of these cyclers, training capacity and local resources. The cyclers are much costly. They have an initial capital investment as well as the maintenance cost with cycler is also higher than CAPD. Okay. So almost 1.5 to 2 times of the cost with automated peritoneal dialysis. Second thing is again fill volume and the number of exchanges. So these are just 2 things which you need to know for peritoneal dialysis. Right? Usually fill volume is between 1200 to 1500 ml per meter square, which comes to around 2 to 2.5 liters. Right? This will exert some intraperitoneal pressure, which should not be more than 18 millimeter of water. This pressure is lowest when the patient is recumbent, when the patient is lying down. When the patient stands up, the pressure goes a little high, but when the patient sits, that's when the maximum pressure is there. And unfortunately, the patient has to squat, patient pressure will go to the sky high. So that is the variation in this pressure, but most of the patients can tolerate this amount of fluid in the abdomen very comfortably. So 2 liters is hardly ever a problem to tolerate in these patients. Whenever we need to increase the dialysis, whether it is for solute clearance or for fluid removal, it is easier to increase the fill volume than to increase the number of exchanges. Right? So instead of 1500, you can ask them to go 2 liters or 2 liters to 2.5 liters. It's so much easier. But if you ask them to increase the number of exchanges, instead of 3 exchanges, 4 exchanges in a day, or 5 exchanges in a day, that becomes much more cumbersome. When we use cycler, the maximum time which is preferred is around 8 hours. And that's the time any person would be in bed. Very few people will be in bed for more than 8 hours. So if you ask them to put a cycler for 10 hours or 12 hours, that's not practical. That will impair their lifestyle. They will have lesser time off cycler. That's when they want to interact with their family, their friends, or do other activities. Right? So 8 hours, maximum 10 hours if at all, if the patient agrees for that, but preferably within 8 hours we should prescribe cycler. Number of exchanges should not be more than 4 or 5. So as it was said by Dr. Vishal Singh earlier, whenever we do exchange, at least 15 to 30 minute time is spent in draining and filling. And this is the time when no dialysis occurs. Okay? So over 8 hours, if you put say 5 exchanges, 2.5 hours will be gone in filling and emptying the abdomen. So effective dialysis will be only for 5 or 5.5 hours. So not more than 4 exchanges preferably. If the patient has agreed for 10 hours of cycler, then you can increase 5 exchanges. So 5 exchanges in 10 hours or 4 exchanges in 8 hours, not more than that. Other thing is rapid exchanges. The dwell time is very less. So that will only promote small solute clearance, whereas the bigger molecule, like phosphorus or middle molecules, will not be cleared in very short exchanges. Also, there is a problem with sodium, what we call sodium sieving. Initially, when we put the fluid in the peritoneal cavity, this fluid has very high osmolarity, and that osmolarity will drive water movement from capillaries to peritoneal cavity through ultra small pores or aquaporia. So initially the water will come to the peritoneal cavity, whereas the sodium will take some time to come through small pores. Okay? So after 2 hours, the sodium will also come into the peritoneal cavity through small pores, and that's when we can remove this fluid. So if you drain fluid in very early in the dwell time, you will remove only water, and the patient will be left hypernatremic. The patient's serum sodium level will go high. That will induce more thirst, and they will drink a lot of water. Okay, so that will become counterproductive. So how to go about prescription, like order the prescription for dialysis? A few things which we need to remember. Clearance target, as discussed by Renal. The consensus is to have the KT upon V, say clearance of urea of 1.7 per week. We should add peritoneal and renal KT upon V to achieve these targets. There is good data which was shown earlier that the greater residual renal function is associated with outcome, whereas increasing the total clearance does not have that type of impact on the outcome. Incremental versus maximal prescription. Incremental approaches where you make up for the declining kidney function by increasing the dialysis, right? So to use initial residual kidney function to achieve those targets. Whereas in maximum approach, you provide dialysis, peritoneal dialysis, irrespective of the kidney function. So whatever residual kidney function is there, that becomes a bonus. You prescribe them dialysis to achieve 1.7 urea clearance per week. Other method is empirical versus modern approach. Empirical approach is where you look at the patients, you choose the prescription after discussing with them, and you adjust the prescription to achieve your goals. Whereas the computer based, where you do a PET test, you look at the anthropometric measures of the patient, you use the residual kidney function measurement and use that model which we call adequacy, put these things in there, and that model will tell you, okay, what type of dialysis is good for this patient, how much fluid or well volume you should prescribe. So all these are good things, but how do we use it practically? Let's see. So when we start dialysis, how should we calculate how much dialysis is to be ordered to this patient to achieve this adequate small solute clearance? As we know, standardized weekly KT upon V urea in a PD, this is expressed by D over P urea. So that is the equilibration of urea with serum capillaries, right? So when we put this dialysate fluid for 4 hours in peritoneal cavity, what is the level of urea in dialysate as compared to plasma? Okay, normally it is 0.9 or 1. So maximum you can achieve is equal amount of urea in dialysate as it is in plasma, right? Into drain volume, into 7 days per week. So that's why there is 7. We standardize it to the size of the patient, which is this volume distribution of urea. Okay. So D over P urea into drain volume into 7 over VD. Target is 1.7. This is per week, so divided by 7, it is 0.243 per day. So let's keep it 0.25 per day. So this equation can be rewritten as D over P urea into drain volume. So we remove 7 from here. Total body water, which should be equal to 0.25. Maximum ratio of D over P urea which is obtainable is 1. So you cannot have urea concentration in dialysate more than blood concentration. So you can have 100% equilibration, so that will be 1. Okay. So dV needed to achieve this daily KT upon V should be then 0.25 into total body water. So in a 0.25 into body weight into 0.6, which is approximately the total body water, right? Then we assume that some ultrafiltration will be there. So let's assume if the patient has 1 liter of ultrafiltration, so what should be the dialysate volume we should prescribe? So in an anuric patient who weighs 60 kilogram, okay, so the initial prescription which is required probably would be 8 liters. Let's see, total body water into 0.25 minus 1. So 60 kilogram into 0.6, 36 into 0.25 would be 9 minus 1 liter of ultrafiltration. So this patient would require 8 liters of dialysis fluid per day. So you can safely prescribe 2 liters exchanges 4 times in 24 hours, right? Let's consider the same patient. If the patient has significant residual kidney function, so we have to adapt this equation to accommodate residual kidney KT upon V of urea. So the urea clearance is again UV upon P. We all know this formula. Urinary urea concentration into volume divided by plasma urea concentration will give urea clearance. Okay, that's a physiology lesson. You say correct it for standardize it to total body water. So urinary urea divided by plasma urea into urinary volume divided by total body water. So in the same 60 kilogram man, the plasma urea concentration is 50 and he produces 1 liter of urine with urinary urea concentration of 240. So his urea clearance would come out to be 3.3 ml per minute. And if you calculate residual kidney KT upon V of urea, that will be 240 divided by 50 into 1 divided by 36 is equal to 0.13 per day or 0.93 per week. This is same as we have discussed earlier. In an average 70 kilogram man, 1 ml per minute of GFR is equivalent to 0.25 weekly KT upon V. Right? So 3.3 is the urea clearance, which underestimate 2 GFR. Creatinine clearance, overestimate 2 GFR. If you take an average of urea clearance and creatinine clearance, that will be somewhere near to 2 GFR. Okay? So rough approximation, 1 ml, 0.25 milliequivalent, 25 weekly KT upon V. Okay? So we want to prescribe 0.25. We already have 0.13 per day. So what we need to do is just give extra 0.12 urea clearance. Am I with people or I have lost the audience? So far, are you getting these numbers? Okay. Sure. So if you just have to prescribe instead of 0.25, 0.12, total body water into 0.12 will give you 4.3 liters dialysis fluid or drain volume per day. If you assume that the patient will also have ultrafiltration of 300 ml, so what you need is 4 liters per day. So in this patient who has residual kidney function of say 1 liter per day, you can just give him 2 exchanges of 2 liters each, and that will suffice for this patient to achieve this Kt/V of 1.7. This number, I think right now it will be looking complicated to you, but these are very simple things. What you just need to remember, look at their urea clearance or GFR, and rest you can supplement by peritoneal dialysis. However, usually we do not do these calculations when we prescribe peritoneal dialysis. I'll come to it in a minute. Right? This is just for you to understand what is the science behind it. Incremental PD, as I said, if the patient has residual kidney function, you just need to start them on some amount of dialysis. Don't prescribe full amount of peritoneal dialysis to these patients. Take the leverage of residual kidney function, supplement it with peritoneal clearance. As the residual kidney function go down, you can increase the peritoneal dialysis and increase the peritoneal clearance with time. Okay? So that's the basic concept of incremental peritoneal dialysis. This can be done with CAPD as well as with automated peritoneal dialysis. For example, in the same patient which we have just discussed, if we have to give 4 liters per day, we can ask him to do only 2 exchanges in the daytime. Glucose-based solution and remain dry in the night. Or you can ask them to do night exchanges, NIPD. Use the cycler, do 2 exchanges in the night, you are free for the day. No fluid in the abdomen, free for the day. Go do whatever you want to do. Or you can do dialysis for few days and give him rest for few days, as it was discussed earlier. You do dialysis on alternate days, or you do dialysis for 2 days, rest for 2 days, dialysis for 2 days, rest for 2 days. So you can accommodate the schedule according to the patient's preference. Right? There is a data where people have shown that this type of dialysis works even when the GFR is very low. Right? You have to assess this patient frequently so that as their kidney function go down, you need to increase their dialysis. That's very important in incremental peritoneal dialysis. And many patients find that if you start them with a small amount of dialysis, that is more acceptable to them. Yes, this looks fine. I'm comfortable with this, I'll do this. Once they will start doing it, they will get used to it. You ask them, you should do hemodialysis, they will say no. I cannot go on hemodialysis, I want to continue dialysis. Do whatever you want to do. You can increase the number of exchanges, but I don't want to substitute with. Sometimes the dialysis is done for fluid removal. For example, patients who have CHF, they do not have solute load, but they have fluid overload, and you want to remove fluid. Okay? This can again be done in an incremental manner. You can just ask them to do 1 or 2 exchanges in the daytime, as we have discussed. Or you can do a NIPD, you ask them to do night exchanges and remain free for the daytime. Other thing what we can do is we can just use 1 bag of icodextrin in a long dwell. Use 1 bag of icodextrin for 8 hours in the daytime or night time, whatever is your preference. This icodextrin will remove 800-900 ml of fluid over 8 hours. Rest you are making some urine. This will suffice for fluid overload. So we have to increase this dose. As I said, as the kidney function go down, we have to increase the dose of dialysis. And this is generally much more patient friendly. There are certain problems with incremental dialysis. Some advantages of incremental dialysis. I think this will be discussed in details more in the next talk, which is going to be on incremental dialysis. Another issue is, should we use this transport status to prescribe dialysis? As we all know, that slow transporters will reabsorb glucose slowly. They will maintain osmotic gradient for a longer time, and they will have good ultrafiltration and solute clearance. This type of transporters are good for long dwells or CAPD, manual exchanges, whereas fast transporters will very rapidly reabsorb glucose. They will dissipate this gradient very fast, and they are not good for long exchanges. So these patients are more apt for automated dialysis using short exchanges so that we have adequate fluid removal in these patients. However, these are not just 4 categories of transport status. This data works in a continuum. Okay? So patients may have D over T from 0.6 to say 0.9 continuously. They're not categorized. So I think more important is to look at the patient, how much fluid they are draining with what type of fluid. So if they put 2.5% glucose solution and they are draining around 1.5 liters of ultrafiltration in 24 hours, we know that this patient has what type of characteristics. So any astute physician or a good nurse can make out what type of peritoneal transport status this patient has. If he is achieving good amount of ultrafiltration, there is no need to change any treatment. Right? How is adequacy measured? Vinant has discussed this. So what is adequate? So adequate is a bare minimum. So adequate is a bare minimum dialysis which will provide or say reduce the burden of uremic symptoms. So we just reduce the symptoms. We don't know what is optimal. Nobody knows so far. So this is the minimum which we want these patients to achieve. And that should come from both renal as well as peritoneal, as we have discussed repeatedly. Okay. Vinant has also discussed that using this urea or creatinine clearance have not worked. What we expected out of that data has not supported that. What is more important is the residual kidney function which correlate with outcome. Why? Because uremia is quite complicated. It's not just one molecule which measures the diffusion and we can estimate the other molecules. There are different molecules of different sizes of different diffusion capacity. They all contribute to uremia. So it's very difficult to predict by using simple urea kinetics. Other thing is Kt upon V is the total body weight. We estimate total body water by 60% of body weight. Right? Just take an example of a fat person with a high BMI. A lot of this BMI is contributed by fat, which does not contribute to urea distribution. So that will increase their V. So their Kt upon V will look small, whereas this V is predominantly because of adipose tissue, not contributing to urea transport. So these are the fallacies for Kt upon V urea. Okay. Another thing is ultrafiltration. Again, when we look at these solute kinetics, urea, creatinine, or say creatinine clearance, we do not know how much ultrafiltration patient is achieving. And it is seen, a lot of these patients are volume overload. So the 25% patients on PD for 2 years have severe volume overload. And this has been shown by observational data from Europe using bioelectric impedance analysis. And this volume overload is associated with increased risk of technique failure and death. So when we manage volume overload in these patients, we use all sort of pharmacological and non-pharmacological measures. For example, you give them diuretics so that they make more urine. You ask them to limit salt and water, they don't feel thirsty and they should limit their water intake. We use higher, say, osmolarity of fluid. So when we have to remove more fluid, instead of 1.5, we use 2.5% solution so that they remove more fluid. But at the same time, if the glucose is high, they will become thirsty and they will drink a lot of water. So that becomes counterproductive. Right? Other thing is when you use frequent exchanges on cycler, the effect of sodium sieving, they remain hypernatremic and again they feel thirsty and they drink a lot of water. So these are the things which need to be taken care of when we prescribe dialysis to these patients. Let me tell you, non-compliance is the commonest reason for these patients to be fluid overloaded. So we have to again and again talk to them and emphasize about salt and water restriction in these patients. This is a simple diagram which shows how simple it is to prescribe. So far, whatever I have said, calculations and everything, they are just for you to understand. How you start dialysis, if there is a patient, discuss what type of dialysis suits his lifestyle, whether he wants an automated dialysis or manual dialysis. Whatever dialysis, start with 2 to 3 exchanges per day. Use 1.5% dextrose solution initially, depending on how much ultrafiltration occurs and how much ultrafiltration is desired, you can adjust the tonicity of this fluid. Initial volume should be between 1200 to 1500 ml per exchange. Start with low volume exchanges, and as the patient becomes comfortable, you can increase the volume of exchange to 2 liters. In CAPD, we only have 2 liters bag available. Whereas in automated dialysis, we have 5 liters bag, so you can adjust the dwell volume in the aliquots of 100 ml. So you can ask them to do 1500 or 1700 or 1800, whatever you want. Right? Assess the patient, how he is doing, and then adjust the prescription according to his requirement. If the patient requires more solute clearance, he is under dialyzed as far as his uremic toxins are concerned, you need to adjust his prescription, increase the volume by 20 to 30%, maximize it to 2 liters per exchange. Okay. If it is not sufficient, then only you can increase the frequency of exchanges or number of exchanges. In automated dialysis, as I said, do not increase the exchanges to more than 5 because that will be useless activity. You have to add the day exchange to these patients, which we call CCPD. In patients who are volume overloaded, maximize diuretics, ensure salt and water restriction, use icodextrin if required in a long dwell, and then adjust the dextrose concentration in their fluid. Okay. This is the practical approach how we practice peritoneal dialysis. Other consideration is urgent start, where patient need to start peritoneal dialysis within 2 weeks of placement of catheter. Ideally, we want to wait for 2 weeks before we start dialysis, but at times we need to start it immediately once we put in a catheter. There is a chances of leakage of peritoneal fluid through the operative site, so we use low volume exchanges. Most of the time this is done in recumbent position, so we use based on their body size 750 ml or 1 liter or 1200 ml exchange. Frequency, again, depending on how symptomatic is the patient, what is the clinical requirement. You can do it daily, you can do it alternate day, you can do it 12 hours every day, or you can do it 24 hours on alternate day, depending on what suits the patient, what suits your system, how you can do it. Tidal PD, again, when we drain this fluid out, when the abdominal cavity is empty, this catheter sometimes will irritate the internal organs. And that will cause pain, which we call dry pain or draining pain. So when all the fluid is drained out, the patient will have severe pain. Usually with time, this pain will go away. But in patients who are on automated dialysis, when they want to sleep in the night, and the time all the fluid is drained out, they will have pain and they will get up from the sleep. So it becomes a problem in these patients. In such patients, you can leave 15 to 25% of fluid in the back, in the abdomen. So you can program the machine accordingly. It will fill with 2 liters, it will drain 1800 and then again fill 1800. So every time it will drain only part of it, 80% of fluid, 20% will remain in the abdomen. But at some point of time, you have to remove all this fluid. Just like a counter current mechanism which we have read for concentration of urine. If you just keep leaving this 20% fluid in the peritoneal cavity all the time, it will become very concentrated. So once in 24 hours, you have to drain the peritoneal cavity. And that can be done early morning, once in a day. You drain all the fluid out. Again in the night, you can use the tidal dialysis, and next day again drain out all the fluid out. So that's what is tidal peritoneal dialysis. When should we transfer patients to hemodialysis? Most common reason for patients to transfer from peritoneal to hemodialysis is infection. It's very easy. If the patient has resistant infection, you have to stop dialysis, remove catheter, put patient on hemodialysis. Once patient gets better, you can again address this issue whether patient can go back to peritoneal dialysis, or if he has severe loss to peritoneal membrane, he cannot go back on peritoneal dialysis. If the patient does not have infection, it is a very difficult situation for the patient as well as for the physician. And that is the decision which has to be made. Delay in this decision will impact the quality of life as well as the outcome of peritoneal dialysis. A lot of patients, they die in this process wherever there is a delay in this decision. It's a very simple. If the patient is achieving adequate solute clearance or ultrafiltration, or if the patient is not achieving. If you feel by increasing the dialysis, whatever doing, patient is not achieving solute clearance, or patient is not achieving ultrafiltration, patient is volume overloaded, switch these patients to hemodialysis. Okay. The cumulative effect of other comorbid diseases. Sometimes patients have diabetes, heart failure, vascular disease, and patient is symptomatic of these diseases, and at times we implicate these symptoms to underdiagnosis. So that's very important. Clinically, you have to look at the patient, decide why the patient is not doing well. Is it because of comorbidities or it is because of underdialysis? So if the patient is underdialyzed, switch to hemodialysis. If it is because of comorbidities, it's not going to get better even if you switch to hemodialysis. So to conclude, a lot of emphasis has been on solute clearance and membrane transport characteristics earlier. That's how we used to practice peritoneal dialysis. But now there is change in thinking. The clinical practice has evolved. So we now prescribe dialysis based on patient preference and to make their life easier than it is. Okay. As the PD grow overall, we adopt more and more peritoneal dialysis. We should very closely work with patients, their families, their caregivers, and develop a prescription which is more acceptable to them rather than being intrusive to them and take them off peritoneal dialysis. And that's where this individualized care model, which Dr. Vinand has also shown, and I'll show it once again. Earlier in 2006, there was a lot of emphasis on solute clearance, ultrafiltration, clinical judgment, whereas ISPD 2020, where they say, you look at this, make the decision, shared decision making, discuss with the person, caregiver, care team, consider local resources, person's lifestyle, caregiver's vision, decide about the prescription, right? Based on what are the patient characteristics, whether the patient is old, whether the patient is frail, what is the prognosis, what does the patient want out of life. Okay. There are many patients who have terminal malignancy, right? But they have one wish, okay, my daughter is going to get married in 3 months, I just want to live for 3 months. You just need to give them enough clearance so that he survives these 3 months or 4 months, whatever he wants to do. So, tailor-make prescription according to patient wishes and preference. And that's what is going to make the PD success. So the recent guidelines, the more emphasis on health-related quality of life. Look at the quality of patients, volume status, nutrition status. Solute clearance is very much down the line. Okay? More important is how the patient is doing. That's where I will stop.
Thank you, sir, for a very nice deliberation. I think for the paucity of time, we'll push the questions at the end and which answer. Thank you.
For the next part of the session, I will call upon Dr. K.M. Singh, Senior Consultant, Department of Nephrology and Renal Transplant Medicine at Infectious Apollo Hospital, New Delhi, and Dr. Manoj Arora, Director, Department of Nephrology at Max Hospital, Shalimar Bagh.
Thank you, Dr. Kuller and team, for giving us this opportunity. Dr. Manoj Singhal has explained very well. Till up to this talk, you must have understand residual renal function plays very important role. Incremental dialysis, it preserves the residual renal function. That is the most important thing. And second important thing is the fluid overload and solute clearance, which incremental dialysis plays role. And third, just with my clinical experience, I want to add, we are seeing so many patients of heart failure, low ejection fraction, cardiologist wants to use ASARB, RNA and MRA, and due to hyperkalemia is not able to use. In this situation, we can also use the CAPD, that plays a very important role. With this, I invite Vinit there.
Good evening, ladies and gentlemen. At the outset, I would like to thank Professor Dinesh Kuller sir and team Max Saket for giving me this opportunity to come and speak in front of this august audience, many of whom have been my teachers. Also, I feel it is a great privilege and honored to be speaking on this topic, which is of critical importance. To be very honest, all of you would be practicing incremental PD in some form or the other, and probably we also, when we learnt about PD, our teachers taught us about incremental PD, and there has been a lot of hype on this topic for the last decade or so. So My previous speakers have also dealt upon some of the topics which I'm going to talk. So I'll just touch upon some key important aspects of this topic and tell you some tips of how to prescribe PD and highlighting upon incremental PD. So before I start, I would want to know that how many of you have heard this term called Kaizen? Anyone has heard Kaizen? Okay, so no one. So Kaizen is an interesting Japanese word taken from two breaks, that is Kai and Zen. So it means improve and increase. And to my knowledge also, many business models have been based on that how to increase productivity. There are management books on Kaizen. So the incremental movement, the incremental improvement model in business is called as Kaizen. So incremental is not the same as increase or improve. So it is a combination of both. So we have to increase PD and improve PD to make it incremental. So in short, what is incremental PD? So I would start with one of my cases. A 64-year-old lady, a housewife, had elementary education from Srikakulam in Andhra Pradesh. She had CKD-U for the last 3 years, was a poor follower, was a very lean, thin lady. She was stable. During one of her visits, she was found to have a creatinine of 8 and a GFR of around 6 or 5. She had anemia, features of MBD. Obviously, we counseled her for initiation of RRT, but as usual, she had no symptoms, had a good output. So she totally refused that, no, I don't want dialysis. But we persisted, and keeping in view her fear of doing hemodialysis, some logistic issues, we managed to somehow convince her for a PD. So how to go about it? We planned for a percutaneous PD insertion. So do we do a pre-op HD? No. We went ahead, did a direct PD insertion. It was without any complications. No pre-op HD was done. During this break-in period, do we give her interim hemodialysis or do we start urgent start PD? So what we did to tide over this period, we gave her a single cycle of 2.5% for 3 to 4 hours a day. Obviously, she was not trained, so it was done in a supine position by the PD coordinator, and the creatinine was maintained around 6 to 7. She was illiterate and was very difficult to train. We started training, and to be very honest, she took close to 3 weeks to get trained fully. And even after that, we had to do a supervised PD for her, and then she gradually became motivated. We educated her. So now comes what prescription we give her. Do we give a full 4-cycle prescription? No. We tried to amend it as per her requirement. We initially put her on 7.5% icodextrin for 12 hours. This comes with a rider that in my center the government provides the fluids, so it is not paid by the patient. So we gave her a 7.5 cycle of 12 hours, gave her a week, 1 day off. So within a month, she picked up the procedure well, had a small faults. She learned that. After about 1 month, she was on 2 cycles, one 7.5 and one 1.5. Had a good urine output of around 1.5 liters. Produced a UF of around 600 ml. The creatinine stayed between 5 to 6. So she was doing well. After 5 months, as her output started decreasing, her urine output, we had to put her on 3 cycles. And since then, she is doing well on 3 cycles, doesn't have a transplant prospect. We have created a fistula also, and she comes on regular OPD follow-up. So this is how we practice incremental PD. We all discussed, but the 3 important things for knowing a PD is a creatinine clearance, ultrafiltration, and the patient symptoms. The major point we generally ignore is the availability and logistics, which we will see is very important. What are the targets of any PD? It has been discussed, KT/V more than 1.7, creatinine clearance of 15 liters per week, euvolemic state, no hypervolemia, uremic symptoms should be under control, and at the end, the patient should be nutritionally, anemia-wise, MBD-wise, she should be optimal. So in PD, what are our parameters or what points can we fine-tune or titrate to see whether she is doing well or not? Of course, the PD ultrafiltrate we check on a daily basis. The urine output, which is very important because of residual kidney function. Creatinine levels, of course. Weight. Weight is an indirect indicator that whether she is losing more fluid by ultrafiltrate and urine or she is gaining more. And of course, the clinical symptoms and signs are a marker. a very simple way mathematically to know that your PD is working well or not. So your PD clearance in terms of ultrafiltrate plus your residual kidney function, which is measured by the urine output, should be equal to the desired clearance. That is, she's like how much intake she is taking, and should be equal to that. So the residual kidney function and PD ultrafiltrate go hand in hand. When both are equal, they both complement each other. With passage of time, the residual kidney function slightly starts going down, so the PD has to increase, and when the RKF becomes quite less, the PD has to work more. So this is in short what we target in incremental PD. How all can we intervene here? These are the 3 points. For the PD clearance, we can change PD prescription, make the number of cycles more, make the amount of volume more. The other two are generally quite ignored modalities, which we also can alter. Say his residual kidney function is less, we can give him diuretics, or if he is taking more fluid, we can cut down on his intake, cut down on his salt intake, and that also can help in achieving the required targets. So we have some common situations of which we find. An ideal situation is ultrafiltrate of 1 liter, say urine output of 1 liter, and total 2 liters, he is doing well. But this never happens. A more practical is that we have a slightly more ultrafiltrate, urine output for around 500-600, or vice versa. Say the output is very good, say 1.5 liter like our patient. So these are the practical situations. Now where do we intervene? So suppose by giving her 3 or 4 cycles, we find that the ultrafiltrate is 1.5 liters, he or she is producing 1.5 liters of urine. So actually that much of UF or that much of clearance is not required. So we can cut down the UF. And these are the main problems, that is in which the RKF has come down, the output is very low, and the UF is also low. So these are the difficult patients where we have to handle and increase the UF. So this is in practical how we go about doing incremental PD. Coming to some definitions. So there is no proper definition as such. In short, using a lower than standard dose of PD to achieve the goals, and subsequently increasing the dose of PD based on the requirement or the residual kidney function is what we call as incremental PD. The standard dose as per textbooks is 4 cycles of CAPD, or in APD around 10 liter cycles plus a long well. Some centers like some Southeast Asian countries say a 3 cycle is good enough for the population, but what we follow as per standard books is a 4 cycle one. It is a standard dose. So incremental is something in which you start from a low dose, say example 1 or 2 cycles, gradually as his urine output keeps falling, go up on the dose. So this gained popularity by the Italians who in the late 2000s, they started sharing some articles, and thereafter there have been a number of observational studies. From our country, Dr. Tarun Jeluka also shared this interesting article in which icodextrin was used upfront in a few patients and compared to the standard 3 cycle of PD, and the patients had a mortality benefit and had equal clearance. So how do we strategize, or how do we practice incremental PD? So what are the alterations we can do? In CAPD, these are the parameters we can modify. We can change the number of cycles, give him 1 cycle, 2 cycle, or 3 cycle. The dwell volume can be quite low, around 1200 ml to up to 2000 ml, which is the standard. The number of days in a week, it's very important. Even if you give him a 1-day holiday or make it 5 days a week, that creates a lot of satisfaction amongst the patient. And of course, the type of fluid also can be modified. If a patient is on APD, how can we start early by doing incremental? We don't give him a long dwell. Say example, he only does nighttime PD and daytime is dry. Or the dwell volumes, instead of a standard thing of 10 liter or more, we start at 5 liters and then give a long dwell. So in different permutations and combinations, and of course by decreasing the days in a week, we can practice incremental PD. There are 2 other terms which we often confuse, use interchangeably, and there is an overlap, and then practically they actually coexist. So that is conservative PD and palliative PD. So in short, the only difference between them and incremental is that they are inadequate and there is no relation with residual kidney function. Let us see how.
Conservative is the PD which most of us have to resort because of financial constraints, logistic issues, some therapy inertia patient is not doing even if she has symptoms. So even if they are doing a less number of cycles, but as per the requirement he is not able to increase. So how do you identify? Of course, they have signs of low kidney function, inadequate clearance signs are there. Second one is the palliative therapy, which someone spoke before that it is in old fragile patients, his requirement might be quite less. In patients who are going on for an urgent start PD, so a full 4-cycle PD may not be required. So generally we give 1 or 2 cycles just to satisfy the requirement and tide over the basic requirement. We have enough discussed these 3 things. Very, very important while we discuss PD, a goal-directed therapy, a patient-centered approach. We have to select a different prescription for a 80-year-old lady or a 70-year-old lady who is at home than a young college student who is very big muscular. So it has to be a patient-centered, and thirdly, it has to be a shared decision making. The patient who does not have an attendant to do cycles, even if you tell him to do 4 cycles, he won't do. So this has to be taken care, and all these 3 are very important practically while we are addressing PD. Some real life situations which generally I start incremental PD. A patient of heart failure, cardiorenal syndrome, say a creatinine of 5 or 6, you have been struggling with the diuretics, going up on the dose, he's not doing well. He is old, debilitated, has got a decent output. The eGFR is around 15 to 20. I put him on a 7.5% icodextrin, give him 1 cycle, only 1 cycle for about 10 to 12 hours. So that takes care of the ultrafiltrate, his edema decreases and he does well. You can continue with this, with time improve the 7.5 and maybe 1 odd cycle of 1.5 or 2.5 you can add. Second situation, as we discussed in our initial case, a first time patient coming to you with a creatinine of 7 or 8 with a good output, you start him on urgent start PD, and so he has some amount of residual renal function months left in him. So during this period, you can give him, say, initially start with a single cycle, then maybe make it 2 cycles, give him a few months to understand the disease, understand the procedure, get trained, and then go on to full 3 or 4 cycles. Ascites or chronic liver disease, amazing patients. There is never a problem of ultrafiltration. So every time they produce more. So you just put in a catheter and give him low volume cycles, 1 or 2 cycles. The ultrafiltrate is never a problem, and generally they are malnourished. So theoretically the creatinine clearance and also are maintained. And of course APD for bedridden patients who have logistic issues. So we can only do by NIPD, that is night PD, in which we only give in the night. The icodextrin phase we can skip. What are the advantages of PD? It improves the quality of life as the number of cycles become less. The volume is less, so the number of the mechanical symptoms are lesser. It is economical, that is quite obvious. Environment friendly because less amount of water is wasted, and as the number of cycles are less, the metabolic problems are low. Infection risk is lesser because the handling the PD cycles become lesser. 2 most important ones are the last 2, that is preservation of residual kidney function and protection of peritoneal membrane. Residual kidney function, whatever we discussed, is very important, and less number of PD cycles increases the longer the RKF is theoretically known to be better. So there were a few observation studies which showed benefit that incremental PD is beneficial to preserve residual kidney function, but one trial, that is the balance trial, which came up and compared incremental PD versus full dose PD, unfortunately they did not find any benefit in terms of protection of residual kidney function or the urine volume with incremental PD. Other point, it's very obvious that more peritoneal exposure will cause more inflammation, more fibrosis and more damage. So incremental PD, or by decreasing the number of cycles, low volume, use of icodextrin can and will obviously preserve the peritoneal membrane. What are the problems of incremental PD? The biggest problem which I face is therapeutic inertia. A very interesting thing, a patient who has been used to do 2 cycles is very reluctant to go on to 3 or 4. So you have to actually convince him that no, you require 4. It's very difficult. So that is one major problem. You have to closely monitor the patient for his clearance and his kidney function for changing. Anemia and malnutrition, somewhat I feel, are better taken care of by the standard PD of 3 to 4 cycles. So they become a problem. Middle molecules like phosphorus, some articles say that incremental PD may not be that good. And of course, as we are doing incremental PD, the patients who become oligoanuric, they may have a risk of fluid overload. So several articles are there on incremental PD. They have observational studies have shown that the patient survival and number of hospitalizations come down. There is only one good RCT which has compared 3 cycles versus 4 cycles, and they got patients of output of more than 500 ml and followed them up for 2 years in China, and found that there was no difference in groups in terms of GFR, urine volume, and anuria-free survival. The only benefit they found was some amount of peritonitis, and peritonitis-free rates were more in case of less number of cycles or incremental PD. The systematic review also, based on mainly observation studies, shows a trend towards benefit for lesser mortality, lesser GFR loss in incremental PD, but the opinion is not backed up by strong evidence. So I couldn't dig out much of my data. Over the last 1 year, in my center, we have done around 48 new initiations, and I would humbly say that around 60% have been incremental PD. We start with a low cycle, and around out of the 60, around I say 40% do well, and after about 3 months, 6 months, you have to go up on the cycle. I would conclude by one of our initiatives to promote PD. In our region, we launched a PD program in which we'll be providing free PD. We are providing free PD to all our patients of that region. And we started with 0 around 8 or 9 months back. And now we have close to 50 patients of PD. And we plan to increase the number to 100 and target that 25% of our RRT patients should be on PD. Thank you.
Thank you so much for elaborating this very much explanatory bit. So we have to choose these 2 patients, CLD with ascites and a chronic recurrent admission for LVF. Their quality of life changes and their cost is also less, because every admission costs at least 1 lakh per day in ICU in a good hospital. And secondly, if they prevent recurrent admissions, that will reduce their mortality also. So we have to spend some time, because creatinine is always 4, 4.5. They are reluctant, very much reluctant. But once you convince them for this incremental PD, their life changes. And then they thank you after some time of 6 months that they are living a quality life which were dependent only on medicine. But now with just adding a 1 exchange, as he told, we have all are following so many patients and they all are very happy. That's the message. Thank you.
For the next part of the session, I would like to call forward Dr. Devrat Mukherjee, Senior Director Nephrology and Transplant Medicine at Max and BLK Max at Max Gurgaon and BLK Max New Delhi, and Dr. R.K. Yadav, Additional Professor, Department of Nephrology at AIIMS New Delhi, to discuss the topic of ultrafiltration failure in PD.
Dr. Narayan, it doesn't require any introduction to this audience. And STPGI is one of the premier institutes which is heavily invested into the PD program for a long time. And they were one of those few institutions where the nephrologists were doing PD. They have a vast experience, and without any more delay, Dr. Narayan.
Thank you very much, great friend, both RK and all seniors. And first of all, I would like to thank Dr. Dinesh Kumar sir for this kind invitations to be here. And I feel most of the things you are aware by the time when you are discussing one theme topic, then there is a lot of overlap. So, but I can say the most important part of all the peritoneal dialysis prescription is to achieve good ultrafiltration. why ultrafiltration is more important than your solute clearance, getting lesser urea, lesser creatinine. Can anyone tell?
Patient is asymptomatic, symptom free.
Yeah. What is the symptom free? Other important is that most of your patients die because of your cardiovascular problem. And this cardiovascular problem happens not because of this urea and creatinine solute, it is because of the volume of body. So, achieving good ultrafiltrations gives lot of life, it prolongs the survival. This is the reason why high transporter patients who have very good solute clearance, urea creatinine always remains towards the lower side, but mortality is higher than your low average or high average transporter. High transporters die early, mainly because of this volume of body and because of lesser ultrafiltration which happens with this high transporter. Before starting my presentation, I will say I support the education of the doctors against this brutality which happens, and I think every one of you should talk not only amongst us but also to the general public so that these things should not happen, because doctors committee as such are morally down in today's time. PD as a renal replacement therapy, we all understand by the time the very establishment. Actually, three processes happens at a time when you put peritoneal dialysis fluid into the abdominal cavity. One is the diffusion, that happens because of concentration gradient. Other important is ultrafiltration, that happens because of the osmotic gradient which you create by putting high glucose containing PD fluid. And third important is absorption. Absorption might happen through the lymphatics or into the abdominal wall. Diffusion, one thing very important you should understand, diffusion is also maximal by the first hour. By 4 hours, most of the urea, 90% of the urea and almost 65-70% of the creatinine gets cleared. This is the reason why we say our dual time should be ideally how long. So usually we do not prescribe the dual time for 4 to 6 hours usually. So this is the reason where when you prolong this dual time, more fluid will be reabsorbed, there will be lesser ultrafiltration. So that is not required even for the solute clearance purpose. So how fluids is removed? When you put high glucose containing PD fluid, there would be, as by the time you know about this ultra pore and aquaporin channels which is there, so there would be this high glucose content stimulates aquaporin and there would be filtration of the water from the capillary side to the abdominal cavity. That happens through the aquaporin mediated or ultra small pore. It happens 50-50%. 50% through small pore and 50% through aquaporin. But there are some forces which oppose this. Two important reabsorption happens. One is the lymphatic absorption and there is the tissue absorption. If you prolong, suppose every minute 2 ml fluid is absorbed. So if you are prolonging your dual time for 5 hours, almost if you have achieved ultrafiltration of the fluid, 600 ml will be reabsorbed. So you have not to prolong too much until unless there is prescription that you have to put the patient on the night well with a higher concentration of the fluid, and that has added advantage of getting a small solute clearance that depends on the duration of the dual. So usually transcapillary ultrafiltrations may happen up to the 25 ml per minute, and reabsorption can happen 1 to 2 ml per minute. So this balance should be there by prescribing what concentration of the PD fluid should be used, what should be your duration of the dual. So we are aware about the 3-pore model of the peritoneal membrane in first lecture. So ultra small pore, only water with this small pore, sodium, glucose, urea and creatinine, this is small molecular weight substance are clear, and through the large pore usually bigger molecules, but where the protein loss happens. So what is the definition of ultrafiltration? Usually, classically it is thought that, but initial definitions were that if you are not able to achieve dry weight of your patients by using 3 or more 4.25% of the bag, then it is ultrafiltration. This was the older definition. Or second was the rule of 4. I will talk a little bit in details in subsequent presentation. If you have less than 400 ml in the 4 hour with the dual of the 4.5% of the bag, then it is ultrafiltration. This is the modern definition of ultrafiltration. So this is how the modified 4-hour PET. A standard PET, what is the difference in the standard PET and what is the difference in the 4-hour PET? I will show you. 4-hour exchange, 4.5% of the bag, 2 liter fill volume, upright position during the dual, 8 hours of the overnight pre-test exchange. And you can see mid-test serum samples, creatine, glucose or sodium, 0 hour, 1 hour, 2 hours or 4 hours. How many times we collect in a standard PET? How many samples? At what interval? Anybody? 0, 2 and 4. So that is the standard PET. Here we are taking 0, 1, 2 and 4. So that is little difference. So what is extra information we are getting from this modified PET compared to your standard PET? We are getting extra information at 1 hour. What is your free water clearance? How is your aquaporin channel in the peritoneal membrane is functioning? Here in a standard PET only 0, 2 and 4 hours. There 0, 1, 2 and 4 hours. 4 samples. And based on that you can have the characteristics of the peritoneal membrane, PET characteristics, high transporter, high average, low average and low transporters that you can see here. The median is 0.6, 0.6 to 8, 0.8 to 1. You can just remembering purpose for the PG, 0.3, 0.5, 0.6, 0.8 and 1. 0.3, 0.5, 0.6, 0.8 and 0.1. If you will make on this chart, you will remember all of them. So, modified 4-hour PET, this is the rule of, it is called the rule of the 4. 4 hours, 4.5% pack, less than 400 ml, suggest ultrafiltration failure. So it has 3 more important informations comes from the modified PET. One is ultrafiltration volume, more than 400 ml, it is fine. D by P creatine value, if more than 0.8, it is fast transporter. If 0.6, less than 0.6, slow transporter. And other important information comes about the sodium sieving. What is the concept of the sodium sieving? What is sodium sieving? Actually, when you put the glucose containing fluid into the peritoneal cavity, aquaporin channel gets activated and there will be free water clearance for 1 hour. At the 1 hour, suppose your PD fluid contains 135 milliequivalent per liter of the sodium. So with this ultrafiltration, that will be pure water without sodium, it will dilute the content. If that dilution is more than 5 millimole, then you think of your probably the aquaporin channel of this peritoneal membrane is fine. So that is sodium sieving concept. So more than 5 millimole per liter dilution is fine. So what does this, suppose initially there was a recommendation you should do periodically PET. Today's time it is for the why you want to do PET. There was question just before, we can guess. Yes, we can guess. But if you are doing periodically, if sodium sieving is being lost, that will indicate, no, probably your ultra small pore is exhausted now with too much of the glucose load which you are doing. So you can give rest to the peritoneum, you can preserve the peritoneum. Or 1 month of this rest of the peritoneal membrane becomes many times sufficient enough. So that there are many other informations comes out. So what are the causes of the reduced ultrafiltration and volume of it? Reduced ultrafiltration means your patient is going to be volume of it. In every presentation we have heard about the non-compliance. It is very common in PD patients. Excess salt and water intake, incorrect choices of the dialysis tonicity, loss of the urine, residual renal functions, mechanical causes can be there, catheter migration, catheter block, leakage into the peritoneal cavity, sometimes leakage into the parietal abdomen, parietal wall of the abdomen. Hyperglycemia is sometimes true ultrafiltration failure. So, how you are going to approach? One is the clinical syndrome, patient having volume overload. So, initial evaluation, you will think of what are the reversible causes of this ultrafiltration failure. Then go next to the step evaluation of the peritoneal membrane function. So, reversible causes. What could be the reversible causes? Dietary discretion, you can see where your patient is taking too much of the salt. Whether patient is really properly educated or not. Sometimes what happens, patient say, I'm fine today, I'm doing only one exchange. Why doctor is telling me to do 2-3 exchanges? So where patient is properly educated. Whether you have given the very complex regimes. If you will be giving the complex regimes, the patient will not do. Suppose you will giving this do 2 exchanges at the night time, 5 exchanges, patient will not do. Burnout of the caregiver. Sometimes the school going boy taking care of their parents gets exhausted. They have their whole life ahead. So burnt out of the caregivers or the patients, both are equally important. Then you think of where your prescription is appropriate. We have good lecture by Professor Manoj Singhal sir about the prescription management, dual time, dialysis tonicity, that you have to look into. And then the mechanical problem. Suddenly your patient has a good ultrafiltration and one day coming to your OPD that no, today I have less ultrafiltration, for past 3-4 days do not have ultrafiltration or they are not, fluid is not coming out. Then you can think of the leak, obstruction, entrapment, malposition of the catheters. So these are other important. These are reversible causes. Once you have established this ultrafiltration response, then you think of whether this is the true ultrafiltration failure, modified PET, 4.5% of the bag, less than 400 ml in 4-hour dwell, or whether more than 400. More than 400 ml, there is something wrong. You can think of probably the non-compliance might be the problem. If less than 400 ml, you can think of probably we are dealing with the true ultrafiltration failure. There is some membrane dysfunction. So what you will do then? Then comes the role of, you should think of, do the PET, see for the solute clearance. What is the solute clearance then? Here comes again the role of PET. So D by P creatinine less than 0.5. This shows along with this ultrafiltration failure and low solute clearance indicate probably there is damage of the peritoneal membrane. Adhesions, too much of the adhesions or sclerosing peritonitis, your membrane is getting exhausted. High transporter, more than 0.8. Inherent high transporters, that is sometimes generally it is in 15% of the cases. Recent peritonitis, acute peritonitis. During that period, usually the patient would have the ultrafiltration failure, but solute clearance remains very good because this membrane is very much permeable. And then third one is the long-term PD. If the patient is on long-term PD, 4 years or 5 years, there would be neoangiogenesis. I will talk a little bit later. And there would be increased reabsorption of the glucose, osmotic gradient will come down, and ultrafiltration failure will happen. When between the 0.5 to 0.8, whether this is the average characteristics, think of, probably membrane is not bad. Is there any mechanical problems? Is there reduced, enhanced reabsorption? Sometimes lymphangiogenesis happens, and or there is aquaporin deficiency. So that's how here the PET plays a role. So you might have 3 situations. Only UF problem, only solute clearance problem. We have both UF and solute clearance problem. So ultrafiltration failure are classified in 2 ways. I have written one time in a book that has been published in many, everyone was quoting about this classification. Subsequently, another classification came into the another books, and at present what I am showing, the classification 1, that is also came out in the up to date. Class 1, type 1 ultrafiltration is high transporter, type 2 is aquaporin defect, type 3 loss of the peritoneal membrane, type 4 is increased lymphatic absorption. Remember this. What was the confusion? In the older classification, high transporter, type 2 was the loss of the peritoneal membrane function, and type 3 was increased lymphatic absorption, and type 4 was aquaporin defect. So type 2 in newer classification was type 4 in older classification, and in many textbooks you will read type 3 and 4 has been described all together, lymphatic absorption and aquaporin defect. So this should not be the type, but in principle you have to think of ultrafiltration failure along with the solute clearance. That is more important. That conceptually makes you where you are dealing with. So 3 causes of type 1 ultrafiltration failure: low UF but high solute transport. Here, inherent high transporter, recent peritonitis, high transport during the long-term duel because of the increased neoangiogenesis. That happens because of the increased production of the advanced glycation end product in the PD fluid, that is acidic, sometimes because of the peritonitis and inflammation and duration of the COPD causes. So causes of inflammation becomes very important. That might be the uremia per se, might be related to the PD catheter, or might be associated with the dialysis solution per se. So what you can see here in upper figure, mesothelial cells, in the lower figure, mesothelial epithelial cell transition. So many of the mesothelial cells layers have been transformed into the epithelial cells characteristics. Only few vessels in some mesothelial layers, there are lot of neoangiogenesis, and that increase the permeability of the peritoneal membrane, and there will be increased reabsorption of the glucose. Osmotic gradient will be rapidly lost. There will be less ultrafiltration. So here is the one patient, all 6 years of the PD. Here we can see the thickness of the submesothelial part. That becomes too much thick. Only these changes start soon within a month time. Where you see when peritoneal membrane starts thickening of the peritoneal submesothelial layers starts happening. So, and gradually with the neoangiogenesis, multiple problems, you might have the narrowing and obliteration of the vascular lumen gradually over the time because of this increased advanced glycation in products. There will be peritoneal fibrosis that can be detected in 50 to 80% of the patients within 1 to 2 years. And many times on the longer period, we have encountered at least 3 peritoneal dialysis patients who have sclerosing peritonitis because of the longer duration of the peritoneal dialysis. It is uncommon in our parts of the world, but it happens. So type 1 in ultrafiltration failure in summary, hallmark. What is the hallmark? Whenever you have the new onset D by P creatinine of more than 0.8, understand that probably we are dealing with a patient with the complication of the long-term PD. Your PD membrane has increased neoangiogenesis. Probably it is likely to, you can give rest to the peritoneal membrane. So this, how you manage this type 1 ultrafiltration failure? By giving the ipodextrin, by shifting the patient on automated peritoneal dialysis, increase the exchanges, you will get better ultrafiltration. High glucose concentration dialysis. Many times during the peritonitis, when you have the ultrafiltration failure, change the patients on ipodextrin. That will give you good ultrafiltration. Peritonitis will resolve. Automatically this ultrafiltration will regain. So type 2 ultrafiltration failure. 3 important reasons. Multiple adhesions because of the recurrent peritonitis. Peritoneal sclerosis, that happens because of the long standing of the PD, and sometimes sclerosing encapsulating peritonitis, sclerosing peritonitis. So, but incidence is very less. Like you can see that in the CT scan picture you might have, when you get this CT scan of the abdomen, mesothelial layers thickening of this parietal peritoneum, you can think how much thick it is, and you would have some calcification over that. That will indicate probably you are dealing with sclerosing peritonitis. And when you will see the histological findings, usually there is a opening of the abdomen, all of the small bowels. So, what is the treatment? Decrease solute clearance and ultrafiltration, secondary to decrease the effective surface, because everywhere there is fibrosis, so surface area is less. So you would have no ultrafiltration, there will be no solute clearance. So here is the find. No solute clearance is also low, ultrafiltration is also low. So usually these patients needs to be shifted on other modality. Transfer these patients to hemodialysis temporarily, use high dosage of the loop diuretics. Sometimes if sclerosing peritonitis is suspected, give rest to the peritoneum. Start with the steroid, azathioprine, meclopramide. Don't have time today to discuss this here, but these are the drugs which have been tried in sclerosing peritonitis. Tamoxifen has been tried, and finally many of these Japanese persons have done enteroclasis, release of this opening from these adhesions, and they have got succeed, but mortality is very high in this group of patients. So newer classification type 2, aquaporin deficiency. So by knowing the sodium sieving concept, at 1 hour, if you have the sodium sieving defect, your fluid is not getting diluted more than 5 millimole per liter, you think of probably you are dealing with this aquaporin deficiency. It is usually genetically determined. One of the study in the PD fluid has shown this TT genotype of the aquaporin 1 SMP was significantly lower, had significantly lower net UF than compared to the wild type CC genotype. So this was the one study, and usually icodextrin may be helpful in type 2 ultrafiltration aquaporin deficiency, because that induces ultrafiltration by non-aquaporin channels. Type 3 ultrafiltration failure, lymphatic absorption. With the long-term PD, peritoneal lymphangiogenisis happens, and animal model has shown lymphangiogenisis is increased in the presence of the peritoneal fibrosis and may play a role in its pathogenesis. How you can diagnose this is increased lymphangiogenisis is there, or lymphatic absorption is high. Reabsorption of the dextran 70 or radio level albumin. You can think of how much of this dextran 70 clearance happens. That happens through usually this increased lymphatic absorption. So that techniques can be used indirectly, can give you help. Or icodextrin reabsorbed through the lymphatics. So that also gives you indirectly the help. So adjunctive HD or permanent transfer to hemodialysis might be required. High dose loop diuretics you can try to get the good volume. Type 4, older classification, again that is the same aquaporin deficiency. Here I can say many times one of the drug called bethanicol. Now that has been used to contract the lymphatics. Lymphatics has contracted with the bethanicol and usually might be effective. These are all theoretically that is required for the PG students only, not for the clinician, and this would not try this medicine, but PG students would know. So bethanicol can be used for this purpose. Icodextrin may be useful in type 4 ultrafiltration failure. Mechanical problems should be ruled out during initial workup, whenever your patients come in. So volume overload, road of PET, where is the road. D by P, creatinine, also low, ultrafiltration also low, type 2 ultrafiltration failure, peritoneal fibrosis, defect in the peritoneal membrane. High solute transporters, either it might be because of the acute peritonitis or longer dwell, longer time of the peritoneal dialysis with increased neoangiogenesis, and this might be other situation. Unchanged D by P creatinine. If you have good drain volume, loss of residual renal functions could be there. If poor drain volume, catheter malfunction, leakage of the dialyzer, or excessive fluid intake you can think of. So that's how this helps all when you will put the ultrafiltration and PET characteristics all together. So management of the fluid overload can be both pharmacological or non-pharmacological. Non-pharmacological way, always put your patient on the low sodium type. Impact of the various PD prescription on thirst. What Dr. Singhal was telling you, when you have the frequent exchange, ultrafiltration which will happen initially within the first hour will happen with the pure water. And the sodium concentration will go on increasing in the patient. So there will be hypernatremia and patient would have the increased thirst. So you should also think of whether your patient without any change in the prescription, you have doing more and more dialysis and patient is feeling thirsty. This might be the one reason. So pharmacological treatment, diuretics, AC inhibitors, for your information, that preserves the membrane function and that reduces the thirst also. So indirect impact on the thirst is there. And patient have no fear of the hyperkalemia in PD patients. So you can use AC inhibitor or RAS blocker in any peritoneal dialysis patient. So overcoming inadequate ultrafiltration, shorten the dual, increase glucose concentration, use adequacy solution, you can shift the patient on APD, echo massage, peritonitis, systemic inflammation, bioincompatible PD solution, local peritoneal inflammation. This inflammation is not necessarily because of infection. This might be sterile inflammations happened because of the low pH of the fluid, high glucose content, and that will over the time will give the high peritoneal transport, increase glucose absorption, decrease osmotic gradient, decrease ultrafiltration, increase use of the hypertonic solution, and high glucose tissue injury. This becomes the vicious cycle. So we should understand this fact. And in the last, thank you everybody for your patient hearing. And I would like to invite you all. You all understand that this time WCN is happening in your vibrant city, New Delhi, and you all are postgraduate students, and deposit as much as possible of your abstract. And for your information, I am just giving you only 54 abstract has been submitted till date. So we need to have at least 1,000 of the abstract, at least and at least 500 of the abstracts will come from India. So as much as possible, submit the abstract. Thank you, ladies and gentlemen. Thank you.
Sir, as usual, excellent presentation. Almost covered every part of our discussion. Thank you,
For the next topic of this session, I would like to call forward Dr. R.P. Mathur, Professor and Head at the Department of Nephrology at ILBS New Delhi, and Dr. Kulwant Singh, Principal Consultant, Department of Nephrology and Renal Transplant Medicine at Max Saket.
My pleasure to introduce my teacher, Dr. Broaden, who is Senior Consultant at Department of Renal Sciences, Sir Gangaram Hospital, New Delhi. So, sir,
Thank you, Dr. Kulwant, Abhishek, Deepak, Rahul. The topic is what's the peritonitis having implication? It increased morbidity, cost, hospitalization, catheter loss, transfer to HD, and transient loss of ultrafiltration. 2022, new guidelines came and they set new targets of peritonitis less than 0.4 episode patient year, culture activity less than 15%, and peritonitis free more than 80% per year. And so these are the few new targets. So I will cover my talk under these headings. So the infection in the PD is peritonitis, tunnel infection, and exit site infections. So how to diagnose a peritonitis? As per ISPD guidelines, at least 2 of the following should present: clinical features consistent with peritonitis, dialysis affluent more than 100 WBC with more than 50% PMN and positive dialysis affluent culture, and special consideration is for APD. Why? But APD, even if the cell count is less than 100, but the PMN is more than 50%, you should consider it peritonitis, and daytime you will use 1 liter 1 liter solution and dwell for 2 hours. So pathogenesis is mainly interluminal, then it periluminal, bowel source, hematogenous or transvaginal, and causes most common is bacterial, and it may be because of touch contamination at the time of exchange, catheter related endogenous peritonitis. If you go to the etiology, the most common is gram positive in various studies, followed by gram negative, and even in DOPS study it was most common was the gram positive, followed by the gram negative organisms. The study from the STPGI, the initial 2003 by Dr. Narayan Prasad sir, the gram positive was 40% and 60% gram negative, but subsequently in 2014 it was found to be mainly the gram positive organisms, but it in various from region. In South Indian studies it is gram negative organisms more important, even over study is more gram negative organisms, and relapsing and repeat is more with the gram negative organisms. So comes to a patient who is having on CAPD for last 1 year, presented with pain, fever and cloudy dialysis, and she started these symptoms within 24 hours ago, and there was diffuse abdominal tenderness at that time. When this patient comes to you, you should ask for recent contamination, accidental disconnection, has any endoscopic or gynecological procedure, constipation or diarrhea, past history of peritonitis, inspection of the catheter and exit site infections. And differential diagnosis could be because of culture positive or negative infectious peritonitis, chemical, eosinophilia of the effluent, hemoperitoneum, malignancy or chylous effluent. So this is the most important thing, how to collect the sample. What we do at our center, we drain bag is inverted into the fill bag, and bag is inverted several times to mix its content, and whole PD bag is sent to the lab, and 7 to 10 ml is taken for cell count from the pot, and 50 ml PD effluent is rotated at 300 for 15 minutes, and sediment is supinant inoculated on bactec. And this is this is a pot from where the antibiotic pot from where you will collect the sample, and you will do it gram stain, often negative, but centrifuge increase the utility, and it is important to detect the fungal elements. So in some centers normal bottles are used, blood culture bottles are used, but the more utility will get the rapid blood culture kits like Bactec, and they should not store in refrigerate, it should be incubated at 37 degree, and blood culture should send if patient has sepsis or immunosuppression and positive culture suspect enteric peritonitis. Another novel diagnostic technique, but none of them is superior to the conventional technique. So once you have established a diagnosis, you should start the patient immediately IP antibiotics, that is intraperitoneal antibiotics, 1 gram positive coverage, 1 gram negative coverage. Initially when I was a resident, the choice was the cephalosporins. Now it converted into the vancomycin, and gram negative either in the form of aminoglycosides or third generation cephalosporin. Recently the cefepime alone monotherapy may be accepted alternative. So you should keep IP antibiotics minimum for 6 hours. Another thing what you should use is 500 international unit IP heparin per liter, means you will use per bag 1000 heparin, and you should start oral antifungal prophylaxis also. So this is monotherapy of cefepime is non-inferior to the other treatments. IP is preferred. IP aminoglycosides should be administered as daily intermittent dosing, not continuous dosing, should not exceed more than 3 weeks. And this is query oral and acetyl therapy may prevent the aminoglycosides ototoxicity. Similarly, the vancomycin is preferred IP intermittent because 90% is absorbed in the presence of peritonitis. The target is to keep the trough level more than 15 microgram per ml, but role of measuring the trough level is controversial. In general, a dosing at an interval of 4 to 5 days they are given. So these are some common medicines which we use, like cefazolin 15 milligram per kg daily for long dwell, and ceftazidime 1000 to 1500 daily, and these are all given. And especially we use frequently the vancomycin, that we can use 15 milligram per kg every 4 days and 15 to 20 milligram per kg every 5 to 7 days. Special considerations, what you should do for APD patients. Intermittent IP dosing can be given in day 12 of APD patients. Insufficient evidence to make a recommendation as to switch to CAPD during treatment of peritonitis. So another concept is when we have given 3-4 liter lavage. Augmented peritoneal lavage should not be performed for the purpose of improving peritonitis cure. Icodextrin should be considered for volume overload during acute peritonitis. How to monitor? Now, daily cell count. But you take a newspaper, put the peritoneal bag on that, and try to see you are able to read the words beneath that bag or not. If there is a clearing of the decrease in TLC by 50% in 3 days, there is indication of response. If there is no response, repeat the culture, and if there is no response in 5 days of appropriate therapy, you can remove the PD catheter. May wait longer if WBC count is decreasing depending upon the patient condition. And this is one study which shows that if your cell count is more than 1000 on day 3, it is unlikely to respond and you should remove the PD catheter. Now comes to the Staphylococcus aureus peritonitis. For this, the duration of the treatment is 21 days. If methicillin sensitive, first generation cephalosporin resistant, vancomycin, and in relapsing cases you can add rifampicin. In some patients IP daptomycin has been also used. Teicoplanin is not preferred because activity on MRSA biofilm is impaired in PD solutions. And other gram-positive, you can give the therapy for 2 weeks. So Staphylococcus aureus, you keep given the treatment for 21 days, MRSA change to vancomycin, and for other gram-positive for 14 days. So comes to the enterococcus, which can be microbial or as a part of polymicrobial, and the treatment is ampicillin. In ampicillin-resistant cases, vancomycin, and polymicrobial, you have to give the 2 or 3 antibiotics. And duration of the treatment is 3 weeks, and if no clinical improvement, remove the PD catheter. Now these are the Pseudomonas, Acinetobacter, Streptomonas. You have to give the combination of therapy, and duration of the treatment is around 3 weeks, and same indication of removing the catheter. These are the another gram-negative bacteria. For the gram-negative bacteria, the duration of the treatment is 3 weeks, and in majority you have to give the combination of therapies. The polymicrobial peritonitis could be because of gram-positive or gram-negative, and here also you will give the combination of therapy, and if no response, you will remove the catheter. If there is a response, then you have to give the therapy for minimum 21 days. So in most of the cases, the duration of therapy is 3 weeks, except non-Staphylococcus aureus gram-positive bacteria. Now comes to the culture-negative peritonitis. It could be because of misclassification from slow-growing atypical organisms, suboptimal sample, and maybe because of recent antibiotic exposure. Culture negative on day 1, day 2, continue treatment. See if there is a response, continue the treatment. If there is no response, think for fungal, mycobacterial. And now comes to culture negative patient. This patient is having stomach pain, diarrhea, nausea, vomiting, fever for 2 weeks. And this patient was having high, mainly polymorphic leukocytosis. Antibiotic was given, no response. Later on turned out to be AFP positive and started on ATT. What is the typical presentation? Typical presentation is in abdominal pain and fever. PMN pleocytosis is there. Culture by the time it reaches you are very late. ADA sensitivity specificity very low. PCR sensitivity specificity is just 32%, not more than that. So duration of treatment is 12 months. Induction therapy initial phase is for 2 months, followed by 10 months of more therapy. And by the time you are able to diagnose, you are late, and early diagnosis decrease the mortality. Now comes to the fungal peritonitis. Fungal, it should be suspected after recent antibiotics treatment for bacterial peritonitis, and mainly the patients are immunocompromised. And what should you do in fungal peritonitis? Immediately catheter removal and treatment for 2 weeks after catheter removal, and sometimes for 4 weeks. And the treatment depend upon the species, ranging these fluconazole, aspergillus, voriconazole, and mucormycosis, IV, amphotericin B, and fluconazole. And previous studies have shown the mortality up to 50 to 90%. But irrespective of the treatment duration, we put a catheter after 15 weeks in a study. It was in less than 1/3 of patients. Reinsertion of the catheter could be done. So in bacterial peritonitis, 2 to 3 weeks, but in fungal peritonitis, you have to wait at least minimum 2 to 3 months before putting a catheter. And non-tuberculars, the duration of therapy is 6 weeks. Now comes to the exit site infection. The exit site infection is the purulent discharge with arrhythmia. Tunnel infection is there is arrhythmia, edema, and induration or tenderness over the subcutaneous pathway. The organisms responsible, most common is Staph aureus, gram-negative, and others could be responsible. Send a swab culture, oral treatment in the form of cefalexin, or if it is methicillin resistant, then vancomycin, gram-negative ciprofloxacins. This is the treatment summary for exit site infection. If exit site infection 2 weeks, if exit site with Pseudomonas 3 weeks, all tunnel infections 3 weeks, and antibiotic to all cases. If you don't treat, then there is a chances of 30% peritonitis. So this is basically the empirical antibiotic therapy in cephalosporins, vancomycin, and in Pseudomonas you have to give the combination of the therapy. Now the last part is how to prevent. The modified part are hypokalemia and medical procedures and H2 inhibitors. So should we give systemic prophylactic antibiotic prior to catheter replacement? Yes. Should we no data exists on the effectiveness of routine screening and eradication of Staph aureus nasal carriers before catheter insertion, and prophylactic antibiotics after wet contamination, and oral antibiotics post catheter trauma. No particular catheter is better than standard silicone Tenkov catheter for prevention of peritonitis. Dual cuff is better. Downward directed exit site. Exit site should be round and tissue should fit around the catheter. Should be kept dry until well healed. Sutures at the exit site increase the risk of infections. So this is odd ratio of developing infection without antibiotic is 11.6. And you should first educate the patient, good hand washing, drying of the hands, and regularly monitoring the patient technique is important. Flush before fill, system with fewer connections so that patient can easily learn. Fungal prophylaxis during antibiotic therapy, antibiotic prophylaxis for the procedure, and prevention of the bowel source of the infections. Should be applied at the exit site the muprocin or gentamicin. This recent recommendations and downgrade about this, and in our center we usually use this for initial 3 months, not more than that. During any procedure, give prophylaxis like colonoscopy or gynecological procedures, and keep the abdomen empty during this procedure. Avoid hypokalemia, avoiding or limiting use of H2 receptors antagonist. Hypokalemia in this paper is a risk factor for peritonitis and high risk of mortality. And H2 receptors antagonist is the risk factor for enteric peritonitis, so use should be limited. So these are the few definitions which you can see. Refractory, no response in 5 days, relapsing within 4 weeks, the same organisms, recurrent with different organism within 4 weeks, and repeat more than 4 weeks. Indications of catheter removal are refractory peritonitis, relapsing peritonitis, fungal peritonitis, polymicroorganisms, and when to reinsert. 2 to 3 weeks of clearing of infection. We are successful only in few because of adhesions and membrane fold failure, and there is no definite test which can predict adhesions pre-insertion. So another big question is used to ask PETs. The PET should not be allowed in the room where the PD is done. Avoid hypokalemia and H2 receptors antagonists. To summarize, the PD peritonitis negatively affects short-term and long-term outcomes. Bacterial peritonitis is common. Gram-negative and polymicrobial infections, low cure rates. Identify organisms vitals to facilitate target therapy. Secondary and antifungal prophylaxis during treatment warranted. IP antibiotic doses need to optimize, especially in APD, and pharmacological studies needed. Thank you.
For the next talk, I would like to call upon Dr. Saurabh Pokhriyal, Principal Director, Department of Nephrology and Renal Transplant Medicine at Max Hospital, Dwarka, and Dr. Gagandeep Chhabra, Director and Unit Head of Department of Nephrology at Fortis Memorial Research Institute, Gurgaon, to discuss the non-infectious complications of PD.
RML, and he'll be talking about the non-infectious complications of peritoneal dialysis.
Thank you so much for the opportunity, sir. Actually, it is a great opportunity for me to stand in front of Dr. Professor Narang Prasad, because he has been my teacher. I have been learning PD from him 10 years before. And in a lighter sense, it is also a ragging for me to come after Professor Narang Prasad, because Professor Narang Prasad has almost, one of the advantages of coming at the end, there are two advantages. Your topic will be mostly covered by the other faculties. Now all the people will be waiting for you to complete the session. Right? So you are at my grace for having your dinner. So I will get the opportunity to ask some questions from the postgraduates or the nephrology colleagues if I have been permitted. So you'll be asked questions in between. So the infectious complications and the non-infectious complications are the other side of the coin. When you want to increase the PD survival, so you need to manage both of these very well. So the presentation overview will be, I will be covering the complications which is due to peritoneal catheters per se, and the complications related to the process of peritoneal dialysis, the ultrafiltration failure which Professor Narang Prasad sir has covered, and the metabolic complications, and I will be try to stick to my time of 15 minutes. So the catheter related complications. So regarding catheter, I will be sharing certain experience, although my experience is limited to 100 catheter insertions. So 50 odd catheters are inserted by my residents. So what I would like to tell to the residents is, when you plan for catheters, all these intraoperative complications you should be keeping in mind. The better planning gives the better outcome, you always know. And we felt, and it is also there in the literature,
that as you learn as a residents, right? So we learned as a resident when no formal teaching of PD was not there, and we just opened the abdomen, we start putting PD. That's how we learned peritoneal catheter insertion. So out of 50 catheter insertion, so I would like to share a certain intraoperative at a certain early complication, and I will take you to certain late complication of catheter. So I would say I was previously in a state where PD was free, fluid was free. So people used to say that to have a single room for dialysis patients, I was treating a PD patient who is a slum. So she lives in a slum under the staircase of the other persons, right? So she used to have only that area. So in that patient we did PD and we could make her survive for around 3 years, and that patient did not develop peritonitis, but she developed the poor outflow. So this is a kind of non-infectious complications of PD. So in the initial intra complications, what you can see is the bleeding like this, right? Even a 2 ml of blood can make the fluid so hemorrhagic, and you'll be afraid of seeing that. But it's one of the slightly common, right? I would say out of 50 catheter incisions in last 3 years by the postgraduates, we have found around 20 cases, and all of the cases went with conservative management. Nothing we did, just we want to do some early flushings. So sometimes the major or minor bleeding which can happen due to PD catheters, it's not uncommon, and it is mostly due to the injury of small blood vessels which is there in the momentum or due to the trauma of, and certain times the muscle injury, right? If you are going paramedian, certain muscle injury can also cause hematoperitoneum, and as little as 2 ml of blood, right? It can render the 1 liter fluid blood tinge. And other important cause which is not in the intra complication is you should not miss out menstruation. I have not seen this complication per se in a female patient. And the management of hematoperitoneum, first of all, you need not fear and just watch for fall in hematocrit. Right? The hematoperitoneum puts at the risk of blood coagulation, so you need to give anticoagulant which is heparin. We used to give 500 units per 1 liter of dialysate until it becomes clear. Certain times we put the patient on APD or rapid exchanges, which helps in amelioration of bleeding. And we need to evaluate the coagulation state, and if the bleeding is continuous, it is prolonged, we give fresh frozen plasma infusion, and many times it ameliorates. So the other important complication in out of our own 50 patients by the postgraduates, we had 2 bowel perforations. So in the 1 bowel perforation, while doing the PD, when they remove the stellate, there was fecal and matter coming out, and that was the first bowel perforation I heard. So we were getting the surgical opinion, and the surgeons as usual, they want to open the abdomen, they open the abdomen, and it becomes a more comorbid or morbid surgery. So what happens in bowel perforation is, it is incident has to be less than 1, and it depends on how well you are doing the procedure. And the symptoms are usually the patient can have an acute abdominal pain, and sometimes feculent. If this catheter gets inserted into the colon, we may get feculent. The most common part of bowel injury is jejunum, so you may not have the feculent material. So there you can have a diarrhea, and which may be missed actually in the, like if you don't get a good outflow, but you close the procedure, end the procedure, and the patient may have a diarrhea which can occur after dialysate installation. And how do you detect it? You can go for eye stool examination, which may show eye glucose concentration. And all this, if they have a period of peritonitis, it is mostly of gram-negative peritonitis if bowel perforation happens. And the initial diagnostic evaluation, we can go ahead with CT. And it is better to have a multidisciplinary or team approach to the evaluation by the surgeons. And in the next bowel perforation case which we had, we treated the patient. I thought, like, if the bowel, even if it gets injured, there is a property of self-healing, right? So because the previous surgery was very morbid, we decided to manage with the conservative efforts. So this patient went good. We reinserted the PD by mini-lap laparotomy after 2 weeks of this episode. So this happened, all this bowel perforation happened in percutaneous technique. So we need to be very careful when selecting the anatomy, and also we have to consider the overall height of the patient, overall body surface area, because all these things makes you to decide well before while doing the procedure. The other rare complications are perforation. I have happened to see this perforation in my while I was doing the residency, although it is uncommon, right? But the risk is increased when the patient is having intrinsic abnormality in the bladder, like the bladder muscle is bigger and the bladder is enlarged, like neurogenic bladder. All these things makes the patient to have an higher risk. So one important teaching point is always make sure that your patient passes urine or completely evacuates the bladder when you go for the procedure. So the other important complication when you do catheter is catheter misplacements. Many times it is pre-peritoneal placements when you don't have an outflow failure. The other teaching point here is when intraoperatively if your catheter is not working properly, do not close the catheter. See, if the catheter is not going to, it is not working intraoperatively, it is not going to work postoperatively. So always make sure that your catheter works, and even it takes time. So sometimes as a beginner you may have, we can complete as an experienced person within 45 minutes. As a beginner it may take 2 hours, 2.5 hours also, but never close it or ask for help when you don't have an outflow. So this is one of the interesting patients. This patient, this was a published case where the catheter was there in the pre-peritoneal space where the patient was doing PD for 3-4 years. The 3-4 years of pre-peritoneal, the catheter placed in the pre-peritoneal space, and this is the fluid, 2 liters of fluid is instilled, and when the clearance was not happening, then they evaluated with the CT scan, they saw that this catheter is not at all in the pre-peritoneum, all the fluid were in the extraperitoneal space. So these are the case reports which makes you to think that sometimes we may have to think about pre-peritoneal catheter placements while doing or even after sometimes. So the outflow is very important. By this patient was taking PD for 4 years in the extraperitoneal space. So the early complications are impaired catheter flow, and the malposition are the impaired catheter flow, right? The inflow or the outflow impairment can happen. The incidence is 1 to 20%, and there are the flow. The impaired flow can be outflow and inflow, as I mentioned. The flow can be due to an extraluminal, right? When the catheter has been occluded by the bowel, usually due to constipation, it can happen anytime. That usually not in the immediate period, can happen anytime. Or the intraluminal catheter occlusion, usually by the fibrin clot, and it can usually affect both outflow and the inflow, and mainly the outflow. And sometimes you can have a catheter kinking, where you can detect where there will be outflow issues, and also there may be an inflow issue, or the catheter malposition, or we call sometimes as catheter migration. Sometimes catheter can be entrapped by the omentum or adhesions. So it can mimic an dialysate leakage. We have to be well aware of it. And in all these occasions, we can treat empirically for constipation with laxatives and enemas, and empirically treat suspected intraluminal catheter occlusion with the help of what we do is we insert a trocar or a stiff gateway and try to like there's a whiplash technique. I'll let you know about it. So this is again a malposition or entrapped catheters. So malposition means the catheter are migrated. We can see the catheter usually wants to be there in the pelvic cavity, in the introvesical or the rectovesical pouch. In the females introvesical, in the males vesico after the bladder and the rectum. And what we can get is these are the migrated catheters or malpositioned catheters, where we can bring it down by conservatively managing with laxatives, and the reposition can be tried with sterile gateway or trocar. So sometimes if it is unsuccessful, we may have to reinsert the catheter, or this laparoscopic correction may be given. The other important, the tips of preventing this catheter, what we were doing previously was to put the bursting suture, and now we started doing this in peritoneal wall anchor technique, which was published in 2021. So we do currently we have done this in a single patients. This many times we feel that if you don't do nothing, if you don't do anything, and the procedure is good enough to have a good outflow or inflow. So if you do many procedures and if you are not sure of the angle and the curvatures, it will be difficult to maintain the outflow. So this is one the anchor technique which I was telling you. So catch hold of the anterior anti-rectus sheath and separate the muscle. This is done in mini-lab technique, and catch hold of the peritoneum. And here is you will be inserting the catheter just 2-3 centimeters below this. You just insert the take a suture and keep this forceps down, and you remove this. You make a suture like this, and then you insert the catheter. So what happens is, by after inserting the catheter, by 2 to 3 centimeters, you are going to make a suture again here, so that this catheter probably will not go in for migration above the umbilicus, we can see. So other important complication is omental wrapping. So omental wrapping here, if you see, if you inject the there's a problem in outflow, sometimes inflow, and here you can have an if you inject at the contrast, the contrast has to flow freely, but it is not flowing, probably due to omental wrapping. This is how it is. It will be visible in nephroscopy. So here, conservatively, if you want to manage, here we can follow the whiplash technique. What is whiplash technique? You insert a trocar till here, just 5 to 7 centimeters before the end of tip of the catheter, and after entering here, keeping the anchor as an the cuff, deep cuff, you just move like just make movement like this, and these movements make detach the catheter from the omentum probably, and then we can remove the trocar and we may readjust it. But we have tried in a patient, we actually our the procedure success was not that great. So again, the patient has to go for reinsertion. This is the whiplash technique. So again, the other important intraoperative complications is the peritoneal catheter kinking. Whenever there is a inflow problem or outflow problem during insertion, always make sure that this kinking does not develop. And if the kinking is superficial or near to that insertion line, you may dissect that and you can correct it. Sometimes it may require repositioning or replacement of the catheter. So other important complication is pericatheter leakage. There can be two. It can be early or late. Early we call it as less than 30 days. It is usually related to the procedure, and here you can there will be an edema, genital edema, abdominal wall edema, and the late leaks are usually because of the any gap which is formed because of tunnel infection or the hernias or the abdominal wall. Here the patient presents with abdominal wall edema or hernias. So there will be a decreased ultrafiltration or the outflow, and the patient can have breathlessness. So the pericatheter leak can be diagnosed with the help of IV contrast CT or sometimes the peritoneal CT peritonography. CT peritonography is you do CT, but while you give contrast via the intraperitoneal tract of around 100 ml, and you see whether the contrast leaks or not. Again, you can do an scintigraphy also, and the MRI also we can do and check for the fluid accumulation in this space, right? The white colors are the fluid. So early leak you can manage with dual volume management. If the leak persists, you may have to stop PD for 2 weeks. And the late leak, it depends on the cause. You identify the cause, treat the cause. And by how to prevent it, whether this has been, we can inject fibrin glue when we insert the catheter, or when we know when there is pericatheter leak, we can insert through incision down, and you can insert the fibrin glue also. I don't have any personal experience on this. The catheter clot can be there with the fibrin. The fibrin clot can be removed, or like we can use fibrinolytics. The common fibrinolytic we were using was TPA, now we are using Retiplase. So because of time, I am not discussing much. So the management of clot, we need to know what is the volume of the overall volume of the catheter. So we use the 42 centimeter catheter. So the calculated volume is 2.26 ml. You add 2 ml to the transfer side volume. So you need 4.26 ml for a clot. So we inject that much amount of volume and wait for 2 hours. Actually the half-life is 30 minutes only. So wait for 2 hours and aspirate. And if it opens up, that's fine. If not, you can repeat the procedure, or you can give higher dose. So the other important non-infectious complication is the extrusion of the superficial cuff. So this extrusion will be usually basically depends on the three things. One is the weight of the overall fluids and the shape of the catheter, right? How the resilience force of the tunnel is created, So we need to keep the resilient force of the tunnel, which should be minimized by creating a tunnel which is synchronized with the curve of the catheter. And if it is not infected, we need to look for the signs of infection. If it is not infected, we can save this external cuff and we leave it like this. And if it is infected, we have to treat like exit site infection. So can anybody tell what is this complication? This is hydrothorax simple. It will be usually seen in early PD complication, basically because of the movement of fluid from the abdominal cavity towards the pleural cavity. It's usually common on the right side. Why is it due to? It's basically because of 2-3 reasons. First reason is increased intra-abdominal pressure, and second reason is either the congenital opening of the lymphatic channels, right? Or the tendinous insertion of the diaphragm is loose, then we can have this. And also another important reason is the negative intrathoracic pressure, which the negative intrathoracic pressure in the pleura and the positive intra-abdominal pressure, that is also a reason for this. So how do you manage this? So when the patient is symptomatic, you remove the fluid. How do you diagnose? You remove the fluid, look for the glucose level. If it is more than 200, usually you are looking at in this problem. And then how do you treat it? No, first of all they give rest. Give rest, right? Rest for 2 weeks, 3 weeks, because glucose itself is a sclerosing agent. And if it recurs after a month, and you may think of doing fluoridesis, but guidelines or the literature recommends VATS by doing VATS. But if VATS facility is not available, you can do sclerosing. You can fluoridesis by instilling sclerosing agents. Can anybody tell this? This is one of the rare complications I have not seen in my personal experience. Chylothorax, it is basically due to a lymphatic injury. It can happen. It's the erosion of the lymphatics or the injury to the lymphatics. Usually diagnosed by the clinical, like you can suspect and you can diagnose by the higher level of triglyceride, more than 200 milligram. This one, Professor Prasad was talking about this. Anybody? How do you exactly mention is? Yeah, very good. Encapsulated peritonitis, peritoneal sclerosis. What is this abdomen called as? Cocoon, right? So it was discussed before. So the another important complications are hyperglycemia, right? Every PD exchange, you are giving 15 grams, 20 grams, 25 grams, right? And 15 grams per 100 ml, almost like 150 to 200 grams of carbohydrates, right? This is similar to amount of carbohydrate what we eat daily. So it is very difficult to manage glucose. Sometimes in diabetic patients, we have to be very good in managing that using insulin, either intraperitoneally or subcutaneous, right? So another important area is weight gain. Although it is associated with improved survival, but if it is patient is obese, you can have a lot of catheter malfunctions. So not a major concern, but yes, we need to address this. Another important is peritoneal protein loss and malnutrition. So the daily loss is around 6 to 8 grams. How do you manage this? By increasing the protein intake and appropriate nutrition counseling. How do you manage the dyslipidemia? Anybody tell? Any 2 trials? The postgraduate SHARP trial and Imperial trial that does not that's not a positive trial. So electrolyte abnormalities, the most common electrolyte abnormality what you can get is hypokalemia, right? It can be there in around 10 to 30% of the patient. Because, can anybody tell the reason? Because any postgraduates? Because the PD fluid does not have potassium in it, right? So it's very, and also if it is precipitated by low dietary intake and GI losses or medications like diuretics can increase. So how do you manage it? You manage it by supplementation, and also you can give an potassium sparing diuretic if there is renal loss. Another important complication is hypermagnesemia. Are you aware of PD fluid containing magnesium? And this question, if you answer it correctly, you will get a gift. How much magnesium is there in PD fluid? Yes, 0.25, 0.5. It is available, right? 0.5 is normally, what is available is 0.5. So what we can arrange, but usually it is 0.5, but 0.25 is associated with hypermagnesemia, 0.75 is associated with hypermagnesemia. The importance of hypermagnesemia is it suppresses PTH. It can contribute to adynamic bone disease, which is common in PD patients than in HD patients. So hypermagnesemia. So all hypokalemia and hypomagnesemia can lead to increased mortality and hospitalization risk. So all the other complication because of increased intra-abdominal pressure is GERD and delayed gastric emptying, which can be treated with metoclopramide, but beware of tardive dyskinesia, and you can give cisabride. So another important thing is back pain because of the fluid and the lordotic this thing. So concluding, right? You are happy? So you want 2 more slides? So conclusion is you have to be vigilant, appropriate training. The most important is interest. So PD as a modality can make a patient laugh, which is impossible in nature. Right? The quality of life and laughing. See, the quality of life is somebody laughing, right? Coming to you and greeting you with hands, and they are smiling. That can be achieved only with PD. And so let's all take a very good approach in giving a comprehensive care, and it's a very actually one nicely thought of, like, although the BNP programs does not every place they cover peritoneal dialysis. I must thank Professor Kulal sir for organizing this meeting, and also for inviting me, and I'm thankful to be a part of a faculty alongside Professor Narayan Prasad. Thank you so much.
It was an excellent talk of your experiences as well as the non-infectious complications. In fact, I remember my first case report was a migratory CAPD catheter which migrated. It was published 20 years back in IGN. Just listening to it all. Excellent talk. I think you should ask the questions now in the next session for residents. It's an excellent platform for you. Please ask as many questions as possible.
I think we've had a very satisfying day, very hectic of course. I mean, we overshot the time quite considerably. But I think time has come where all good things come to an end, and today is no exception. I must thank everyone. We are actually cutting short the panel discussion. General Nula had to go somewhere, and I'm sure you will all agree the speakers have done a fantastic job. So if anything more needs to be done, it is the questions to be asked by the young nephrologists, the budding nephrologists. So I think please come out with this thing. Otherwise, I think there's actually been a lot of learning, and I would find myself quite satisfied to see all those things which we as a team had envisaged for today's program have actually come to a very fruitful conclusion today. So I just want to make some quick take-home points from what at least I learned or recapitulated heard my dear friends talk about the topics today allotted to them. Dr. Manoj Singhal did a fantastic job, and I think he's practically covered everything. We understood how to take care of the volume overload in a given patient, because we have been told that volume overload means a bad outcome for our patients. So try to look at the estimation of the dry weight and go all out to achieve the estimation dry weight in your patient. One thing which we didn't really touch upon, maybe for the paucity of time, was there are different solutions available. We did talk about Nephrology, Physiology, etc., but also the low calcium bags are available. So they help you manage your patient's mineral bone disease. You know, typically the calcium is 1.75 millimole, which is, as I said, the morning 3.5 milligrams or 7 milligrams per cent. But what we also have is availability of the low calcium bags. That's 1.25 calcium, which translates into 5 milligrams per cent of dialysate calcium, which will allow you to bring down the calcium, give these patients the benefit of vitamin D and so many things which you ordinarily will not have been able to use, especially if calcium becomes high. We also have, Vineet did an excellent job, and I think the concept, we in India were always for it. We always used to believe, even in the context of hemodialysis, we would always say, take pride in the fact that we try to strike a balance between what our patients can afford. So we always would believe that 3 or 4, 5 years of meaningful existence for a bread earner or an important member of the family would mean a lot, rather than talking about an ideal kind of dialysis which will be not manageable, not affordable by the family beyond 1 year, and you will end up losing these patients. So we have to strike a balance. We always used to believe that twice a week hemodialysis is good enough for majority of other patients. Only if they start becoming symptomatic, shift them on to thrice a week dialysis rather than always being bothered about KT over V and sort of having a complex that the Westerners are managing their patients in a much different manner. And look at where they are heading these days. When you stop bothering about cost totally, even developed countries are feeling the pinch now. The same holds true about peritoneal dialysis, and that was what Vineet very nicely alluded to. We talked about the concept of incremental dialysis, and look at that patient which we have repeatedly told you to do, sitting in front of you, to manage to give a comprehensive kind of PD prescription. It could be incremental and could actually, of course, Vineet talked about therapeutic inertia. I would probably feel that it's the way we make you as residents work. It's the totally opposite of what Vineet was referring to. जब आप आते हो बहुत ज़्यादा सत्कार मिलता है, बहुत पैम्पर करते हैं, आइए प्लीज़ क्या खाएंगे क्या नहीं खाएंगे, और आप कहते हो कि आपने तो सुना था कि ये नर्क है, तो ये तो हमें तो बड़ा पैम्पर किया जा रहा है. धीरे धीरे पता लगता है कि एक पहली नाइट ड्यूटी, फिर 2 दिन के बाद एक और नाइट ड्यूटी, फिर आप कहते हो ये तो नर्क है. तो हमने कहा था वो तो ट्रेलर था पहले, तो ट्रेलर के लिए. सो दिस इज व्हाट इंक्रीमेंटल डायलिसिस में भी ऑल अबाउट, कि आपको पहले थोड़ा सा काम दिया तो आपने एडजस्ट कर लिया, फिर आपको थोड़ा सा ज़्यादा दिया तो आपने और एडजस्ट कर लिया, रादर देन पहले दिन ही 4 एक्सचेंजेस करने के लिए करोगे, धुआं निकल जाएगा. आई थिंक प्रॉबेबली मे बी इंक्रीमेंटल डायलिसिस कुड बी having I'm sure Vineet you will agree that this is one stark contrast to say थोड़ा करके काम करवाओ और शायद उनकी capacity will make it easier for them to, and of course Narayan, I mean nothing could have been better, and I thank you so much for accepting our invitation to be here. I know how busy you are, but then it was a treat to listen to the ultrafiltration failures so well described by Narayan, and I think only those who actually manage a lot of PD patients will be able to tell you how best to manage your failure, because you don't want ultrafiltration failure in your patients. And of course it was a bit confusing because we are now with the oldies trying to adjust to the newer classification, but then again to recapitulate the ultrafiltration failure. One is typically because of the new angiogenesis or bombardment of your patient's peritoneum with high glucose. There is increased permeability and typically ultrafiltration failure. There is a role of RAS blockade here. You must avoid beta blockers. You must CNIs also have been shown to exaggerate this entity, but there is a role of RAS blockers, and you can certainly have the confidence of using RAS blockers in your patients once they are put on PD, because hyperkalemia may not be as relevant as it was. The type 2 now, I personally would want to look at aquaporin dysfunction. Dysfunction is the word, remember. It's not the deficiency. It's a dysfunction. People have tried, I don't want you to remember what I'm going to tell you, but people have tried high dose corticosteroids, a very high dose, the way we use typically the pulse doses. But that's anecdotal unless you have more data. So that's to overcome this thing. And of course, when it comes to encapsulating, I was talking to you this morning as well. Our longest survivor at 21 years, when he migrated to Canada, was finally found to have encapsulating peritoneal sclerosis, had to be shifted to hemo. He's still on hemo. It's been 22 years into dialysis as far as that is concerned, but then it's the longer. Typically you can time it 1 year, 3 years, 5 years, 8 years, 15. This is how it increases the incidence of EPS in your patients. And people have tried tamoxifen, people have tried steroid, people have tried MMF, people have tried azathioprine. So all these drugs can be tried, but then thankfully the way we used to say, and I often have been talking about, and I'm sure you have heard it before when I said that my MD thesis was beta-2 microglobulin. So I was itching to have a patient of proven beta-2 microglobulin amyloidosis. So you would say this is cruel. But then I was speaking from the other point of view. Beta-2 microglobulin related amyloidosis happen only once your patient has been on hemodialysis for longer than 7, 8, 9 years. So I would have loved to see that kind of entity in India, which would indirectly mean that yes, there has been survival beyond 7 or 8 years in India as well. And of course, the fourth, Dr. Miran Prasad talked about, you must as residents remember about the potential possible role of the therapy in that type 4, the lymphatic obstruction. So whole and a wonderful job by Anurag. I can't thank Anurag enough, and such a lovely gist of and beautiful slides of something the way we should all be managing peritonitis. And I think this is very, very important. Remember, we may encounter a lot of gram negative, but remember it is gram positive, and especially Staph albus, cons rather than Staph aureus, which is the commonest variety. And thankfully, it responds beautifully. The Staph albus epidermatitis variety responds to vancomycin. So you will have less of a problem if your patient ever gets peritonitis related to Staph albus. That's one. Of course, we've heard, and Rag also talked about the fact that even daptomycin, when we are dealing with VREs, vancomycin resistant enterococcus, so you have to either give them linezolid oral, or you can even try intraperitoneal daptomycin, so something which I came across only recently. IP, fluconazole can be given as well. So all those things which should be part and parcel of your learning as residents, and we've talked about extensively about the use of icodextrin. Few tips for the residents again about icodextrin usage. There are a few things which are synonymous with icodextrin. One is the entity called chemical peritonitis. It is not a true peritonitis. Thankfully, not seen very often these days. They have modified it. They have come out with a modified version of the original product. So we don't get to see too much of chemical peritonitis. But what is very important for all of you to remember is if your patient is using icodextrin, insist that they use the glucometer, the one-touch one, which has the glucose as the enzyme response to. Otherwise, it's a maltose base, and the AccuTrend, AccuCheck, other things they will pick up, and you will come across blood sugar levels as high as 500, while the actual sugar should have been just about 150, 100, and you give something like 30-40 units of insulin, and you are going to reduce hypoglycemia. So that's two. And third is something which I remember Deepak had pointed out this recently in one of our patients who was on icodextrin and had peritonitis, and we said the amylase is normal. So that was because of icodextrin, because it suppress the values of amylase. So these are 2 or 3 things which, and sodium sieving is very important. We somehow, my personal experience has been association of a significant degree of hyponatremia. That's controversial for some other time. So, and then finally, Muthu, Dr. Muthu did a fantastic job, and he practically covered all those things which you can actually encounter, not to scare you, to promote this therapy, but yes, no therapy is free of any kind of potential problems, and we know the incidence is very small. We do get to see a lot of, we have seen a few pleuroperitoneal communications. We see problems when there is a patent tunica vaginalis. We have successfully repaired these. We have done fluorodesis, and then there is another controversy whether you do fluorodesis, bats, or you go from the peritoneal side whereby they have something called, as he said, opening up the channels, the Bach-Dallek variety of hernias, abdominal hernias, the posterior side, and whether you want to operate from lower down or typically the cardiothoracic surgeon will go back here, or fluorodesis would be a little, I would say, more exaggerated response, I would say, to the given problem. But yes, the bleeding, you come across hemorrhagic PD fluent, it could be trauma induced, it could be catamenial, it could be menstruation induced. So you just have to have patience, confidence, do some few rapid exchanges, and it all clears off. And then of course, I think these are the few things which certainly come to mind, and I think I've become quite wiser from what I've been able to learn from my colleagues today. I'm sure you also probably found this an ineffable experience. I hope you are going to take back some learning, some good memories of the day spent here, and day well spent, hopefully. This thing. And before we end and proceed for dinner, I would one more time extend my sincere thanks to all those who have worked to make today's program prayer and success. May I call upon stage Kulwant, Deepak and Abhishek up on the stage. These are the people behind the success. I'm just a face being presented today in front of you, but they are the torch bearers. Please, all of you. So Rahul, please present. So and of course I'll be filling in my duty if we don't. Please, why don't you? I'll be filling in my duty if I don't thank Baxter for their wholehearted support. They are the ones who came up with this idea. Gaurav, Kubarpal, I'm forgetting the names of Rahul and his team. They have toiled very hard for making this successful program. So thank you very much for staying with us till quite late on a Sunday evening, and please join us for dinner now. Thank you once again, everyone, especially those who have come from outside Delhi and took time out. Thank you. And we will try to make it an ongoing program whereby, as I said in the morning, today was just the brass tacks. The next time we'll hope to take it to the next level, whereby very soon we don't just have any kind of qualms, any kind of unfounded fears about PD. We will next time hopefully talk about the next level PD. So till then, have safe days ahead. Thank you very much.
I just want to say one thing, that on behalf of all of you, I would like to thank Dr. Fuller and his team, entire team, for really putting a wonderful learning experience for all of us. In fact, in last so many meetings we have been talking about glomerular nephritis, transplantation and other aspects of kidney disease. But PD has somehow taken a back seat in discussions also. That may also be one of the contributing factors why we really require to give it a resuscitation bid. Yeah. So I'm sure this particular effort has really worked wonders for all of us. Yeah. Thank you very much.
Thank you very much. Very nice. Thank you. And Kumar, आप राहुल प्लीज आओ कभी ऐसे नहीं गौरव जल्दी आओ यार गगन आओ भाई जल्दी करो आपकी वेट हो रही है जल्दी एक मिनट बस रुको एक मिनट जल्दी ऊपर आ जाओ एक मिनट और ये एकदम Thank you very much. Wait.